Okay. Thank you for Chairman. My name is Haruya Yamane from Japan. 1 week ago, my son had a high fever and he was infected COVID-19. And 3 days ago, I was also diagnosed with COVID-19 infection. So my presentation may include cough or any noise. Please forgive me. But fortunately, I'm doing well, and I'm very glad to join this conference. Thanks for program members and online technology. Today, I will make a presentation about indication of non-surgical management for acute limb ischemia and introduce our novel technique. Just a moment, there's no COI. Acute limb ischemia, ALI, is a sudden decrease of limb perfusion that has a potential threat of life and limb viability. Thrombectomy using a Fogarty catheter is recognized as first-line treatment, but endovascular treatment, EVT, has recently developed as alternative to surgical revascularization for ALI. There are several conventional EVT procedures for ALI. However, their indication remains unclear. Before main topics start, etiology and severity of ALI are needed to understand. The etiology of ALI can be classified into several categories, but almost ALI was occurred 2 reasons. They are native vessel thrombolysis and embolization. Native vessel thrombolysis usually occur in the atherosclerotic plaque. Those patients often have risk factors such as hypertension, diabetes, dyslipidemia, or smoking. Embolism is often derived from intracardiac thrombus due to atrial fibrillation. And recently, debris from aortic ruptured plaque is also recognized as important cause of embolization. More than 70% ALI occur due to these 2 etiologies. Next, we explain about severity of ALI. Severity of ALI can be classified into 4 stages depending on the limb viability. Stage 1 means viable limb. In many cases, Doppler signal is audible and emergent revascularization is not required. Stage 2 means threatened limb viability. Emergent revascularization as soon as possible is needed for limb salvage. Stage 2 is divided into 2 categories. Stage 2B shows more severe condition. Sensory loss or muscle weakness are important signs of stage 2B. Stage 3 means irreversible limb damage. In this stage, complete limb salvage will not be achieved. In short, only stage 2 needs emergent revascularization for limb salvage. For revascularization of ALI, surgical procedure is being performed traditionally. Even now, it is recognized as a first-line treatment. Thrombectomy using a Fogarty catheter like that was a game changer for ALI treatment. Especially, it is extremely effective for the patient with ALI due to embolization. These patients do not have atherosclerotic change lesions So Fogarty catheter can pass the lesion easily and remove embolic material like this image. As you can see, large thrombus could be removed. However, it can cause some complications such as vessel dissection and distal embolization of below the knee artery. In addition, it cannot be performed by only cardiologists. It generally needs surgeon's help. So we start to explain conventional non-surgical treatment for LI. First, percutaneous aspiration thrombectomy, PAT. PAT is a simple suction of embolized material by 6 to 8 French catheter. Of course, the catheter can aspirate the material smaller than its size, so the recanalization by PT alone is not frequently successful. PAT is recommended for small vessels, such as below the knee arteries, like this image. Thrombus in BTK artery is often small, so PAT can be effective. Next, catheter-directed thrombolysis, CDT. CDT is also considered as a first-line treatment for LI, according to the current guideline. As the figure shows, CDT uses a march-hole catheter. It is inserted into thrombus directly, and thrombolytic drugs is infused through the catheter. CDT can lead to similar clinical outcome compared to surgical treatment, and several clinical trials demonstrated them. However, CDT has an important disadvantage. CDT needs long time to revascularize. Therefore, for the patient who need emergent revascularization, it should be avoided as initial therapy. CDT should be used in stage 1 patient. Angioplasty and stent implantation is a well-established strategy in chronic artery disease. For LI, the effectiveness of angioplasty is limited, but it is mandatory procedure for underlying atherosclerotic lesion. Stent implantation is widely applicable and useful for LI patient in any stage and any etiologies. However, we should be careful not to deploy it in the non-stenting zone, such as common femoral artery or popliteal artery, because non-stenting zone is located in the medial joint. It easily leads to stent fracture by the joint movement. By the way, in Japan, many disasters frequently occur due to earthquake and or typhoon. Of course, landslides also frequently occurs, as you can see in this picture. In such a case, sometimes we make another route to pass it, such as bypass or tunnel. After making another route, landslide is removed. Finally, another route is also removed. We apply this method to our novel technique for LI. This technique is based on the distal perfusion concept and uses a guide extension catheter named temporary and luminal bypass technique, TEB technique. The steps on this technique are very simple. First, we evaluate the lesion length. The second, We deliver a guided extension catheter through the occluded lesion. Third, we confirm the contrast flow to the distal arteries. And finally, we administer a thrombolytic drug. Guided extension catheter is used as tunnel. Now I will show a representative case. The patient is an 83-year-old female and she complained of pain and coldness in her left leg. She had some risk factors and she did not have a notable past history. She had some risk factors such as hypertension and past smoking. And she has nothing in particular past history except for the hypertension and past smoking. ABI in her left leg was unmeasurable, and ultrasonography showed occlusion in her left popliteal artery. The Doppler was inaudible in her left leg, and her sensory function was slightly injured. We diagnosed her with grade 2B ALI, and the angiography was performed. We can see the mild atherosclerotic change in the open vessel. It demonstrates the occlusion from distal SFA to popliteal artery, like this image. Besides, below the knee artery couldn't be visualized at all. The wire could pass the lesion easily. After that, we evaluated the lesion by intravascular ultrasonography. This figure shows the schema of IVAS findings. IVAS means intravascular ultrasonography. The red line shows the healthy vessel, and the black line shows the occluded lesion. First, we performed aspiration and balloon dilation, but they couldn't revascularize. We thought that thrombectomy is not applicable because because the lesion advanced to the BTK lesion, and the surgeon in our hospital is under surgery. Stent implantation wouldn't be applicable because popliteal artery is in the non-stenting zone. So we decided to perform TEV technique. IVAS showed that lesion length was over 30 centimeters. So we selected the Guidozilla 2, which is a guided extension catheter with 40 centimeter lumen length. We delivered the guided extension catheter to cover the lesion fully like that. These are the angiogram after TEV technique. A lot of thrombus was observed in the popliteal artery. However, we could see the contrast flow to the distal arteries through a guided extension catheter. This movie, the second movie, shows the important feature of this technique. The contrast reaches below the knee artery at first, and after that, popliteal artery is visualized. It makes possible to prevent a limb ischemia and buy time to reduce the thrombus. After that, we started administer the brokinase, which is a thrombolytic drug from the CIS directory. This is a clinical course of angiography. The angiogram showed a reduction of the thrombus gradually. On POD2, the guided extension catheter was removed. A little thrombus can be observed, but the result was acceptable. The blood flow of the BTK arteries were also improved gradually. On POD2, the angiogram showed an acceptable patency, especially ATA gain a good flow. This figure shows timeline of medication. We administered Rokinase at the dose of 240,000 units and heparin at the dose of 10,000 units on POD 0. We stopped Rokinase on POD 1. On the other hand, we continued the anticoagulant therapy with heparin until drug administration was started. Finally, she was discharged without any complications or interventions. TB technique is based on the concept of a distal perfusion. While maintaining the blood flow to the distal part, thrombolysis therapy is conducted. This technique has an advantage of revascularization without deploying any device in the lesion. There are 3 chips in this technique. First, the lesion length should be measured. The guided extension catheter, which has enough length to cover the lesion, should be selected. Guideline PV has 25 centimeter lumen length. Guidogera 2 PV has 40 centimeter lumen length. We can choose 2 types of them, depending on the lesion length in Japan. Second, the proximal edge of the guided action catheter must be separated from the distal chip of the cyst. Generally, the space shouldn't be made when the intervention is performed. But in this technique, the space is needed to deliver to the blood flow to the distal arteries. Third, the blood flow of the distal artery to the distal arteries should be confirmed. When it is not obtained, we should change the position of the catheter to more distal or change to another tibial artery. This is a summarized table about non-surgical management according to the occluded lesion and LI stage. PAT is effective for the small vessels, such as BTK arteries. CDT is recommended for the patient with stage 1 ALI. Angioplasty is available for any lesion, stage, and etiology. But we need to understand the effectiveness is limited. Stent implantation is often effective and it has high success rate, but we shouldn't not deploy them in the non-stenting zone such as CFA or popliteal artery. Our novel procedure, TB technique, is available for any lesion and any etiology. Of course, TB technique is not first-line therapy. First, we should try conventional treatment. But if they do not work, TB technique can be an option for non-surgical treatment for ALI. This is the conclusion. Thank you for your attention.
Hello, thank you for your presentation, Dr. Hemane.
Can you hear my presentation?
Yes,
I
yes.
see the chat is there's something problem.
Okay, then any questions to Dr. Hemane? Okay, thank you. You can drop your mail ID in the chat box, Dr. Haria Hemane. If anyone is having any queries, they can contact you through mail.
Holy crap, is not clear here, voice obstructions.
Hello? Can you not able to hear me properly? Hello?
Sorry. Is there any questions in the chat box, right?
Yes.
I cannot.
No. There is no questions in the chat box.
Yeah.
You just enter your email ID. So if
Email ID. Okay.
If anyone is having any queries, they can contact you through mail.
Okay, I will write.
Okay, now we are moving to the second presentation. I would like to welcome Dr. Masataka Kitono from Okinawa Prefectural Nanbu Medical Center and Children's Medical Center, Japan. Dr. Masataka, no? You can now unmute. Hello, Dr. Masataka.
Sorry.
Oh, okay. Now we can able to.
Okay.
Yes, doctor. Now we have made you as a host. You can share your screen and start your presentation.
Yes. Oh, I'll start my presentation.
Okay, thank you, doctor.
Undersized device can be cause of device stabilization. The risk factors of device stabilization include division of blood filtering, especially absent aortic rim and anatomic rim. You can see a case with absent aortic rim after contractile septal lunar placement. When discs are closed shape behind the device migration risk becomes high. On the other hand, the risk factors of the rock include absent aortic rim, alveolar rim, the pressure of disc edge to the conservative wall with the device motion, and fracture territorial and aortic walls such as steroid user. I present an absent aortic rim and alveolar rim case developing cardiac pneumonia 4 days later after fibula flex 2 placement. Immediately after placement, the shape of the two discs on the lateral side looks flared as the RA disc is not straddling the valsalva but strongly pressing the wall perpendicularly. I think the strong pressure caused the erosion. In case after placement of contractile septal occlusion, the shape of the two discs can change over time because it often restores its shape. In this case, the two discs shape was cleared and straddling the valsalva immediately after placement. But the shape changed like a trap flow 2 months later. Therefore, it's known the edge became strongly pressing the valsalva wall, causing the aortic RA fistula. For avoiding these serious complications, we have treated AC patients with an absent or malaligned aortic or superior rim using a fibula flex 2 shaped flared and straddling behind the aorta at the hospital. However, it's not clear if this method focusing on the device shape and the change. I'll show the method. Study population. 165 SD patients treated with Igaflex 2 at the hospital from February 2020 to April 2019. We tried to treat 47 patients with an absent or extremely deep shaft, which are defined as less than 1 millimeter, aortic or superior rim, with or without monoline. Igaflex 2 read and struggling behind the aorta. The object of the study is the 47 patients with age 6 to 73 years, weight 70 to 76 kilograms, and 31 female. Concerning device size selection to make a clear and strategic, we select the Igaflex 2 device with a waist diameter 4 to 6 millimeter larger than the balloon sizing diameter measured by Stokelo technique. We prefer a 4 millimeter larger device in tension weight around 20 kilograms and 6 millimeter larger device in tension with weight more than 30 kilograms. But especially in small children with a small atrial range, like the figures, we select the device. The length of the device size plus LA disc rim length is not beyond the length of atrial length plus 2 millimeter, avoiding excessive atrial stretch, which may develop conduction disorder. It's expected this selection will make the device layered and structured shape behind the valsalva. We collected these TEE data before placement, immediately after placement, and 6 months after placement. Concerning device shape, that's the chart showing. We collected waist diameter, device thickness at the center, valsalva side, and outside side, and inter-edge distance, which we define as IED, but this is when the device came nearest to the valsalva, but farthest from it. We studied the following: successful procedural rate, which we defined when the device was not retrieved until the next day after placement. Effective closure rate, defined when residual leakage was not small. Onset and outcome of every serious complication during the period of a mean 50 months. Changing device shape and rear index over 6 months. Rear index was defined as inter-edge distance minus device center thickness. Relationship between device size minus balloon size diameter and rear index at the nearest spaces immediately and 6 months after placement. Concerning valsalva wall deformation, press by the discs. We summarize what part of the disc press the valsalva wall, how deformed it became immediately and 6 months after placement. Baseline patient's characteristics and TE findings before placement. The mean maximum AC diameter is 17.7 millimeter. The mean device size is 24.3 millimeter, which is around 4 millimeter larger than the mean balloon sizing diameter. Many patients have not only absent or extremely deficient output, but also deficient superiorly. For 47 patients, absent of green is recognized in overall that is 64%, and non-green is 38%. Was not recognized by one year of the president. Instead, in addition, no change has occurred 3 months after the president. The table displays the pattern of complications during the observation. There are no serious complications. In one patient, we recognize the clear correlation of 220 milliseconds immediately after placement, which was continuous to recover 3 months later. In an 8-year-old boy having a maximum 25 millimeter HD with absent aortic artery, slight dysfunction in junction ring, occurred immediately after 30 millimeter device placement. Downside of the device, 27 millimeter, maintained silently thereafter. In another picture, we recognize a femoral anterior venous fistula that continuously closed up by the 2-year follow-up time. The table shows about device shape and its change from immediately after placement to 6 months later, guided by the advices when the device came nearest to the person and farthest from it. During 6 months, the base decreased by 1.5 millimeter. The device's thickness are center, lateral side, and opposite side significantly decreased by around 3.5 millimeter over time. The IED did not change for 6 months. Therefore, the flare index became larger over time. This figure shows the relationship between device size minus ballon size diameter and flare index as the nearest phase at 6 months after placement. The two have a positive correlation, indicating that larger a selected device size but at the ballon size diameter, the more clear the device shapes behind the structure is later. I show cases concerning basal wall pressure by the devices. In upper images case,
कंबल कर अच्छा देना अपना इस बेला जेली लरिसा मेंट्रो लोरा वेल
here are surrounding shape behind the basal, and already this inner plane is right facing the basal. 6 months later, the shape becomes more clear and we can see any pressure on the basal wall. In the lower images case, is an undersized device. The clear shape, but the already edge is rightly facing the basal wall because the two pieces didn't surround basal enough. 6 months later, similarly, the already sketch faces the basal. It was discovered later on the ratio of the basal side diameter to the AC diameter was larger have upside the device millimeter until being surrounding. The table summarizes the basal wall deformation raised by the discs is usually the point of impact and effect of deformation. We recognize the deformation in 13 of the 47 patients immediately after placement and in 28 of 44 patients at 6 months after placement. Although the deformation was mostly due to pressure by either this inner plane, it was due to pressure by the right lateral disc cage in patients at 6 months after placement. We could have avoided the pressure if the devices had been upsized without conduction disorder. Discussion. From the Dartmouth study, Infraflex 2 keeps the flared and structured over the study. Usually, this edge doesn't press the basal wall in its shape. Therefore, we believe that can avoid erosion as well as device stabilization. Comparing umbilical septal occluder with Infraflex 2 in device shape and change over time. In umbilical septal occluder, two disc edges direct toward each other, and this can become from flared shape behind Valsalva to closed shape over time. On the other hand, in Infraflex 2, the area disc edge directs outward and the area disc changes shape flexibly. Therefore, the disc keep flared and sliding shape over time. Actual type of cases having device stabilization or erosion. This case has naturally malaligned absent of sleep, but also large valsalva sizes compared to the HB. We make a flared and striding shape. In this case, if we select a device more than 8 millimeters larger than the balloon size diameter, we can make a striding shape because the device becomes not only flared shape but also balloon shape. 6 months later, the center of the device becomes the discs become more flared shape, keeping sliding the aorta. Like this case, it's important to upsize the device until being sliding the aorta. In patients, the small size coupled with single-center nature makes it not extremely hard-edged. Conclusion. For a HD patient with absent or malaligned optic rim, HD closure using a figure flex 2 shape flared and struggling behind the aorta currently are effective and safe for mid-time OR, although with care of conduction disorder. If you have any questions, please email the following address. Thanks for your attention.
Okay. Thank you, Dr. Masataka Kitano.
Thank you.
That was an excellent presentation. Hope the participants learn and they gain knowledge by sharing your research work.
Sorry.
I hope that was an excellent presentation and the participants have learned and benefited by sharing your research work. Thank you. Thank you so much, Doctor.
Thank you. Thank you.
Now I call upon Dr. Ismail from University College Hospital in Nigeria. He will moderate further sessions. Doctor, can you hear me? Dr. Ismail?
Good morning, everyone.
Yeah, good morning, Doctor.
Good morning, everyone. I'm Dr. Adroba Aziz from University College Hospital, Ibadan. I'll be taking over as the moderator of this program. I hope people have been enjoying this program from the beginning. So I would like to call on the next speaker, Dr. Daniel Feng from Tungbin Medical College of Wuzhou, University of Science and Technology, China, to do his presentation. So you are welcome, Dr. Daniel Feng.
Okay. Good morning, ladies and gentlemen. Good morning, ladies and gentlemen. It's a pleasure to be here with you today. First, I'd like to introduce myself. I'm Danny Feng from Wuhan, China. I'm a graduate student from Tungbin Medical College of Huazhong University of Science and Technology. In the master stage, my research direction is mainly the attitude and behavior intention of patients with aortic dissection on exercise-based rehabilitation. Based on this theme, I first carried out a study to understand the impact of exercise-based rehabilitation on patients with aortic dissection and wrote a scoping review. Now I will describe it in detail in the last oral report. My presentation includes 4 parts. To begin with, I will explain the background to do this research. Then I will describe my research methods in detail. Last of all, I will summarize my presentation, which is about the research results and the discussion. Now, let me introduce the background. As we all know, aortic dissection is a pathologic change that the blood in the aortic cavity enters the aortic media from the aortic intima tier and expands along the long axis of the water, resulting in the separation of the true and false aortic cavities. Is a series of with the characteristics of sudden onset, rapid progress, and high mortality. In recent years, the survival rate of AD has improved. However, the quality of life of AD patients is not ideal. Their exhaustion and lower function are decreased. Also, the growing number of survivors is usually younger. They have doubts about lifestyle, return to normal physical activity, and even exercise. Therefore, too many physical restrictions will have a huge impact on their daily life. Cardiac rehabilitation as a comprehensive and coordinated long-term plan, including medical evaluation, access cardiac rehabilitation, physiological prescription, patient health education and consultation, nutrition prescription. The exercise-based cardiac rehabilitation ECR is now core. ECR can low blood pressure, delay the development of atherosclerosis, reduce the occurrence of cardiac events, control risk factors, promote mental health, improve the quality of life, and improve the prognosis. Nevertheless, the recommendation for type and intensity of ECR for patients with AD still represent a dilemma. Therefore, our group conducted a scoping review of the literature on AD exercise rehabilitation. The key aims of this scoping review were to provide evidence for ECR so as to better improve the prognosis of patients and improve the quality of life after discharge. Let's take a look at the research methods. We use 5 frameworks. Step 1, identify the research question. 1, what are the measurement indexes of ECR for AD? 2, what are the support types of ECR for AD? 3, what is the safety and the effectiveness of ECR for AD? Step 2, identify relevant studies. Research Department IBOS, Medline Web of Science, Clock Library, Wanfang Chinese Database, Zhiwang Chinese Database, and Clinical Trials Registry. This is the process of searching on PubMed. The keywords are aortic dissection and access rehabilitation. Step 3, study selection. The inclusion criteria are research in articles that include patients with AD, studies that carried on the ECR, studies that included corresponding observation indexes, and published in English or Chinese, and included trials registry in Clinical Trials Registry. Publication date and research type were no restriction. The inclusion criteria are intervention content such as therapeutic measures unable to get full test article. Studies were reviews or mental analysis. Studies were repetitive. All relevant papers published up to February 2021 were retrieved. Step 4, sorting the data. The following data were extracted and classified. Each individual study first author, year, and country of publication, study type, time, and location for taking ECR, measure evaluation indexes, may types, study purpose, the progress of ECR, summary of results, and main conclusions. Step 5, collecting, summarizing, and reporting the results. A total of 1,684 records were found by searching and the database and the clinical trial registry. 138 duplicated records were deleted, and 11 records made the inclusion criteria according to the screening process. The screening process is showing in the right figure. Later, I will introduce the research results from the following aspects. 1, describe the articles. We summarize the characteristics of the articles, including case study, cohort, randomized controlled trial. The picture on the left shows the country of publication of the article. The figure on the right shows the year of publication of the article. 2, evaluation indexes of ECR. The evaluation of indexes of patients with AD after participating in ECR could be divided into 4 parts. including indicators reflecting cardiopulmonary function, reflecting adverse events, reflecting hospital cleaning costs, and reflecting psychosocial function. Main types of ECR. The main types of ECR for patients with AD, including early activities, aerobic exercise, resistance exercise, flexibility exercise, and coordinated exercise. For summary of studies included in this review, the study showed light results of ECR for patients with AD, which were described from 3 aspects, including the purpose of study, the effectiveness of ECR, and the safety of exercise. We also found 2 studies from the Chinese clinical trial registry, although the research has not yet been complicated. The purpose of is also to evaluate the effectiveness and the safety of early basket trialing, as well as early rehabilitation. The intervention contents of rehabilitation include early mobilization, cycling, cardiopulmonary rehabilitation by psychosocial therapists. The last part is the discussion and conclusion. I will cover the discussion part in 5 parts. Only 11 eligible studies were included in this scoping review. The publication time of these articles were relatively new. Randomized control trials were few. However, we also found that the recent literatures on this topic are gradually increasing, and the clinical trial registry center has also carried out correlative research on this aspect, which shows that the ECR of patients with AD is more and more concerned by the medical community, and is a topic worthy of study. Implementation of observation indexes. This scoping review divided the evaluation indexes of ECR into the following aspects: adverse events, indicators reflecting cardiopulmonary function, psychosocial function. The 3 parts is multiply outcome criterion score standard. 4 in hospital cleaning costs. However, there is still a lack of systematic management indexes for the rehabilitation of AD. This exhibit leads to be future studies by research in the future. Standards clinical exercise rehabilitation pathway. The types of exercise include aerobic exercise, independence exercise, flexibility exercise, and coordination exercise. Special support that patients in AD can maintain normal physical and sexual activities, including lifting weights to 50% of body weight, as well as daily activities. So then recommend patients perform mild, moderate activities and avoid heavy daily activity. Channel encourage patients with AD to take moderate intensive aerobic exercise for is not more than 30 minutes and at least 150 minutes per week. CPET is a method of objectively and quantitatively assessing respiratory reform. And due to the particularity of AD group having the characteristics of sudden onset, repeated progress, and high mortality, for those older patients with underlying disease, even if they are screened comprehensively before trialing, it's still possible that possibly complications occur. So we should take the 4 parts. So finally, I will introduce the conclusion. This review has proven the safety and effectiveness of ECR for patients with AD. Our results should promote future research in 3 aspects. 1, systematic evaluation indicators and standards clinical exercise rehabilitation pathway. 2, more randomized control trials. 3, more assessment methods such as CPET. This is the reference. This is all my presentation. Thank you for your attention.
That was an excellent presentation from Ms. Daniel Feng. Do we have any questions, any comments? Ms. Daniel Feng, you can leave your email for further queries if people have something to communicate with you. I hope the participants have learned and benefited by sharing your work. Any questions for Ms. Danny Feng? Any additional comments? At this juncture, I'd like to call the next speaker, Dr. Mukesh Pasania from Calcutta National Medical College, India, to do his presentation.
One minute.
Dr. Pasania, you are welcome.
Welcome. Thank you. Screen there is. Good afternoon, everyone. Are you listening me? Hello? Hello? Hello?
Yes, doctor, we can hear you. You can start your presentation.
Okay, thank you. Good afternoon, everyone. This is my topic, basically my study in India. Hello?
Continue with your presentation.
Okay, okay, sir. So distal radius for routine
clearly.
concentration, county angiography. Hello? Hello?
You can do your
Hello, good
presentation.
afternoon, everyone. Okay, okay. This is my topic, basically distal radius for routine concentration, county angiography, safety and feasibility study. Study background. The PCI are the important tools for the diagnosis and treatment of CAD. Although conventional transfemoral and proximal radial approach mostly chosen, but there is a paradigm shift towards the distal radial approach with the improvement in technology and equipments. Moreover, both transfemoral and proximal radial access sites have peripheral complications with respect to bleeding and radial artery occlusion respectively. The distal radial access artery has advantage over two in the terms patient comfort and almost nil peripheral complications, including radial artery occlusion and preservation of the proximal radial artery as per for future procedures like chronic hemodialysis or bypass graft. So this is the anatomy. You can see here lateral view, palmar view, and dorsal view. This is the branch, dorsal carpal branch of the radial artery. Basically, we puncture here. This is also anatomy. You can see here anatomical snub box. This is the dorsal branch. In between tendons of extensor pollicis longus and tendons of abductor pollicis longus. Basically, this is situated on the base of the thumb. So lastly, basically, first study was published in 2017 in intervention by Dr. Kaimanich. The first distal radial artery approach data. They have taken basically 70 patients. The first study was published on distal radial approach, basically by Dr. Kaimanich. They have taken basically 70 patients. You can see here.
Dr. Mukesh, kindly unmute and do your presentation.
So this study was generated and determined the safety and feasibility and advantage of the distal radial artery as routine access site for the percutaneous coronary intervention. The first study from Eastern India to best of knowledge addressing the novel technique. Our study was a retrospective single center observational study. Basically, we have taken 70 patients who were controlled for CAG and PCI from March 2019 to August 2019. The most important inclusion criteria we have taken in presence of the pulse in the snub box on examination by the interventional physician. All patients undergone Allen test. The pre-procedural exclusion criteria, basically absence of the pulse, severe forearm artery malformations, shock and primary PTCA, history of previous CABG and radial artery use. These are the baseline characteristics of patients. Majority of males, 72% males, smoking, risk factor. These are the baseline characteristics. The study technique, informed consent taken, basically every patient and patient were positioned comfortably supine on the angiography table with right upper arm, while positions comfortable next to sideboard, basically in right side. Or in the left side, left arm was naturally placed over the patient's abdomen, and hand was positioned over the right bone as described by Kaimanich. After supplementary injection of 2 ml lidocaine over a 5 ml needle, Salvage techniques we have used in the anatomical snap box. The radial artery puncture was performed with 20 gauge needle and 6 trench sheath we have used routinely in all cases. The vascular hemostasis, we have used a small rolled up sterile gauze piece was placed over puncture site and compressed tightly, manually followed by with a semi-elastic bandage, approximately for at least 2 hours, without including the thumb. These are the procedure characteristics of the study. Majority of single cell study, single cell disease. Out of 70 patients, assess was taken successfully in 67 patients, with failure only in 3 patients, requiring crossover to conventional radial artery approach. The mean hospitalization duration was 2 days, and the mean X-ray exposure was to 3.23 plus minus 1.68 minutes in CAG group, and basically in plastic to 12.5 plus minus 6.2 minutes. The data collections. Basically, we have taken the success of the taking, assess number of the puncture attempts, assess time, total procedure time, post-operative complications like major, minor bleed, hematoma, vasospasm, AV fistula, radial artery occlusion, and hand movement disability. All data we have collected. Our study results and outcomes, you can see here in the primary endpoints, CAG success rate was there 94%, PCA success was 98%. Secondary endpoints, puncture success 94%. Only 3 patients we have gone by femoral. The crossover rate was 6%, left radial 49%, right radial 51%. Procedure variables, puncture time near about 1.9 minutes, procedure time in CAG 15 and PCA 40 minutes. Assess site complications, bleeding none, artery occlusion none, perforation none, pseudoembolism none, dissection none, AV fistula none. So basically no patient developed local hematoma after the procedure, no major bleed, no AV fistula, no RA occlusion. No patient complained of dysfunction of hand or arm. The patients were followed up for next 1 month for the further complications. For key findings, the coronary intervention through the distal radial artery in the snub box is safe and feasible, especially in the right distal radial artery. The VAS score is low and the hemostasis time is also short. So using minimal sources, the success rate of the distal as high as 94%. The number of the minimizing the risk of peripheral nerve injury, AV fistula, and thrombosis. No major complications were reported. The patient tolerated well. So, our conclusion of the study: the cardiac catheterization through the distal radial artery is safe and feasible. The right distal radial artery access can be routinely carried out. Our study was published in Singapore Journal of Cardiology. So, last 30 years on, the real question: why the interventional cardiologists have not converted to a high proportion of the radial first practice? Because the benefits of the patients has been clear. Thank you.
Thank you, Dr. Mukesh. That was an excellent
you.
presentation. Hope the participants have learned and benefited by sharing your views or the research work. Thank you so much, Doctor. If there is any questions, you can ask Dr. Mukesh now.
Any question regarding distal radial artery approach?
Thank you, Doctor. So
Okay,
you
thank
can
you.
drop your email ID in the chat box. And if there is any questions, the speakers and the delegates will contact you through email. Thank you, Doctor.
Okay, thank you. Okay, thank you.
The next presentation will be Dr. Motara Gotari from QOM University of Medical Sciences, Iran. Hello, Doctor.
Hello.
Hello, Doctor. So you can start your presentation now. I'll make you as a host so that you can share your slides now.
You can see, okay. My slide. Okay. Can you see my slide?
Yes, Doctor, we can see your slides.
Okay. Good morning, everyone. Thank you to the organizer and to providing an opportunity for presenting my paper at this conference. As the coronavirus disease 2019 pandemic has spread around the world, there has been a growing recognition that persons with underlying increased cardiovascular risk may be proportion effect. COVID-19 is approximately 18% similar to SARS, and the causative agent of COVID-19 attack host cells by binding to the angiotensin converting enzyme to receptor. ACE2 is a membrane-bound monocarboxy peptidase organized ubiquitously in a human and represented predominantly in the heart, intestine, kidney, immune system, and pulmonary alveolar cells. Respiratory failure from acute respiratory disease syndrome is the leading reason for mortality in COVID-19 infection patients, and initial prospective analysis in Wuhan relieved bilateral lung opacity and for TO of 41. Chest CT in infected patient and described lobular and sub-segmental region of consolidation as the most typical detection. Other investigators examined chest CT in 21 infected patients and found a high rate of ground glass opacities and consolidation, sometimes with around morphology and peripheral lung distribution. Accumulating evidence offers that a subgroup of patients with severe COVID-19 might have a cytokine storm syndrome, secondary hemophagocytic histocytosis is an under-recognized hyperinflammatory syndrome characterized by a fulminant and fatal hypercytokinemia with multi-organ failure. Main features of HLM include unremitting fever, cytopenias, and hyperferritemia. Pulmonary involvement occurs in approximately 50% of patients. At this moment, significant lymphopenia is revealed. At the time of admission, the majority of patients demonstrate lymphocytopenia, thrombocytopenia, and leukopenia. It represented a significant association between lymphopenia and acute respiratory distress syndrome. The enhanced risk of ARDS was significantly associated with a rise in neutrophil and decrease in lymphocytes. PPP creates an inflammatory response in the whole body. The most severe form of this reaction, a range of lesions may occur, including dysfunction of the lung, kidney, intestine, brain, myocardium, coagulation, and hemolysis disorder. Increased susceptibility to infection and leukocytosis. This syndrome is called SIRS after virus. Factors such as non-pulsatile fellow, shale storage, cardiac infarction, ischemia, and hyperfusion, hypothermia, related anemia, and anticoagulation play an important role in stimulating tissue damage and inflammatory response. This response may keep after the obesity for a long time, and depending on the severity of the inflammatory response, it may have a wide range of adverse clinical consequences. Pulmonary function is impaired in patients after CPP, ranging from microscopic atelectasis to acute respiratory distress syndrome, and therefore oxygenation and mechanical ventilation in patients in China. Several functions include atelectasis, pleural opening, pulmonary glycans disorder, and systemic inflammatory response. A significant proportion of deaths after heart surgery are from acute lung injury. Anaphylaxis and complement activation of neutrophil, cytokines, arsenic acid metabolites, and impaired pulmonary metabolism are some of the causes of ALA. Activated neutrophils migrate to the inflammatory and ischemic area during CPP and release proteolytic enzyme and cytotoxin, which directly damage the lung and increase pulmonary permeability. Finally, it's associated with pulmonary insufficiency after CPP. A 53-year-old man with a history of hypertension, smoking, alcoholism, right bundle branch block, chronic kidney disease, thyroid nodules, gallstone without stenosis, HPC, fatty liver, and myocardial infarction. He was admitted to the hospital for further investigation suspicious SARS-CoV-2 infection at April 22. The result of PCR test was positive. Combination therapy was started with multiple medications such as azithromycin, corticosteroid, hydroxyzine therapy by infectious disease specialists. After his symptoms were relieved, he discharged from the hospital. 2 weeks later, he was admitted to the emergency department with chest pain and dyspnea. In the emergency department, transthoracic echocardiography and angiography were performed, and obstruction on coronary vessels, such as left main, LAD, diagonal 1 and 2, and PDA as a result for chest pain and dyspnea were recognized. He had an ejection fraction of 50% and mild mitral recognition. According to the thrombosis in myocardial infarction score of 6, the maximum waiting time score of 8, frequent chest pain, the rate of troponin, EKG changing, arrhythmia, atrial fibrillation, premature atrial contraction, and hypertension resolved to emergency cardiac surgery on 24 to 48 hours maximum. Based on history of SARS-CoV-2 infection, PCR test was performed and the test result was negative. Otherwise, chest CT revealed bilateral ground glass. Before the surgery, of course. In this slide, you can see preoperative tests, include troponin 0.78 milligram per liter, CKMB 30, and ESR 59 millimeter per hour. At end of CPB, the patient experienced a drop to saturation. The conduction of the airway was investigated for the location of the tracheal tube, the lack of one-line trachea, the polarity ventilation of both lung and atelectasia. The suction of lung secretion was performed. The ventilator was readjusted and the positive expiratory pressure or PEEP 10 was set. Salbutamol was sprayed into the tracheal tube, with the exception of the above treatment approaches. The pulse oximetry device indicate 90%. In ABG-PO2, 115 millimeter Hg, and saturation 98% was observed. Evaluating the amount of urine during the CPB less than 0.5 cc per kilogram an hour. A history of CKD represented a reduction in GFR. On the first day of admission, the total amount of chest tube drainage was 1,000 cc in 6 hours. According to the hemodynamic status and the opinion of the surgeon and anesthesiologist, the patient remained intubated until the clinical condition stability for 24 hours. On the second day, this reduced drainage and improvement of respiratory status extubated. The mask with the reservoir bag was placed on the patient's mouth with the oxygen flow of 10 to 12 liters per minute. Based on initial monitoring and ABG in ICU, evidence of a reduction in PO2 and pulmonary dysfunction is represented. Modification of ventilator setting were adjusted by the anesthesiologist. ABG showed pulmonary dysfunction. Pulmonary consultation, PCR test, and chest CT were performed. The PCR test was negative. However, chest CT illustrated the conversion of the ground glass phase to the consolidation phase in previously complex pulmonary areas and exacerbation of the lesion. Cardiology, anesthesia, and infection consulting were excused for the patient, and eventually the infection disease specialist diagnosed pneumonia. He was confused after extubation and recovered consciousness after 3 days. On the third day, an assessment of fluid intake and urine in the first 24 hours showed sign of oliguria and rise protein and BUN. Nephrology consultation was also performed to examine the kidney. Furosemide 5 milligram per minute infused was performed. On the fourth day, platelet count started to decrease and on 5 days it was below 18. Urgent hematology consultation was requested, and the other reasons for thrombocytopenia were investigated. He had hemoptysis and vomiting. Ultimately, the patient was transferred to the cardiac care unit after 6 days. An acute respiratory syndrome is the most significant disorder in all patients with COVID-19, which can have more destructive effects on 17 to 99% of COVID-19 patients. 75% of patients had bilateral pneumonia and 14% had bilateral ground glass aside. This pattern of ground glass and consolidative pulmonary opacity, often with a bilateral and peripheral lung distribution, it emerged as a chest CT hallmark of COVID-19 infection. Also, X-ray images show rapid progression of pneumonia and some difference between the left and right lung. Chest CT is a vital compound in the diagnostic algorithm for patients with suspect COVID-19 infection. Indeed, given the limited number of PCR kits in some centers and the possibility of false negative PCR result, the National Health Commission of the Islamic Republic of Iran has encouraged diagnosis based on clinical and chest CT finding alone. Acute respiratory infection may result in activation of coagulation pathway, pro-inflammatory effects, and endothelial cell dysfunction. COVID-19 patient portend severe levels of cytokine storm and systemic inflammatory response syndrome. Initial of CPB ischemia and perfusion leads to complement activation. And site activation. Night in the toxin and the time is a short time before the termination. In the conclusion, the author believes hyperinflammation and cytokine storm in COVID-19 patient in combination with SIRS induced cardiopulmonary bypass leads to severe disorder and exacerbation of previous lesion by SARS-CoV-19. In pandemic condition, it's reasonable for cardiac surgery patient to be more carefully selected to prevent postoperative mortality and complications. Thank you for your attention.
Thank you, Dr. Mutare, for that excellent presentation.
Thank
We
you
welcome questions and commentary from our listeners. Do you have questions for Dr. Mutare? I think somebody has a question in the chat box. Do you read from there, or can I read for you? The question says, which day of illness should CT set should be done in COVID-19 infection or a patient with COVID-19 infection? Which day of illness should CT chest be done?
Oh, well, CT chest done before surgery and after surgery, and 24 hours after surgery, and 6 days, and also 20 days after surgery. In conclusion, about 6 chest X-ray done for patient.
Do we have further questions for Dr. Mutare?
Do you hear me? Hello. Hello. Do you hear me?
Yes, yes, we can hear you.
Okay. I read a question in chat box. Which type of illness chest tube should be done in COVID-19? It's better a chest tube done in some level. First level before surgery, and second and after surgery we do it again. It's and 6 days and 20 days after patient discharge in ICU, it's better we don't chest CT.
That was an excellent presentation from Dr. Mutare. We've learned and benefited from our presentation.
Thank you so much.
So at this point, I would like to call on the next speaker, Dr. Fatima Hogali from Hamad Medical Corporation, Qatar, to do our presentation. So you are welcome, Dr. Fatima Hogali.
Hi there. Can everyone hear me? Share system audio.
Yes, we can hear you.
Okay. I'm sharing now. Window.
Dr. Fatima, can you unmute yourself? Can you unmute yourself? Dr. Fatima, can you start your presentation?
Okay, can everyone hear me?
Yes. Yes, you can go ahead.
Okay, so I'm just worried that once I show my presentation, is it still showing the presentation?
It's okay.
It's okay, it's showing and everyone can hear me, yes?
And from here, I can only see your name.
Right. Well, I've been trying to share my screen, but if I share it, then it mutes me. So what I'm gonna do is I'm gonna just share my presentation and my article at the end of the lecture, but I'm just going to be presenting now. Okay, I hope that's all right with everyone. So I'm going to be presenting an unusual presentation of a 29-year-old female who came 10 days after Moderna vaccination with a case of perimyocarditis. This patient was previously healthy, only with a background of mild, stable chronic kidney disease from birth and partial nephrectomy. Other than that, she's had no other medical problems, no history of recent viral illness exposure or any other complaints. She presented to the ED on May 10, complaining of a 3-day history of low-grade fever and fatigue. Patient was given IV fluids and paracetamol for the fever, and preliminary bloods were taken, and COVID antigen was also taken as this patient was the staff. COVID antigen ended up being negative, so patient was discharged as labs were unremarkable. She returned 2 days later with non-specific symptoms of nausea, vomiting, and diarrhea of 1-day duration. She has also had complaints of myalgia, headache, and fatigue. So the initial diagnosis was acute severe gastroenteritis with dehydration and hypotension, as BP on admission was 80/60. But the patient had come in walking to us to the emergency department, so we were a bit confused about her presentation. On more history taking, it was found that she had taken the second dose of the Moderna vaccine 10 days prior to admission on April 28, 2021. Patient, once she was admitted and her blood pressure started to decrease, she was moved to the observation room where she was given aggressive fluid resuscitation of about 4 liters over the next couple of hours. However, she started to destabilize and blood pressure continued to fall. So she was given high dose inotropes and stress steroids to maintain mean arterial pressure. Meanwhile, baseline labs, including CBC, liver function tests, renal function tests, coagulation panel, cardiac enzymes, and pro-BNP were taken. ECG stat and bedside echo were also performed. So if everyone could see this slide. So the first thing obviously that came back initially was the ECG. So as you could see in almost all the leads, there is diffuse ST elevation. Patient is also having sinus tachycardia. There is some PR depression, and there's ST and T wave abnormalities as well. So this is consistent with a picture of acute pericarditis. So keep in mind, so far, no one had any idea what was going on. Patient came to us looking like a picture of acute gastroenteritis, but all her hemodynamic instability and vitals were going more with pericarditis, and this was confirmed on ECG. Bedside POCUS was also done for this patient, and this is the first video that was taken. Okay, as you can see, there's reduced contractility of both the right and left ventricle, and there's also pericardial effusion. And in the second video, there's compression of the right ventricle and the right atrium. Okay. So this third echo was done about 30 minutes from admission time. And as you could see, there's overt pericardial effusion and impending cardiac tamponade. So as the patient was hemodynamically unstable and we couldn't wait until the official echo report was done, we transferred her to the ICU, and there she started to deteriorate further. So to improve her ventricular function, as her ejection fraction was very low, it was about 27%, dobutamine was added. However, that exacerbated her condition as she was having a mixed picture of all three types of shock: cardiogenic, obstructive, and hypovolemic. And due to the complex pathophysiological mechanisms involved in each of these shocks and the impending cardiac tamponade, once the dobutamine was given, the patient ended up having actually vasodilatation. And what ended up happening with that and the cardiac tamponade, she had further hemodynamic compromise. So, as part of the management as well, we noticed that in some of the labs, the patient was having severe acute kidney injury with metabolic acidosis. So to try to combat both things that were happening at the same time before the pericardiocentesis was able to happen, SLED dialysis was started for this patient. However, there was some miscommunication, I believe, that had went on between the teams in the emergency, and this patient ended up actually going into pulseless electrical activity for 2 minutes after SLED was started. The patient underwent a cycle of CPR, and there was a return of spontaneous circulation, and the patient regained consciousness. Volume expansion was also given to further expand the intracardial pericardial pressure. Finally, pericardiocentesis was done and 300 ml of fluid was removed. So immediately after that, the patient started to improve, vitals started to stabilize, blood pressure became in the 100/90 or so, and also she started to just regain more consciousness, and the color of her face started to become better. So after the pericardiocentesis, patient was transferred to the ICU private bed where extensive workup was done. So the troponin, the cardiac biomarkers had come back at the time, and troponin initially on admission was 98. After this episode, and on the second day, it had increased to 1,632 nanogram per liter. So that is very high, showing us obviously there's cardiac injury consistent with the pericarditis and also the global hypokinesia and myocarditis as seen in the previous echo videos. I will share those later if you guys are not able to see it now. Pro-BNP was also very increased from 2,000 to 36,000. All other labs initially on admission were normal. CBC and inflammatory markers and COVID PCR were all negative, as well as autoimmune profile. So basically, our team just wanted to find out the cause for this pericarditis in a previously healthy 29-year-old. So all the blood tests were done. And throughout the course of her hospital stay, from day 3 to admission up until the 3 weeks that our patient had stayed, she ended up developing multi-organ injury, like acute kidney injury, deranged liver function, and DIC. However, the only thing that was kind of initially there with the cardiac tamponade was the acute kidney injury, which we could attribute to pre-renal azotemia. So as you could see in the lab findings over here, the highest findings were the troponin and the proBNP, again going with our diagnosis. There's also derangement of the coagulation profile in the PT, the INR, the D-dimer, and the PTT and the fibrinogen, and urea and creatinine are increased. Just to put some perspective, this patient had only mild chronic kidney disease, meaning their creatinine never exceeded above 110 micromole from the time they were a child. So this is stable. So we're not attributing that to any cause of recent acute kidney injury that happened during the course of this patient's hospital stay. And this is a venous blood gas showing high lactic acid and a picture of severe metabolic acidosis. So recovery, how did the patient recover? So all that is well ends well. So although our patient had a very complicated course with acute kidney injury, DIC, liver derangement, and also cardiac arrest, she eventually ended up completely recovering after her 3-week period. She stabilized hemodynamically, and she was weaned off all medications, and she was followed up with serial ECGs and echoes up until the time of discharge. And finally, she would be followed up later in the OPD cardiology clinic 4 to 6 weeks later on medications like colchicine and aspirin. So what is our diagnosis here? Our diagnosis is query perimyocarditis, but what is the cause? So again, like I mentioned, as we didn't really know what was going on, and at that time, the CDC had not reported real statistics or adverse events on patients who had received COVID-19 vaccination and developing heart inflammation. There were very few reported cases in the literature. The earliest reports had actually occurred in Israel in about April 2021 in a cohort of small teen males who between the ages of 15 to 20 ended up having myocarditis, pericarditis, or myopericarditis 1 to 2 weeks after vaccination. However, because it was the rollout campaign had just started there, we didn't know how accurate or representative of the incidence rate could be. So the question here is, what is the pathophysiology involved? What has precipitated the perimyocarditis in our patient? What other contributing factors could have led to this? Is it causal or is it merely a coincidence? So it's important to note that even up to now, as the COVID-19 vaccination rollout campaign is still quite new, there are more questions than answers. So the 4 most commonly used vaccines right now are the mRNA vaccines, Pfizer and Moderna, and then we have the less commonly used ones like Janssen and AstraZeneca. So majority of cases now reported by the CDC and by VERIS, the Adverse Events Reporting System of the United States, is showing that the majority of heart inflammation cases is occurring following Pfizer vaccine more than any other vaccine. After that, Moderna, then AstraZeneca, then Janssen. However, the reason behind this is not fully understood. There are not enough reports coming out, and there is not enough studies being investigated into the long-term, not only efficacy of these vaccines, but the long-term unobserved side effects, especially regarding vaccine immunogenicity and reactogenicity in certain populations. Currently, the most current literature I could find is of August 18, 2021, reported by the CDC and VERS, that there is about 2,574 reports of myocarditis, pericarditis, or myopericarditis across all age groups. The most prevalent infection, however, is a combination of both, which is myopericarditis, as seen in our patients. The highest incidence occurs between individuals between the ages of 18 to 24, but it was reported in individuals up to 50 years of age. It's also important to note that most cases occurred in males. However, cases are starting to rise in females as well. So this is now not only an adverse event that is being reported, but it's actually a known side effect. So these two distinctions are very important to know. And another important point to mention is that most cases reported after the second dose of vaccination, whether it was Pfizer or Moderna, rather than the first dose. And the time between vaccination and exhibiting any heart inflammation symptoms can be from 1 week up to 90 days post-vaccination. So these are just some statistic differences between countries. In Israel, there's about 12.4 cases of myocarditis or pericarditis per million patients. In Australia, which is the most recent, it's showing about 50 cases of myocarditis or pericarditis out of 288 reports. So that means if the incidence is estimated to be true, this is quite high. So it's important to keep in mind. And the UK and Canada had similar 3.9 to 5 per million doses. So how is this related to our patient? Circling back to our patient holds a unique presentation in that she had so many complications that almost led to her death. The rapid accumulation of pericardial fluid leading to cardiac tamponade, followed by cardiac arrest, in an otherwise healthy young patient is worth further investigations. And it's also a possibility that increased reactogenicity, which means the reaction of the proteins in the vaccine to a person's immune system and the person's own cells can occur. So what is the conclusion? So us as physicians, as researchers, what is the take-home message? The take-home message is that we need to keep an open mind when approaching patients who are having atypical or vague symptoms following any post-COVID-19 vaccination. It is also important to note that there has been cases of heart inflammation following COVID-19 infection, but now we are concerned with the vaccination rates. So we need to be able to keep an open mind, and we need to consider the long-term effects and etiology regarding vaccine-related myocarditis or pericarditis. Patients, we also have a duty regarding patients to inform them so that they can make an informed decision regarding potential symptoms and when to seek care as to avoid delay in diagnosis and management. My patient is from Qatar, and the population of Qatar is actually very small. It's about 2.8 to 3 million people. So if you compare this rate to the States or Canada or the UK, the rate of these types of infections may be higher because it's scaled towards a smaller population. However, it is important to mention that these facts, these statistics are not reported to the public on a daily basis in Qatar. It's just like an overall basis of how many people have been vaccinated, but not the side effects. So to be able to know the true incidence rate would require further investigation and further studies. And finally, it's important to see if there are any long-term complications associated with COVID-19 vaccination that is not otherwise being told to us, not only in the medical profession, but also in the general public regarding the safety profile and efficacy of these vaccines. I would like to state my opinion that I believe vaccination is very important. I just believe that there is more research that needs to be done on this topic to avoid any major complications that could happen in our patients. Thank you so much, guys, for listening. If anyone has any questions, please refer to me. I'm not sure if anyone could actually see the presentation or if you could just hear me. These are the references. This is the article that I have published. I will be sending forward everything to you guys. So I see the question from Dr. Sunita. Hi. So yes, for this patient, a full panel was done: viral, autoimmune, immunological, multidisciplinary teams from cardiology, nephrology, rheumatology, immunology, infectiology, like every discipline you could think of was seen by this patient, as it was a very rare case. So all etiologies were ruled out. And it's important to mention also that an MRI was done for this patient, but at the end of her 3-week recovery stay. So by that time, the infection had resolved and the MRI was clean and there was nothing else to say. So yeah, thank you so much for listening, guys.
That was an excellent one from Dr. Fatima Kugali. I hope
Thank you.
Participants have learned and benefited from your presentation. Do we have further questions, comments for Dr. Fatima Kugali? We have further questions for Dr. Fatima Kugali. Dr. Fatima, you can leave your email for people to contact you for further queries. At this point, I would like to call on the next speaker, Dr. Ghulam Naro from Rashid Hospital, Dubai of the Emirates, to do his presentation. Dr. Naru, you are welcome. Dr. Ghulam Naru, we are expecting your presentation.
Dr. Ismail.
In place of Dr. Naru, I'd like to welcome Dr. Simonga from Command Hospital, India, to do his presentation. Dr. Simonga.
Yes, sir, can I go into my presentation, sir? Should I share the screen?
Dr. Simonga, you are welcome.
Sir, I want to share my screen, but its message is showing host disabled participant screen sharing.
Hello?
Yes, ma'am. I am unable to share my screen.
No, no, I don't know. Either his organizer pronounced Dr. Sunita Kumbhalkar.
Okay,
or...
now I'm going ahead. Okay. Yes, can everybody see my presentation? No. Are my slides visible? Am I audible?
Yes, doctor, it's audible. You can start your presentation.
Okay. Today, first of all, I want to thank organizers of this conference, esteemed conference, for giving me opportunity to present my case series of this is a single center observation study on clinical profile and OCT guided management of the young ACS patients. Actually, I work in Command Hospital, Chandi Mandir. It is in India, northern part of the India. Here we get a lot of patients, young patients, especially less than 45 years of age, who are serving soldiers and who are posted in high altitude area in the Himalayas, northern Himalaya belt, that is in Himachal Pradesh to J&K, Leh Ladakh area. So they are all coming to me and being evacuated. So I had made yes. So I had made this study of 1 year duration. To aim of my study is to present experience of clinical profile and OCT guided management of these young patients less than 45 years who had presented with ACS during the study period. The study period was from October 2019 to September 2020. So I've completed around 18 months of follow-up for these patients. So this is a single center observation study. Study population is total amount participants are 119, and they are all less than 45 years of age. They have been referred to me and with ACS, acute coronary syndrome diagnosis, and thereafter I did further evaluation here, echocardiography as well as this coronary angiography for all these patients. So and proceed. So the results of the study are all these patients are male. These are all fit serving soldiers. Age range from 23 years to 45 years. So youngest patient was of 23 years age. And 71 of these patients had common risk factors. Commonest risk factor is being posted in high altitude area. That is more than 15,000 feet. They all were evacuated a day or 2 days later, and when they were diagnosed with ACS there. So other modifiable coronary risk factors in my patient population was history of smoking in 48 patients, that is 40.3%, dyslipidemia in 18 patients, that is 15.1%, hypertension even lesser, that is 7.5%, and diabetes only 3.4%, and family history of CAD is 2.5%. So traditional risk factors were lesser. However, smoking was still common risk factor, and other being the presence of high altitude area. So none of these patients were obese or had a sedentary lifestyle because they were all fit soldiers of Indian Army. None of these patients had prior atrial fibrillation. So presentation and CAG findings were commonest presentation in our population was unstable angina. That is in 57 patients. Overall 47.9% presented with unstable angina. Next commonest presentation was STA elevation MI. That was seen in 38.6% patients. And with further subdivision was that 68.8% of these patients were of anterior wall MI. And next common was inferior wall MI, that was in 26.1%. And 13% patient had presented with true posterior wall MI. And rest 14 patients, that is 11.7% had NSTEMI. So NSTEMI was the least common presentation. And commonest CAG findings was patent coronaries with slow flow. And most of these patients were suffering from unstable angina, and they were diagnosed with patent coronaries with slow flow. This was seen in 53.8% patients, and rest obstructive CAD was seen in 55 patients. Unique point of my study was that all these 55 patients underwent OCT study. And the distribution of CAD was single vessel disease was seen in 67.3% patient, double vessel disease in 12 patients, that is 21.8%, and triple vessel disease was least common, that is 10.9%, because these patients were young relatively and were having lesser traditional risk factors. Even diabetes was lesser. So LAD was the commonest vessel involved, that was seen in 60% patient, followed by RC in 25.5% and LCX in 14.5% of these patients. So intervention findings were that out of these, all those 55 patients who underwent angiography and were found to have obstructive CAD, 31 patients, that is 56.4% patients were having large intracoronary thrombus burden. And of these 14 patients, that is 45% of these patients out of these 31 patients overall, and 85% of patients who were evacuated from high altitude with MI, they underwent deferred stenting. What strategy I followed in these patients was that I used intracoronary thrombolysis immediately, either through the diagnostic catheter or through the even Tiger catheter I used, and or through the guiding catheter, whatever I used. And I used either TPA 10 mg in most of these patients. And however, when TPA was not available to me, I used nictaplase with the lesser dose, 5 to 8 mg. That is 1/5 of the systemic dose. So this was followed by GP2B3A infusion, mostly Riopro infusion, that is abciximab, for 24 and next 24 hours, and then 7 days course of LMDH at the dosage of 1 mg per kg twice a day was given for all these patients. And thereafter, all these patients underwent check CAG, and OCT was also done. So after following this novel approach, 85.7% of these cohort patients, these patients, that 14 patients, that stenting could be avoided, while only 2 patients required stenting after following this approach. And I've given examples, sir. I'll be showing. Most of these patients had completed uneventful 2 years follow-up, and rest of the patient has completed 18 months follow-up. So all these patients will have survived a 2-year follow-up, and mortality is nil till date. No major complication has happened. That is, only 1 patient had VF after intracoronary thrombolysis, and that required DC cardioversion. And so coming to the patient examples, this is the profile of the first patient. That is a 39-year-old serving personnel, non-smoker, no comorbidities. He was evacuated from high altitude area, that is more than 15,000 feet in Leh Ladakh area. He had suffered from interval MI on 2nd of Feb 2020. ECG was suggestive of acute ST elevation MI. Echo had shown EF of 40%, and he was live with nictaplase there. But however, window period was very late. He had presented to nearest medical facility after 8 hours. So pain had settled. ST resolution was there on ECG, more than 50%. Thereafter, he was evacuated to us on 3rd Feb, that is next day. So this was the pre-thrombolysis ECG, and this was the post-thrombolysis ECG. ST resolution was there, and T-wave inversion had come. So coming to the angiography, I had seen one this doubtful area of opacity is there. However, this is non-obstructive. There is a filling defect here. Most likely thrombus is there. So this is the thrombus which is there, which has not been cleared despite the thrombolysis. RCA is normal, completely normal. So what I did for this patient, I gave intracoronary thrombolysis through the diagnostic Tiger catheter only, and this dosage was 10 mg of TPA. Check CAG was done 20 minutes immediately. There was no immediate resolution of thrombus after 20 minutes because patient had presented to me very late. More than 24-hour delay was there. So he was shifted to ICCU and kept on GP2B3A infusion for next 24 hours. This was followed by 60 mg BD course of another 7 days of LMWH. So thereafter, on 10th of February, I did the check CAG, and OCT was also done. These were the findings. Now the thrombus has completely resolved. The vessel is completely clear. I still wanted to be sure whether plaque rupture is there as a mechanism or not. So I did the OCT pullback also for this patient. So these are the OCT findings. If we go from distal to proximal, all 3 vessel trilaminar structure is clearly visible. There is no residual thrombus or no plaque rupture is seen anywhere. It is coming from distal to proximal. Some residual thrombus may be there still adherent to the wall. However, there is no rupture, plaque rupture. Till now, it is not visible. This is a branch, it is come. This is the plaque erosion, which I could identify, and some residual thrombus. But after 7 days, that is check NG after 7 days of following this novel approach. So further course was that since OCD revealed only plaque erosion, there was no rupture. So vessel was not stented. He was kept on DAPT for 1 year, and clinical follow-up until to now 22 months is asymptomatic. Echo has improved, ejection fraction is improved to 55%, and TMT is negative at 12.4 mets. That is after 18 months of follow-up. DAPT for 1 year and is now on, and now we have kept the patient only on single antibiotic, that is ecosprin 150 mg. Procoagulant workup was done, and which is negative. So coming to the second patient, this 28-year-old serving soldier who is non-smoker, no comorbidities, and he is presented again evacuated from 15,000 feet Ladakh area, and he had suffered from inferior MI on 26 November 2019. This ECG was ratio of acute and inferior LMI with junctional escape, and EF was 45%. He was not lysed as he had come to me out of window period. So he was later on air evacuated to Command Hospital on 28th November. So his patient has continuously having ongoing angina for last 2 days. However, he reached nearest facility very late, so he could not be thrombolized. So with ongoing angina, I took him for urgent angiography, that is after 48 hours. This was an ECG on presentation to me. And this angiography, left angiogram, we see that RCA is completely filling, the distal part is filling retrogradely. Collaterals have formed. Since this patient has come to me 48 hours now. So this thrombus was there. So I crossed with the wire. This vessel was completely occluded. I didn't take angio for this part. And after crossing the wire, you can see this is all thrombus-laden vessel, completely thrombosid. This was 100% occluded. So with after passing the guide wire, some flow has been restored. That is, CME1 flow has come. But thrombus, we can see large thrombus burden is there. So I did not many runs of thrombosuction for this patient. And after this thrombosuction, this was the flow I could achieve. Still, we can see there is large area of residual thrombus is seen. This was the thrombus I could aspirate, red thrombus. So again, thrombosuction was repeatedly after giving 10 mg of TPA, which I followed this process. Residual thrombus was there. But even after 20 minutes of this repeated thrombosuction and 20 minutes of waiting after giving intracoronary thrombolysis, we can still see that residual thrombus is there. However, now flow is almost TME3. So I kept the patient on for deferred stenting. So OCT was also done in this setting only. Since almost TME3 flow was restored. So this, and after that check CAG was done. After 7 days, which has clearly shown that all the thrombus has been cleared. Vessel is now, there's nothing there. So only plaque erosion could be seen on OCT at this stage. So the vessel was not stented. So coming to the third case example, this patient is another 28-year-old young patient of anterior LMI, who was again evacuated from high altitude area. He had proximal LD lesion of around 60 to 70% borderline lesion was there. And on various views, I could identify only this one. So this patient has also come to me after 72 hours. So I first did FFR, which was 0.84, which was negative. However, I wanted to be sure that there is no plaque rupture as mechanism for this MI. So I did the OCT. OCT at this stage clearly showed plaque rupture, and thrombus was also seen over that. So I did the PCI. For this vessel, 4 into 15 minute drug-eluting stent was done, and it was post L2 4.5. So this is the result post stenting. We could achieve good minimal lumen areas, minimal stented area. Another example where I had to stent this patient, this a 35-year-old young surgeon, again evacuated from altitude area. OCT again showed plaque rupture in this patient. This was the initial angiogram when he presented to me. He had osteoprox lesion 99%. So this was the plaque rupture was there. So I had to stent this. So I had to do left main to LED stenting, and I had to cross LCX also, and had to dilate with the 3 millimeter balloon. So this is the final port was done with 4.5, and thereafter I did this angiogram. So and OCT. So this is showing well expanded stent, and stents have been cleared from the LCX ostium also. So another example, this is a COVID positive patient, recent patient. So this is the pre-procedure and this is the post-procedure result. So this is the fifth example. Mid-RCA is showing again 100% thrombotic cutoff, and post-intracoronary thrombolysis and with TPA followed by GP2, P3A and LM2H. This was the result, and this was the OCT image showing completely normal anatomy. So again, this patient was not stenting. So I've shown you 5 examples, out of which 2 were not, 2 were only stented and 3 were not stented. So conclusion of my study is that young ACS patient is subset that needs to be studied for the presence of traditional as well as specific risk factors. In our study population cohort, 59.3% patients were posted in altitude area, and approximately 40% of these were smokers too. So I found that high altitude area and smoking combination is worst for these patients. So, and with this, with the use of deferred stenting approach that I have shown in my case example, and after that OCT guidance, we managed towards stenting approximately 85.7%, that is 14 patients, we could avoid stenting in this kind of substrate with high thrombus burden on initial angiogram. So take a message. Firstly, ACS patient FFR may be misleading. Then thrombosuction still has role in young patient with high thrombus burden, especially with delayed or no lysis. And as we have seen case example 2, there was role of thrombosuction. Imaging helps us in differentiation of plaque rupture versus plaque erosion and further need of stenting in this kind of substrate, young ACS patients. So, and in patient with severe LV dissection, still OCT can be done. However, we used less contrast, that is what 1:1 deletion was used. Thank you. I'm open for questions.
That was a nice presentation from Dr. Sin, Dr.
Thank you,
Monga.
sir. Thank you, sir.
Yes. I hope we have benefited from his lecture, from his presentation.
Thank you, sir.
Do we have any questions? Any questions, any queries for him? Excellent one from Dr. Monga.
Thank you so much, sir. Thank you, sir. Thank you for giving me the opportunity, sir.
Any message in the chat box? No message. At this point, I would like to call on Dr. Sunita Kumbaka to do his presentation. Dr. Sunita, you are welcome.
Yeah. Good morning, sir.
Share screen.
I'm sharing my screen.
Can't be shared. Slideshow.
Okay. Good morning, all dear faculties and dear colleagues. Am I visible and audible?
Yes, doctor. The slides are visible and your voice is audible.
Okay. So I'm presenting my study in a clinical and angiographic profile of young patients of ischemic heart disease, a Central India study. So I am thankful to my guide also, Dr. Vikas Bisne, for the help he has provided to me. We know the cardiovascular diseases, they are the leading cause of death globally, and around 17.9 million it claims lives per year. Many behavioral factors are known to occur, like unhealthy diet, physical inactivity, tobacco, and harmful use of the alcohol. What is the effect of this behavioral risk factor? It leads to hypertension, raised blood glucose, dyslipidemia, and obesity. What will occur after the reduction of all these risk factors of CVD? If you cessation of tobacco use, reduction in the salt intake, intake of more fresh fruits and vegetables, and the regular physical activity, and if you avoid harmful effects of alcohol, it definitely has an effect, as so many studies are there, which causes decrease in the prevalence of the coronary vascular disease. What is premature coronary artery disease? Is the disease occurring in an age less than 55 years in men and 65 years in women. We call it the severe or the malignant CAD when it occurs in the age less than 45 years. Especially the Indians, we are more prone for at very younger age. The 50% of the heart attacks occur before 55 years and around 25% heart attacks occur before the age of 40. So that is a burden of the CAD in our part. These are the figures from 2013 when there's an increase about 7-fold in the urban areas and it has quadrupled in the rural areas from 1.7% to 7.4%. The urban areas, definitely the diabetes mellitus also has doubled. Rural areas, still the smoking is a major risk factor. And there are so many differences in the hospital and the discharge medical care facilities. So CAD in young, especially, so many definitions are there, especially when it occurs less than 45 years of the age. Recent study indicates the prevalence of 1.2%. Ethnic wise, South East Asians, especially Indians, the prevalence is of course 5 to 10%. Most common risk factor is the smoking. Several genes have been attributed like CETP, lipoprotein lipase gene, ApoA1, ApoE, and ApoB. Various biomarkers are associated with the premature CAD like lipoprotein A, fibrinogen, D-dimer, gamma-glutaryl transferase, vitamin D, and osteocalcin. One important thing is, as the previous speaker described, there are many thrombotic lesions are more common, and that is why the prognosis is better with the thrombolysis and the early arrival at the hospital. Poor prognosis, especially in obesity, and if the person is currently heavy smoker. What is angiographically findings are there? They are predominantly they are having single vessel disease. So they are the study by Agarwal et al. So this study I carried out to study, have the clinical, biochemical, and the angiographic profile of the ischemic heart disease in young adults to study various traditional risk factors and certain newer risk factors like lipoprotein A, fibrinogen, and homocysteine. We also studied correlation of the significant and the non-significant coronary artery disease with various risk factors. It was a cross-sectional, it was a monocentric hospital-based study at Super Specialty Hospital Nagpur. I recruited total 70 cases during over a period of 2 years. Males less than 35 years of age and females, we studied less than or equal to 40 years, considering the reproductive age and the premenopausal age. Ischemic heart diagnosis was made by the guidelines by the ESC and the AHA. We studied them clinically, biochemically, and angiographically. The newer risk factors like lipoprotein, homocysteine, and fibrinogen was studied in 44 cases only due to some constraints, and appropriate statistical analysis was done. So this is a chart table showing our age distribution. I can show here the majority of the subjects, they were in the age group of 31. Majority of the subjects were the age group of 31 to 35 years. And in the female group, which was there, they were in the age group of 36 to 40 years of age. That is 9 cases, so 12 to 12.8%. The average age of presentation was 32.97 plus minus 3.93. Regarding gender, there are majority of the cases, 84.28% were males, while 15.7 were females. Again, it corresponds to the various studies by various authors. As occupation was studied, majority of the subjects were in the businessman. They were physically active, around 54.28 were there, and other categories include laborer, farmer, then drivers. Only one student was there. The youngest patient in our study was 21 years of age, and he had a normal coronary angiography. Again, this is showing so highest class belonging to the business class of group. The associated factors like stress was studied. Of course, the stress is a very difficult to study. We cannot quantitate the stress, but we have got only suprarenal mass was there in one case, that is 1.4%. Then job stress was there in 1.4%, and cerebrovascular episode presented in 2.8% of the cases. Various conventional risk factors were studied. In our study, smoking, diabetes mellitus, hypertension, tobacco, that is a gutka chewing, was the important factor that we found out. So this is a gutka that we get over the counter. It is a form of tobacco, and people eat it like various classes. They eat this gutka. and it is found to be about 35.71%. History of premature CAD was present in 8.57%. So important factor found out to be a gutka chewing or the tobacco. It is a smokeless tobacco in 35.71%. So again, as you can see that tobacco has a important association with our CAD patients. So our study correspond to the other authors like Hari Krishnan, Bharadwaj. They also found out smoking as an important factor, additional risk factor. Center to value found out 43.75% of the cases having diabetes mellitus, while again Kasliwal in their study found systemic hypertension to be 70% of the cases. While our study, we find tobacco chewing is an important factor in 37.71%. Another type of myocardial infarction was studied. The majority of the group, about 74.6%, they presented with the anterior MI, followed by the inferior MI and NSTMI and unstable angina. So anterior MI was the predominant presentation in our group. LV function in these patients we studied, majority of 61% patient presented with moderate LV dysfunction. So metabolic syndrome was studied. It was absent in about 87.15% of the patients. And this is very contrast to the elderly population, which are mostly obese. Our population was not very obese and they were active, physically active. So the traditional risk factor, lipid profile was studied, and the decreased HDL was found to be 61.85% of the cases, followed by about increased total cholesterol and increased LDL and increased triglycerides. So our study, again, we compare with the other groups. So Hari Krishnan et al. Found dyslipidemia in 92% of the cases. Bharadwaj et al. They found decreased HDL in 43.1% of the cases. Kasliwal, they found out decreased HDL in about 72.5% of the cases. In our study, we found decreased HDL in about 62.85% of the cases. So newer biomarkers were studied, like lipoprotein. The average value was 47.18 milligram per deciliter. Homocysteine was studied. It was found to be 29.78 millimole per liter, and plasma fibrinogen was 333.25 milligram per deciliter with standard deviation. The coronary angiography was done in all the subjects. We found predominance of the single vessel disease in 57.14% of the cases, followed by DVD, double vessel disease in 11.47%, and TVD in 7.14% of the cases. The angiography was normal in 24.28% of the cases. So predominance of the single vessel disease was found in our study, which also corresponds to the studies by other authors in a young CAD patient. We found out thrombus in 4.2% of the cases and dissection in 4.2% of the cases. This is the echo of one of the cases having LV apical thrombus, young patient. So depending on the coronary angiography involvement of the vessels, the predominant Bharadwaj et al. Found out single vessel LAD involvement in 86.1%. Sengo value found out LAD in 59.4% of the cases. In our study also, we found out LAD involvement predominantly in 82.5% of the cases. Another author reported 6.2% of the aneurysm, and we found out dissection in about 4.2% of the cases. And study by Deshmukh et al., they found out dissection of the arteries in 4.87. So predominantly LAD involvement was seen in most of the studies. So this is one of the angiogram of the patient who was a young patient of 33 years old, and he had a triple vessel disease. So you can see the severe critical stenosis of the LAD and LCX. The RCA is not seen in this. This is another patient having young patient of 28 years old, showing the coronary artery dissection in the RCA. Another patient having severe LAD stenosis, 90%, she is just 29 years of old. This is important siblings, brother and the sister. we showed the, of course, the one admitted after the first, that is brother, after about 3 months, and we can see total cutoff of the LAD in the female patient, while in the male sibling, we find the LAD, of course, the critically narrowed LAD. So these both the patients, they were having history of premature CAD in their family. So I am presenting case 1 here. She was a young female, and she has an angina for 1 month. When she was admitted, she has anti-wall MI, and she was 32 years at that time. She was hypothyroid. There was no history of premature CAD. She was on insulin and OHA. And after that, when she presented to us, she has biochemical profile of total cholesterol 130 milligram, total triglycerides to 15 milligram percent. HDL was 39.2 milligram percent, and the ratio of TC and HDL was 3.31. So this patient has LAD involvement on angiography. Of course, about 80% of stenosis in the proximal LAD. She was treated with angioplasty. And after angioplasty, she has got good results. So she was treated with this Pronova stent, and she has a good result with a good flow. So TIMI-3 flow was there in LAD. So second case was 27 years. He presented in 2007 with anginal pain. There is no history of diabetes or premature CAD. He was a tobacco chewer for 4 years, unmarried. TMT was negative, and this patient was also on the regular treatment. He was again admitted in 2013 for palpitation. So during his index admission, these were the parameters. Fasting blood glucose was 100. Total cholesterol was 186 milligram percent. The HDL was 40 milligram percent, and the ratio of TC and HDL was 4.65 milligram per, ratio was 4.65, and his LDL was 132 milligram percent. So this patient has again critical LAD stenosis, and he was also underwent angioplasty with the Pronova stent, and these are the result. After his stunted, the good flow was there. His RCA was normal. So again, in both of the patients, the LAD was critically involved. So you can see the flow in this patient after the angioplasty. There was a good flow. So we studied the risk factors in other normal CAG. In those patients, the CAG was normal. The tobacco was found to be predominantly in out of 17 patients, 8 patients. It is more than 50%. They had the tobacco, smokeless tobacco as a important risk factor, followed by smoking, hypertension, diabetes. So these are the findings in those having normal coronary angiography. After that, we studied the clinical characteristics, compared the group, those having significant coronary artery disease and non-significant coronary artery disease. So in this age group, we had different like smoking and other risk factors we have studied. Premature history of CAD was found to be statistically significant in the group having significant CAD and the non-significant CAD. Significant CAD, we had taken the coronary stenosis more than 70%. The other factors like smoking, diabetes, hypertension, and the gutka were not found to be statistically significant in this age group. The other lab characteristics we studied in the significant CAD and non-significant CAD, again in these triglycerides, then the ratio of total cholesterol and the HDL, and the LDL and the HDL. These 3 parameters were again found to be statistically significant in these 2 groups of significant CAD and the non-significant CAD. Other newer risk factors were studied in the 2 age groups, groups like significant CAD and non-significant CAD, but all the like 3 factors like fibrinogen, homocysteine, and lipoprotein A were not found to be statistically significant. We again studied involvement of the proximal or the mid LAD and the non-LAD region. So comparison of the LAD and the non-LAD region. Here we found out family history of premature CAD. It was found to be statistically significant. While again tobacco intake, smokeless tobacco also found to be statistically significant in the two age groups, while having those having proximal or the mid LED involvement and the non-LED lesion. We compared the biochemical parameter in the two groups. Again, here we found out ratio of LDL and the HDL to be very significant, those having proximal LED and the non-LED lesion. The newer risk factors which were studied in the group like left main or the proximal LED stenosis and non-LED lesion, but none of the factors like fibrinogen or homocysteine or lipoprotein A was found to be statistically significant in the according to the type of lesion involvement. So my study concluded with, we have got a average age of the patient was 32.97 years plus minus 3.93. Male patient predominated in the study 84.28%. The female, again, they were 15.7% involvement was there, and all females were in the age group of 36 to 40 years of age. The female were mostly found to be diabetic in this subgroup. So male patients were predominantly 31 to 35 age group. So major conventional risk factors like tobacco was seen in 35.71%, hypertension in 22.84%, smoking in a 17.1%, diabetes mellitus was least common of the like 11.47. The history of premature CAD was seen in 8.57%. As compared to the other study, we also found entry-wall MI to be a common presentation in 74.6% of the cases. Females, again, entry-wall MI was more common. 36.36% were diabetic in a female group. Metabolic syndrome was only present in 12.85%. We found out elevated total cholesterol in 38.57. Important finding is a decreased HDL in 62.85%. The newer risk factors, increased lipoprotein A seen in 61.36%, increased homocysteine in 77.27%, and increased fibrinogen in 18.18%. Single vessel disease was found predominantly 57.14% of the cases. Normal coronary angiogram seen in 24.28%, and of this normal angiogram, 46.07% at the habit of smokeless tobacco consumption. LED was the most culprit vessel in 82% of the cases. LMCA, left main coronary artery involvement, was not seen in our case. In few studies, they have also found to be a involvement with the LMCA. So significant CAD was associated with the positive history of premature CAD, increased serum triglyceride, total cholesterol and the HDL ratio, and the LDL and the HDL ratio. So these four parameters were associated with the significant coronary artery disease in young subjects. Then LED lesion association with the positive family history of premature CAD, tobacco intake, and the LDL and the HDL ratio. So LED lesion, like proximal LED lesion and the mid LED lesion, was mostly associated with the positive family history, tobacco intake, and the LDL and the HDL related. There was no correlation was found between significant CAD and LED lesion with a newer risk factors. The other investigator like Pineda et al., they also studied lipoprotein A, they studied fibrinogen, and the Pineda et al. Found again the fibrinogen to be an important risk factor associated with the coronary artery disease in a young patient. While Vishwanath Mohan also from the southeast like India, they found to be also associated with risk factor as a lipoprotein A also. So, but in our study, we could not found the newer risk marker association with the coronary artery disease in young subjects. So our limitation, it was a single-centric study, cross-sectional, no controls were taken, and some patients were already on statins, they came late to us, and newer risk markers we could study only in 44 subjects. So take-home message, Southeast Asian, the males in Southeast Asia, they are more prone for the coronary artery disease, especially less than 40 years of age. Early screening for risk factors should be started early. The tobacco consumption in the form of gutka especially should be discouraged, and the healthy dietary habits in the form of fresh fruit, vegetables, and the fresh vegetables should be encouraged. So with these remarks, I conclude my presentation. I'm thankful to you and thank the organizer for allowing me presentation in this Heart 22 conference. Thank you.
Thank you.
Thank you,
Professor Mbaka, for this presentation, for an excellent presentation. I hope we have benefited and learned immensely from our presentation. Do you have any questions for Professor Mbaka?
yes, the questions are invited.
Any questions for Prof?
If any questions are there, happy to answer the questions, if any. Are there any chat questions in the chat box?
Well, if there are no questions for
okay, thank
no
you.
questions for Prof.
Thank you, thank you. If there are no questions, I will unshare my screen. Right.
There are no questions for Professor Sunita. I'd like to invite Dr. Fatima to come and share her slides. She could not share her slide the first time she presented. Dr. Fatima Kogali from Harvard Medical Corporation, Qatar.
Yes, hi.
Like
Hi.
Can
you hear me?
Yes, Dr. Fatima, I can hear you. So I'll share you the slides now, and you can explain the.
Sure. Okay, hi everyone. Thanks for joining me again. I'm just gonna give a quick presentation. So my name is Dr. Fatima. I am a medical doctor and I work as a scientific review researcher and publisher in the Medical Research Center in Hamid's Medical Corporation. Today I will be presenting an unusual presentation of acute perimyocarditis following SARS-CoV-2 mRNA Moderna vaccination. Next slide, please. So case presentation, history of present illness. So I'm presenting a case of a 29-year-old previously healthy female with a background of mild, stable chronic kidney disease from birth and partial nephrectomy, who presented to the emergency complaining of a 3-day history of low-grade fever and fatigue. Patient was not having any other symptoms, and she was given IV fluids and paracetamol for fever. Preliminary bloods and COVID antigen was negative, so we didn't do for her the PCR. She was otherwise fine and ambulating, so she was discharged home. She returned 2 days later with non-specific symptoms of nausea, vomiting, diarrhea, and also myalgia, headache, and fatigue. The only positive element in our history is that this patient had taken the second dose of Moderna vaccination 10 days prior to admission to the emergency. on admission to the emergency for the second time, she was admitted as a case of acute severe gastroenteritis with dehydration and hypotension. Next slide. So as the patient started to feel unwell and she actually started to feel very faint, we moved her to the observation room and hooked her up to the continuous monitoring machine. Patient started to destabilize and blood pressure was falling, and there's lack of compensatory mechanisms. She was given aggressive fluid resuscitation of about 4 liters over 2 hours, at which the blood pressure was mildly elevated, but still below 80 over 70 millimeter mercury. So we gave her high dose inotropes and stress steroids to maintain the mean arterial pressure. Preliminary bloods were taken to rule out any sort of sepsis, as well as any sort of pneumonia, and ECG stat and bedside echo were performed. In the next slide, next slide, please. Thank you. So as you could see here, the unique development is that this patient actually showed signs of acute pericarditis, as you could see in leads 1, 2, 3, AVF, and in V1 to V6, this patient is having diffuse ST elevation, as well as some ST and T wave abnormalities with NPR depression. All findings which go with a diagnosis of acute pericarditis. Next. In the bedside echo, it is showing, if you could just click on the first video, Ms. Sarah. Yes. So as you could see, the contractility is reduced. It's falling behind the lag time. So this goes with reduced biventricular contractility, and it goes with hypokinesia of the cardiac wall. And if you could click on the second video. As you can see, it's 15 minutes between the first and the second video. So both videos are showing a mild pericardial effusion that is compressing not only the ventricles, but also the right atrium. On the next slide, this echo was done about 1 hour after, and it's showing impending cardiac tamponade with a large pericardial effusion. Next slide. So the story continues. Patient was having very low ejection fraction and was not able to stabilize. So she was moved to the ICU, and we added for her dobutamine to improve her ventricular function. However, it ended up causing a vasodilatory mechanism, and she had further hemodynamic compromise. Patient was also suffering from acute kidney injury, and to compensate for this, we started sled dialysis. Unfortunately, what ended up happening, we depleted the volume, and this patient, as they were having cardiac tamponade and shock, it ended up causing her to go into pulseless electrical activity and cardiac arrest for about 2 minutes. After spontaneous return of circulation, pericardiocentesis was done for the patient, and she was hemodynamically improved. Around 300 ml was removed. Next slide. Cardiac biomarkers were showing evidence of cardiac injury in the form of pericarditis and myocarditis, which goes with a diagnosis of perimyocarditis. As you can see, the troponin is very increased from 98 to 1,600, and the proBNP had also increased from 2,000, increasing up into 36,000 to the second day of admission. Other labs, as Dr. Sunita had actually asked if the viral panel was done. It's not shown in these slides, but all other workup was done for this patient, and everything was negative. So the only positive history was the recent vaccination. Next slide. So this is just showing the labs, like I said, and also some derangement of the coagulation or liver profile, as you could see in the indices. And also in the next slide, there is severe metabolic acidosis with an increase in lactic acid. Next slide, please. So patient recovered over a 3-week period. She was discharged on colchicine and aspirin with OPD follow-up in the cardiology unit, and she was diagnosed as perimyocarditis, most likely, but query due to post-Moderna vaccination. Next slide. So what has happened here? This patient presented with a unique atypical presentation of acute perimyocarditis. This begs the question, what is the pathophysiology involved here? What has precipitated this and what has contributed to these factors? Next slide. So the CDC has reported that the incidence of myocarditis and pericarditis or cardiomyopathy following COVID-19 vaccination to be rare. Keep in mind, I saw this patient 7 months ago in May 2021. So the reports that were being done back then were not very up to date. Now there are a bit more reports, but we don't have the full picture of how many cases or the true incidence rate, not only in the United States, but across all countries. Questions regarding vaccine immunogenicity and long-term effectivity, as well as long-term unobserved side effects and the safety profile of the vaccine has also not been proven. Next slide. So the most important thing to keep in mind when you have a patient and they're coming to your clinic or to the emergency and they're presenting with vague symptoms, you should keep in mind all the possible causes, especially if they're in the age group that is reported to have the highest incidence between the ages of 18 to 24, and also if they're males, and also if they have taken their second dose of vaccination, whether that be from Pfizer, Moderna, AstraZeneca, or Janssen, because these four are most commonly implicated in causing heart inflammation symptoms across all age groups. Next slide. Okay, so these are just some statistics. As I mentioned previously, they're more or less the same, but the most highest incidence reported so far, as you can see, is in Australia as of July 11, 2021, reporting 50 cases of myocarditis or pericarditis out of 288 reports. This puts us at 13.5 per million doses administered, which is quite high. Next slide. So, like I mentioned previously, our patient is unique in that severe complications were not really reported in literature. Most patients who ended up having these heart inflammation cases resolved spontaneously or had an uneventful recovery. Our patient had a very complicated course with cardiac tamponade, pericardial effusion, full body edema, and also cardiac arrest. So it's a possibility that increased reactogenicity, which means that in some patients, their immune system will react stronger to the proteins and the cross-binding of the protein vaccines to the cardiac muscle as compared to other patients. So this may be a possible reason why this patient got this side effect and the severe complicated course. Next slide. So in conclusion, as physicians, researchers, and as healthcare workers, we should advise patients of potential symptoms and when to seek early care as to avoid delay in diagnosis and management. It is also crucial to keep an open mind when approaching patients with atypical or vague symptoms, as it could lead to potentially fatal consequences. There should be further investigation into the etiology of these long-term side effects, especially as the rise for more vaccines and more booster doses continue to occur. Next slide. So closing links. In regards to our patient, actually, I forgot to mention this. She has been advised against, according to the Ministry of Public Health in Qatar, to not take this vaccine, as she can have a very possible and serious complication of getting this perimyocarditis once again, and it's very possible that she might not survive it. So it is important that we keep this in mind for every patient, and before just going with the flow and not researching every case properly, each patient should have a catered consent form and should be made aware of their decisions prior to taking any sort of vaccination. Thank you for next slide. Thank you so much for listening for the second time. I really appreciate being given the opportunity to present not once, but twice. My bad, there was some technical errors going on earlier, but thank you so much, everyone. If anyone has any questions, please don't hesitate to contact me or email me.
Nice one from Dr. Fatima Kukali. I hope we have learned and benefited by sharing our slides once more. Do we still
Thank
have
you.
questions
I
for
appreciate
her?
I thank Dr. Fatima for giving your presentation for the second time. Kindly drop the email in the chat box so that if there is any questions for the speakers or the attendees, they will contact you through email. Thank you once again, Dr. Fatima. So I would like to thank Dr. Ismail for moderating and supporting for the whole morning session and making it a lively and interesting one. So now there will be a break, lunch break from 12 to 12:30 p.m. And after the lunch break, we'll meet again with the interesting sessions. Thank you.
Thank you everyone for listening. I hope we meet in the next session.
Transient depression of the STT segment on the ECG is due to other reasons. So aim to compare the results of computed coronary angiography with the conclusion of the pretest probability of chronic coronary syndrome in patients with abnormalities, microvascular disease, non-obstructive or obstructive atherosclerotic disease, materials and methods. Our study was conducted on the basis of the Rostov Regional Clinical Hospital with the participation of 50 patients aged 40 to 67 years. Inclusion criteria: chronic coronary syndrome with evidence of pain. Before starting the study, each patient is assessed for the pretest probability of chronic coronary syndrome. The main anthropometric indicator were evaluated: body mass index, waist circumference, hips, conducted ECG, ultrasound of the heart, BCA, Holter, and most importantly, computed coronary angiography. If necessary, disable coronary angiography was performed within 1 month after spiral computed coronary angiography. Computed tomography data of the atrial bed were studied using Excel section. The evolution of the lumen of the coronary arteries was performed by segment according to the classification of the Society of Computed Tomography Specialists. All patients divided into 5 groups: patients with muscle bridges, storage and initial stenosis, moderate and severe stenosis without atherosclerosis, and anomalous hypoplasia of the coronary arteries. The obtained data were processed in the application program statistic VERSA-12 using such enrichments and Shapiro-Wilk, Mann-Whitney, chi-square Pearson with the Yates correction, set of statistical estimate with p less than 500. So results. On detection of spiral coronary angiography in patients with muscle bridges found initial stenosis, conclusion coronary angiography showed a low probability, the test moderate high. The second group, initial stenosis, were detected to a greater extent in the anterior interventricular artery. Conclusion, coronary angiography showed a low probability, the test moderate high. In group 3, moderate stenosis were found in the left and right coronary arteries, anterior interventricular and circumflex arteries, severe stenosis of the anterior interventricular and circumflex arteries of the right coronary artery. Conclusion, coronary angiography showed a moderate high probability, the test high. No calcification were found in the group with coronary artery anomalous. Conclusion, coronary angiography showed low probability, the test moderate. Dear colleagues, please look at the general table. In group first, male patients predominate. Depressed probability within the proportion differences was moderate to high. Transient depression on the STT segment in group 1 is more common than in group 2. Group 2 was dominated by patients with moderate pretest probability. Group 3, patients were found to be older than those in other groups. Compared with the detection of initial stenosis, women were more common in the third group. Predominant apical pain syndrome, patients with high pretest probability, and the third group more often than in the first and fourth groups, there was atherosclerosis in the carotid arteries. A feature of patients with clean arteries is a higher incidence of exacerbation of pain. Pretest probability in group 4 and 5 was more moderate. Discussion. I'd like to know as follows from the result of the study. Computed coronary angiography made it possible not only to identify patients with the risk of developing coronary complication, but also to conduct differential diagnosis on an outpatient basis without resorting to an invasive method. In our study, a large number of patients with muscle bridges were found. According to the literature, there are large differences in the frequency of their detection. The prevalence of muscle bridges varies considerably from 4 and 60%. This widespread can be explained by different generation of tomographs. As follows from the literature, with computed coronary angiography, the probability of detecting muscle bridges is higher than with traditional coronary angiography. The need for coronary angiography after computed coronary angiography was low in our study, which avoided additional financial costs associated with hospitalization and possible complications associated with an invasive procedure. In 4 cases with a low pretest probability, coronary atherosclerosis was detected, requiring treatment. In 28% of cases, transient depression of the STT segment was not confirmed by finding on computed coronary angiography and was due to microvascular lesions of the coronary arteries, and in 1 case, mitral valve prolapse. Thus, the table of pretest probability of chronic coronary syndrome doesn't allow to reveal the differential diagnosis and evaluate the nature of the manifestation of coronary arteries in accordance with the result of computed tomographic coronary angiography. Wherein my personal contribution to the work, ideation, drafting of the manuscript and presentation of profit for the International Conference on Clinical Cardiology and Congenital Heart Disease 2022. I'd like to note that spinal computed coronary angiography was performed of our patient as part of compulsory medical insurance. This is free of charge. Therefore, it's possible to prescribe this examination method free in your clinic. We strongly recommend using it instead of routine methods. Thank you for your attention. And if you have any questions, you can contact my mail. I'll write it in the chat now.
Thank you, Dr. Masako. That was an excellent presentation. Hope the participation have learned and benefited by sharing research work. Does anyone have a question? Please write down on the chat box. Nobody have question? Thank you, Dr. Masako.
Thank you so much.
So much. Have a good night. Have a good day. Bye. Okay, and now I would like to invite Dr. Liza A. Adro to give her presentation for our Moscow Medical Stomatology Russian Federation. Dr. Adro, can you hear me?
Good day. Good day. No. Mhm. Mhm. Can you see my presentation?
Yeah, please start. Thank you.
Okay. Good afternoon, dear colleagues and members of the Presidium. My name is Leisan Andreeva. I am an assistant of the Department of Internal Disease of the Moscow State Medical University, named after Yevdokimov. My report today is devoted to the following topic: features of changes in central aortic pressure and arterial stiffness during the day in patients with arterial hypertension, depending on concomitant comorbid pathology. According to the latest epidemiological study of RF, the prevalence of hypertension has increased from 40 to 44% over the past 6 years. By 2025, the number of people suffering from elevated blood pressure is projected to increase to 1.5 billion. Arterial hypertension refers to key problems of the 21st century medicine. Hypertension is often asymptomatic or with mild clinical manifestations, leading to damage to target organs. In this regard, a crucial role in risk stratification belongs to identify subclinical lesions of target organs. At the same time, the total risk of cardiovascular complication is affected not only by the level of blood pressure, but also by the presence of associated pathology, as well as damage to target organs, including the vascular wall. Currently, pulse rate velocity more than 10 millimeters per second is approved as a marker of vascular wall damage and an independent cardiovascular risk factor. It is known that pulse rate velocity is subject to daily fluctuation, and therefore it is of interest to study its diurnal dynamics. It is known that arterial hypertension is associated with a progressive increase in arterial stiffness, which from the point of view of the theory in Nielsen is interpreted as previously vascular aging. Currently, there are 3 ways to determine vascular age. Based on the intermediate thickness of the common carotid artery using the transformed formula HOMA et al. And according to the method of De Agostino, using data from the Framingham study, taking into account gender, age, smoking status, the presence of diabetes, blood pressure, total cholesterol, and ADL cholesterol, using the recommendation of the European Society of Cardiology based on the 10-year risk of fatal cardiovascular events calculated on the SCORE scale. Prognostic value of central aortic pressure and is closely associated with arterial stiffness, still being discussed and requires further research. It is known that in young healthy individuals, the difference between brachial and central blood pressure can be more than 30 millimeters AD. It is due by pulse pressure amplification. With age, increases the stiffness of the central arteries and central aortic pressure becomes higher than at the periphery. It's due by phenomenon of the reflected wave. Thus, the central aortic pressure and its deforming load on the heart more realistically reflects the load on the left ventricle. In modern medicine, the study of comorbid conditions is of increasing interest since most diseases of different organs and systems often agree is a coexistence of 2 and or more disease in one patient, pathogenetically and genetically interrelated. The most frequent combination of comorbid conditions is associated with cardiovascular pathology, including hypertension. Of great interest is the combination of arterial hypertension with overweight and the development of metabolic syndrome. It is proved that cardiometabolic disorders led to early and significant lesions of target organs. Insulin resistance led to the following changes: hyperglycemia, hyperinsulinemia, hypertension, dyslipidemia, reduced fibrinolytic activity, endothelial dysfunction, inflammatory markers of atherosclerosis, microalbuminuria. This increases the risk of developing cardiovascular disease. Thus, arterial hypertension association with metabolic syndrome is characterized by the elasticity of blood vessels decreasing faster than in characteristic of the age, inadequate sensitivity of blood vessels to changes in hemodynamic parameters. In recent years, there has been an increased interest in the study of cardiovascular diseases, one of which is arterial hypertension with presence of hypothyroidism. Hypothyroidism leads to conditions such as insulin resistance, dyslipidemia, hyperhomocystinemia, hypercoagulation, and increased reactive protein. These changes increase cardiovascular risk too. In this table, we show that difference between subclinical hypothyroidism and manifest hypothyroidism. A number of studies have noted endothelial dysfunction even at normal thyroid hormone levels and worsening as it increases. In our research, we assumed that the association of arterial hypertension with metabolic syndrome exacerbates the structural and functional changes in the cardiovascular system, worsens the arterial hypertension, especially parameters of the central aortic pressure and arterial stiffness that affects the cardiovascular prognosis. We our task to conduct a comprehensive analysis of the dynamics of central aortic pressure indicators during the day in person without cardiovascular pathology and its patient with essential arterial hypertension associated with metabolic syndrome and subclinical hypothyroidism. To conduct a comparative assessment of daily arterial stiffness indices, pulse waist velocity, arterial stiffness index, reflected wave times, pulse time index of norm in healthy individuals and patients with essential arterial hypertension associated with metabolic syndrome and subclinical hypothyroidism. To clarify the correlation between the indicators of central hemodynamics and the values characterizing arterial stiffness in individuals with essential arterial hypertension associated with metabolic syndrome and subclinical hypothyroidism. To analyze the relationship between vascular age comorbidity index and arterial stiffness in comorbid patients with essential arterial hypertension associated with metabolic syndrome and subclinical hypothyroidism. Our researching inclusion men and women aged 30 to 65 years, the presence of hypertension, the presence of metabolic syndrome, the right and consent for participation in the study, and the ability to follow the study protocol. We exclusion and not inclusion such patients as pregnant and lactation woman, mental illness, the presence of acute disease at the time of participation in other clinical studies at the time of recruitment, or a single clinical study within the previous 3 months, the lack of informed consent, the inability to follow the study protocol, patients with symptomatic arterial hypertension, and the presence of associated clinical conditions. All the patients include 82 with hypertension, which amounted to 2 main groups. 33 patients with arterial hypertension, 49 patients with arterial hypertension and metabolic syndrome, and control group consists of 22 people, matched for age and sex. All the patients do routine search methods, urinalysis, general analysis of blood, biochemical analysis of blood, electrocardiogram. Measurement of the daily monitoring of the central aortic pressure and arterial stiffness was performed using the oscillometric device BPLAB was attempts with the analysis of the main parameters of the central aortic pressure, systolic, diastolic blood pressure, hemodynamic pressure, pulse pressure, index augmentation, and amplification of pulse pressure, and the parameters of arterial stiffness, pulse wave velocity, arterial stiffness index, and TIM index. Vascular age was calculated using the score scale modified by De Agostino. The comorbid status and mortality prognosis of patient was assessed using the Charlson index according to a point system. The technique consists in a scoring system for assessing age and the presence of certain concomitant diseases, which are summed up in points corresponding to concomitant diseases, and 1 point is added for each decade of life when the patient exceeds the age of 40. In this table, we see that the patients of all study groups were comparable in age. In the group of arterial hypertension and subclinical hyperthyroidism, women predominated, unlike other groups. In groups of comorbid patients, body mass index and waist circumference were statistically significantly higher. There are also differences in the growth rates of patients in the studied groups, which will be taken into account in the statistical analysis of the data obtained. The studied groups were comparable in terms of the degree and duration of hypertension. According to laboratory analysis, we see statistically significant changes in lipid and carbohydrate metabolism in comorbid patients, this group of essential arterial hypertension with metabolic syndrome, and the group of arterial hypertension with subclinical hyperthyroidism. In addition, in the group of subclinical hyperthyroidism, the levels of the thyroid-stimulating hormone were significantly higher. In the studied groups of patients, including comorbid patients, there are differences in central aortic pressure during the day. Statistically significant differences were found between systolic and pulse blood pressure in the brachial artery and in the aorta, which corresponds to the literature data on this issue. The analysis of the average daily indicator of the central aortic pressure revealed statistically significantly higher indicators of systolic and diastolic pressure in the aorta, and statistically low augmentation index after adjusting for height in the study groups compared to the control group. This confirms the presence of arterial hypertension in the study groups. We made a correction for height since the BP lab with a TENS device takes into account the length of the aorta, which is directly related to the height of the patient when calculating. Similar changes we found during the day and night hours in all studied groups. Systolic, diastolic blood pressure, pulse pressure, and index augmentation are higher than in control group. In group of in the group of comorbid patients, arterial hypertension with metabolic syndrome and arterial hypertension with subclinical hyperthyroidism, significantly lower rates of pulse wave amplifications were revealed compared to control group. Intergroup differences were also revealed between the arterial hypertension with metabolic syndrome and arterial hypertension groups in the average daily and nighttime parameters of pulse wave amplification. We see that in group of arterial hypertension with metabolic syndrome, the pathological daily profile non-zipper prevalence, and in group of arterial hypertension with subclinical hyperthyroidism, the pathological daily profiles non-zippers and night pickers significantly prevailed compared to the group of isolated essential arterial hypertension, which is associated with a high risk of cardiovascular risk complications. Analysis of arterial stiffness reveals statistically significantly higher values of pulse wave velocity in the study groups compared to the control group. Significantly higher rates of arterial stiffness were found in the group of comorbid patients. In all the studied groups, statistically significantly higher indices of the augmentation index were noted compared to the control group. In group of arterial hypertension with subclinical hypothyroidism, statistically significantly high indices of arterial rigidity index were revealed at night, compared with control group, a group of patients with isolated essential arterial hypertension and group of arterial hypertension with metabolic syndrome, which prognostically increase the risk of coronary heart disease. In our study, we've also studied a new indicator of arterial stiffness, pulse time index of norm. The pulse time index of norm is percentage expression of the time of day during which the pulse wave velocity value didn't exceed the threshold of the accepted norm, 10 millimeters per second. In all the studied groups, statistically significantly pulse time index were noted compared to the control group. Significantly higher rates of pulse time index were found in the comorbid patients in groups of arterial hypertension with metabolic syndrome and in group of arterial hypertension with subclinical hypothyroidism. Vascular age indicators reflect the state of the vascular wall and depend on concomitant comorbid pathology. In group of essential arterial hypertension with metabolic syndrome, arterial hypertension with subclinical hypothyroidism, vascular age was statistically significantly higher compared to control group. And in group of arterial hypertension with subclinical hypothyroidism, vascular age was statistically significantly higher than chronological age. In this category of patients, a statistically significant noticeable direct correlation of vascular age with the comorbidity index was revealed. So conclusion, the analysis of daily indicators of central aortic pressure and arterial stiffness revealed the greatest pathological changes, indicating a deterioration in the elastic properties of atherus in the group of arterial hypertension and metabolic syndrome and arterial hypertension with subclinical hypertension groups. As the vascular age increases, the likelihood of developing cardiovascular complications increases, which is more pronounced in groups of comorbid patients, arterial hypertension with subclinical hypothyroidism and arterial hypertension with metabolic syndrome. The result of this work allows us to consider the prospect of using the indicator to assess the risk of developing and timely diagnosis of complications of hypertension, in particular in patients with comorbid pathology. Thanks. Any question?
Thank you, Dr. Endrova. That was an excellent presentation. Hope the participants have learned and benefited by sharing your view. Does anyone have a question?
Thank you. Any question? Are you ready?
Anyone have a question? Please write it down on the chat box.
You may write a question to chat.
Okay. Thank you, Dr. Endrova.
Mm-hmm.
And the next presentation, I would now like to invite Dr. Mohammad Zahran to give his presentation from Nasser Institute for Research and Treatment, Egypt. Welcome, Dr. Zahran. Can you hear me? Dr. Zahran. Dr. Zahran, can you hear me?
Yes, I heard you. I will. Hello?
Hello. Welcome.
Yes,
You
I hear you.
Speech.
I will share now.
Yeah, I can hear you.
Yes.
You can start your presentation.
I have a problem with sharing.
Please click on share screen in bottom of computer.
تمام. Can you see?
Yeah, I can see.
I am Dr. Muhammad Zahran, an emergency medicine specialist working at Nasser Institute for Research and Treatment Hospital. Introduction. Injuries to the thorax are the third most common injuries in trauma patients, next to injuries to the head and extremities. Thoracic traumatic injuries in general have a favorable outcome. There are many scores that were used to predict the morbidity and the mortality of thoracic trauma injuries. Injury severity score is one of the anatomical scores. It is mostly used in traumatized patients. Wagner score for pulmonary contusion focuses on one parameter only and does not parameters that can affect the mobility and of the patient. In 2000, Babe et al. Has developed a new score, thorax trauma severity score that combines patient age, anatomical and physiological parameters, partial pressure of oxygen divided by fraction of uninspired oxygen, pleural injuries, lung contusion injuries, and left fracture injuries to predict the morbidity and the mortality of thoracic trauma injuries. Review literature. Scores used in predicting the diagnosis of thoracic traumatic patients. Physiological scoring system. Hello.
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 I can't hear you.
Hello. Physiological scoring system, revised trauma score. Revised trauma score calculates the Glasgow coma score, respiratory rate, and systolic blood pressure. It is calculated by the summation of the values of these three parameters and multiplying them of their respective weights. As we see in this equation, anatomical scoring system, abbreviated injury scale, it represents the life-threatening condition accompanying the injury rather than describing the total assessment of the injury. The abbreviated injury scale is a measurement scale for single injuries. It is not globally proposed. Injury severity score, it is a means to define a major trauma, polytrauma. Injury severity score is calculated by summing the square of abbreviated injury scale of the three most severe injured regions in the body. The maximum value of injury severity score is 75, as the maximum value of abbreviated injury scale is 5. Injury severity score considers the single most serious injury in each region, ignoring the contribution of the injuries to the other regions within the same. Source and the trauma injury severity score as outcome equals the anatomical injury plus the physiological injury plus the patient physiological reserve. Trauma and injury severity score was developed to overcome the disadvantage of injury severity score. It combines the age of the patient that could affect the physiological reserve of the patient, injury severity score that represents the anatomical injury of the patient, revised trauma score that represents the physiological injury of the patient and considers the mode of trauma, blunt or penetrating. Trauma injury severity score is expressed by the probability of the survival, as we see in this equation. The trauma severity score, since the trauma and the injury severity score wasn't developed for isolated thorax trauma, over this thorax trauma and injury severity score is difficult to calculate in emergency room. To overcome this difficulties, AL has developed a new score to predict the outcome of thoracic trauma patients. It combines the age of the patient that could affect the physiological reserve of the patient, anatomical parameters, and physiological parameters, providing a simple, reliable solution to the problem of early CT independent judgment of thoracic trauma. Thorax trauma severity score is a simple tool that can be calculated easily and can be applied in emergency room. As we see, thorax trauma severity score is composed of 5 parameters: partial pressure of oxygen divided by fraction of inspired oxygen, rib fractures injuries, lung contusion injuries, pleural injuries, and the age. Minimum value of thorax trauma severity score is 0 point, and the maximum value is 25 point. Aim of the work: evaluation of thorax trauma severity score in predicting the prognosis of thoracic trauma patients. Patient and method. Our study was carried out upon 300 patients of traumatic chest injuries in emergency department. The inclusion criteria was adult patients above the age of 18 years old. The exclusion criteria was chronic respiratory diseases, pregnancy, malignancy, and organ failure, associated mediastinal injuries, severe abdominal and pelvic injuries, and brain injuries with Glasgow Coma scale below 13. History, clinical examination, laboratory investigation, random blood sugar, complete blood pressure, and arterial blood gases, routine radiological investigation, chest X-ray, chest computed topography, electrocardiogram, echocardiography to assess cardiac injury suspected. According to advanced trauma life support, management consists of a rapid primary survey, resuscitation of vital signs, and a more delayed survey, and finally, initiation of definitive care. Progression highlighted in this item: normal equals towards admission up to 7 with pneumothorax or hemothorax managed by simple thoracostomy. Fair prognosis equals inpatient to admission more than 7 days. Pneumothorax with persistent early. Pneumothorax needs open thoracotomy. Pneumonia, ICU admission not needing mechanical ventilation. Poor prognosis equals ICU admission needing mechanical ventilation. Fatal equals this. Results: we distributed the patient outcome according to vital signs, systolic blood pressure, and respiratory rate, and the heart rate. We find that respiratory rate showed a significant statistical difference in the outcome of the patient. All fatalities were in the range of above 20 breaths per minute, and all early discharged patients were of 12 to 22 breaths per minute, a significant p-value. All patients that were with heart rate below 100 beats per minute were discharged with heart rate above 100 beats per minute. There was an increase in the morbidity and the mortality with a significant p-value. Patient according to patients were discharged and 80 patients were admitted to work. They fall from 10 Hello?
Dr. Zaha.
Hello?
Hello.
I'm sorry.
Yeah.
I
You
will
can
complete.
continue.
I will complete. A patient with a thorax trauma severity score of 11, between 11 and 15, 8 patients were admitted to admission to and 16 patients were admitted to ICU. Sorry. Hello?
Dr. Zaha.
I
Can you hear?
am here, but there is a problem with Zoom. I will share again.
Okay, no problem. Please continue with the speech.
Yes, thank you. Patient with thorax trauma severity score of 16 to 20 score. 20 patients were admitted to ICU and 4 patients were died in ER room. A patient with a score of 21 to 25 score, 12 patients were died in ICU and 12 patients died in ER room. Correlation between score and the duration of mechanical ventilation, as we see, there is with hello, hello, hello,
Hello.
hello.
You
I
can
am sorry, there is a problem.
I can hear you.
Thank you. I will complete.
Yeah. I can hear you completely.
There is a message when I share, only the host can share in this meeting.
You can click on in share screen in the middle of button in computer screen.
Okay. A correlation between the score and the duration of mechanical ventilation. As we see increasing score, there is an increase in the duration of mechanical ventilation. Correlation between the score and the long of stay in ICU. With increase in score, there is an increase in the long of the stay in ICU with a significant p value. Rock curve. Rock curve showing that a score above 7 point has a sensitivity 100 to fair and poor and fatal prognosis, and specificity 97.73% to good and normal prognosis, with 96.88 positive predictive value and 100% negative predictive value. Discussion. Our studies showed that thoracic trauma value of 7 point or above point have 100 sensitivity and 97.73% specificity to morbidity and mortality of patients of isolated thoracic trauma after exclusion of associated severe extrathoracic injuries. This result includes LB and the co-worker who found that thoracic trauma severity score of 7 point or above was 100 sensitive and 100 specific to poor prognosis. Similarly, NABI and associates found that thoracic trauma severity score value of 8 or above have a sensitivity of 92.3% and a specificity of 100% in the prediction of poor outcome and mortality. In our study, the area under the curve was 0.98, showing that thoracic trauma severity score has a strong predictive value for morbidity and mortality. In a study of Hildenbrand and associates, they found that thoracic trauma severity score has had the best predictive value in comparison to CT-dependent Wagner score for pulmonary contusion and CT independent scoring system. Limitation of the study. Filial chest, either a small or large size segment in chest fracture parameter. In thoracic trauma severity score had a score of 5 points. However, a small size filial segment can be managed with conservative treatment. Fracture of the first and second ribs are indicative of severe trauma, despite that they take 1 point on thoracic trauma severity score. Conclusion. Thoracic trauma severity score of 3 to 6 points. Patient should be observed in patient with thoracic trauma severity score of 7 or patient may need observation in ICU or fear of needing mechanical ventilation, and there is increasing probability of developing ARDS. Thoracic trauma severity score of 20 or above, patient has a fetal prognosis and needs a prolonged duration of mechanical ventilation. Thank you.
Thank you, Dr. Zahran. That was an excellent presentation. Hope the participants have learned and benefited by sharing your view. If you don't have any question, please write it down on the chat box. No one have comments? Okay, thank you, Dr. Zahran. And the next speaker, I would now like to invite Dr. Taimar Eitat to give his presentation from Tel Aviv Sourasky Medical Center, Israel. Welcome, Dr. Aitat.
Can you hear me now? Is it okay?
Yeah.
Okay. Great. Thank you very much. Okay. Hi. So my name is Tamar, and I'm a medical resident at the cardiology department of Tel Aviv Sourasky Medical Center in Israel. And I will be presenting my work on prognostic implication of tricuspid regurgitation in STEMI patient. So this is my, it's not moving, I'm sorry. This is my declaration form and I have nothing to declare upon. So I just wanna go back to a little bit of history, the background of tricuspid regurgitation. So in the past, but not too many years ago, we used to believe that tricuspid regurgitation is an innocent bystander. As one can see, the paper of Nina Brownwald in American Thoracic Surgery in 1967 on conservative management of tricuspid regurgitation patient undergoing mitral valve repair, which he conclude one can easily ignore tricuspid insufficiency when fixing the left-sided valve because it always goes away spontaneously. And that at the time, that was the common belief that tricuspid insufficiency is a benign condition that doesn't require any treatment. But then in the past 20 years, there's a growing numbers of work showing us quite the opposite, and that tricuspid insufficiency is not so benign as once thought to be. As we can see in the opinion article in 2010, the title was The Forgotten Valve, Lesson to be Learned in Tricuspid Regurgitation, which summarized a few important work at the time, up to that time. And I will present shortly one of them. So in 2004, Nets and al. Presented his work on impact of tricuspid regurgitation on long-time survival. This is a retrospective work on more than 5,000 patients, graded by the TR severity, and it followed them up to 4 years. And then what they saw, that according to the severity of TR, the survival was worse if you have moderate or above tricuspid regurgitation. And it was not, if we adjust it to LV dysfunction, RV dysfunction, age, SPEP, and so on, the survival still was worse for patients with moderate to severe TR than those with mild or no TR. Another work from my department in 2020 for a bigger cohort, more than 30,000 patients, again, divided by the severity of tricuspid regurgitation. The follow-up time was 5 years. And we see more or less the same result. Patients with moderate to severe TR have worse outcome. They suffer from more heart failure, more readmission. The 30 days mortality is higher than 1 year, and overall mortality is a lot higher than people with no TR. So I think for now we can agree that tricuspid regurgitation is not an innocent bystander, nor is not a benign condition. But now we ask ourselves, okay, so what is the prevalence in the population of tricuspid regurgitation? How common is it? Then if we look at the Framingham study, which I assume most of us are familiar with, wide population study for a long period of years following this population. And in this paper, they present the valve disease prevalence. If we look specifically on tricuspid regurgitation, then we see that up to 80% of the population suffer from any severity of TR. But then we ask ourselves, okay, so how many suffering from clinical important TR, which is moderate and above? And if we look with increasing age, the prevalence of moderate and severe TR reached to, here we see up to 1.5% in men, this is the men table, and 5.6% in women, which show us it's not uncommon disease. And then another work by Tupilsky et al. In 2019, again, following a certain population in the Olmos County. And what he shows us here in the graph that if you follow this population and with age, the prevalence is rising. But also if you look on patients with other valve disease, such as aortic stenosis, mitral stenosis, AR and MR, then the prevalence of TR is even higher. And then in this another work that he presented with the title "Tricuspid regurgitation is a public health crisis." What he says that moderate to severe TR affects more than 1.6 million people in the US and about 3 million people in Europe. The problem is that we diagnose TR late because right ventricle can tolerate volume overload for many years. So people can be asymptomatic for a while at the presentation time, usually the severe is clinically important. And also we have long sensitivity for diagnosis with auscultation. So the main way we can diagnose it's with echo, but we do know that there's a wide underdiagnosis of valvular disease. So the number I just presented are probably much higher in the real life. And if we look at people that suffering from severe TR, how many of them are treated with surgical therapy, then we see that only 5% are going through repair or replacement. So what we can say that TR is definitely a common problem, health crisis problem, and most of the people are underdiagnosed as well undertreated. So just go briefly of etiology to tricuspid regurgitation. We usually divide it to two main groups. So the first one is the functional TR, which means that the TR is secondary to another etiology. If it's the left-sided heart valve, the pulmonary hypertension, either right ventricular dysfunction, and so on. And this is the main group. More than 90% of the patient will be functional TR. The other one is primary TR, and that's due to congenital disease or due to infection or endocarditis, as we can see here. Also flail or coaptation of the leaflet. People suffering from carcinoid, people who went through chest radiation, and people with pacemaker. This is important in etiology because we always need to remember once we implemented a pacemaker lead in the right ventricle, then TR is something we need to consider and we need to look for. So a lot of questions arise whether the worst outcome for tricuspid regurgitation patient is due to the main etiology causing functional TR, and that whether people with only isolated tricuspid regurgitation are not suffering from the same prognosis. So Tupinsky again show in 2014 that people with isolated tricuspid regurgitation with no other valve or heart disease, if we follow them for several years, here we can see that people with severe TR are suffering from lower survival rate and higher cardiac event. Therefore, their prognosis is not good or better than people with functional TR. All of that led us to ask ourselves, okay, so we do know that tricuspid regurgitation is something we need to consider, but what is the prognostic implication of tricuspid regurgitation in STEMI patients? So in the present study, we investigated the clinical profile, in-hospital outcome, and long-term mortality associated with the presence of TR in STEMI patients treated with primary PCI. This is a retrospective single-center observational study for 2,139 STEMI patients admitted between September 2011 and May 2016. We excluded patients with missing records of tricuspid valve echocardiographic evaluation, as well patients with previous MI or previous TR, which was already known about. And therefore, the final cohort consists of 1,071 patients. The mean age was 61, and 80% were male. What we did is patient presented with STEMI went through primary PCI if the patient were with symptoms up to 12 hours or up to 24 hours if they were still symptomatic. All patients went a screening echo examination within 6 to 72 hours. TR severity was determined using the American Society Echocardiography recommendation, as we see in this table, but I'm not gonna go over it. And in our study, we had 32 patients diagnosed with moderate to severe TR, while the rest, 1,039, were diagnosed with either mild or no TR. And this is the baseline characteristic in this table. And we do see that patients with moderate to severe TR were significantly older, as well, more female gender, suffered from more hypertension and had lower kidney function. But the rest of the baseline characteristics were not significantly different. If we look at the echo parameters, then we see that it's mostly different. So if we look at the moderate to severe TR, then those patients significantly had worse echocardiographic parameters. They had lower ejection fraction, they had higher septal E prime, they had enlarged right atrium size, they suffered from higher S-pipe, but I do like to mention that there was no significant difference in TAPSE. If we look at the in-hospital outcome, then patients with moderate to severe TR had higher 30 mortality rate. If we see here, it's 12.5% compared to only 2% with patients with no or mild TR. They also suffer from more acute kidney injury. They needed more hemodynamic support or mechanical ventilation. They had more heart failure and arrhythmia and major bleeding. Okay, if we want to look at the long-term outcome, then we follow this patient for mean period of 2.5 years. In the entire cohort, 6.6% of the patient died, but mortality was significantly higher among patients with moderate to severe TR, 28%, compared to patients with no or mild TR, only 6% of this group died. And that was, of course, statistically significant. So looking at this result, we ask ourselves whether the difference between the two groups was due to the difference in baseline or echocardiographic parameters. So what we did is a multivariate Cox hazard analysis, and we adjusted for significant clinical and echocardiographic parameters. And mortality hazard ratio of moderate to severe TR still remains significant after adjustment. So we think we can conclude that moderate to severe TR can serve as a prognostic marker in STEMI patient, but we do have to bear in our mind a few limitations of the study. Once it was single center retrospective and non-randomized observational study, the moderate to severe TR group was small, patients were significantly older, female gender, and with lower kidney function. And also, we only included patients with first MI with no previous TR, and therefore we cannot generalize our result to all STEMI patients with tricuspid regurgitation. So to conclude, I think that now we can say that the tricuspid regurgitation is not forgotten anymore, but not forgiven. TR adversely affect prognosis, and among STEMI patients, moderate to severe TR can serve as possible prognostic marker. To our knowledge, this is the first report to data suggesting a possible prognostic implication of TR in STEMI patients. I do want to thank you all for listening, and if I would like to use the remaining time for questions.
Thank you, Dr. Etat. That was an excellent presentation. Hope the participants have learned and benefited by sharing your view. Does anyone have a question? Okay. Thank you, Dr. Etat. Now, I would like to invite Dr. Rima Chada to give her presentation from Lebanese University, Lebanon. Hello, Dr. Chada.
Hello.
Hello. Welcome to our Congress.
And I want to share my screen also. So, can you hear me?
Yeah, I can.
Okay, good afternoon, everyone. Let me start my presentation with this picture. Many among you can see one face in this illustration, and the others can see two. Have you ever had too much to drink and thought you are seeing two of your best friends? Well, I will confess something. I felt I was seeing two of things more rare than a best friend. I'm Rima Shaddad, a cardiology fellow at Lebanese University, and I'm here to tell you the baffling story of our patient, Mrs. S.G., who gave me double vision. Or did she? Today, I will be presenting each and every one of you the opportunity of trailblazing, of solving a mystery, and even better, a really rare one of those. I hope you are now interested in the story I'm about to share with you. So here we go through this rare case of congenital heart disease. Mrs. S.G., a 46-year-old woman with irrelevant past medical history, presented with intermittent chest pain, palpitation, and shortness of breath on moderate exertion. Her physical exam, including heart sounds, was normal. Her vital signs also were within normal limits. Her EKG showed a sinus regular beat without obvious ischemic changes. So we performed an echocardiogram, and this is the parasternal long axis view, as you can see here, showed a structure that is parallel to the septum with colored Doppler flow in between. This pattern could be due to abnormal insertion of papillary muscle or something else. We'll see. So this is a short video of the same parasternal long axis view with a colored Doppler flow as shown below between the septum and the other parallel structure. Another views, the video on the top is the parasternal short axis view of the heart, showing the same structure that is all the time accompanying the septum and sharing the same echogenicity. Below, the apical 4 and the apical 2 chamber view. Then we proceed to other imaging modality, which is the cardiac MRI. So the cardiac MRI showed features of LV non-compaction, and the diagnosis is now clear of the ventricular septal duplication without any ventricular septal defect or any associated thrombus. And this is also a short video showing it clearly in action. Our patient may be the first case in the literature diagnosed with a double septum. The echo may be not sufficient all the time. More additional imaging modalities are also needed to make a clear diagnosis. So what about embryology? The interventricular septum is the anatomic structure that divides the right and the left ventricle. The formation of the interventricular septum starts around the 5th week of embryonic development. During the expansion of the primitive right and left ventricles and the addition of migrating myocardial cells, a muscular interventricular septum forms from the primary fold or ring that partially separates the ventricle. By growing from the apex to where the atrioventricular endocardial cushions, the muscular interventricular septum is formed. Any defect in this embryonic phase can result in many congenital anomalies. The duplication of the septum is the rarest one. What about differential diagnosis of this case? So it could be a duplication of interventricular septum, could be also an accessory papillary muscle, or a moderator vent. And because of that, I went through the literature and I found a really rare case, same to ours, in which a duplication of the interventricular septum here was associated with a double orifice mitral valve, where the diagnosis is made also with a cardiac MRI. A mimicry of our case, also published in the European Heart Journal, with an apically displaced anterolateral papillary muscle, where the base of the papillary muscle is located at the apical 1/3 of the LV, as you can see here. So back to our patient, Mrs. SG was started on beta blockers, and follow-up visit after 1 month, she was nearly asymptomatic. Our case also was published in the Journal of Medical Case Reports. I'm very grateful to have had the chance to discuss my case with an audience equipped with such a wide fan of experience. I hope I shed enough of the light deserving of this case. And I shall finish with the verse of Paul Vincent Cannon, 2 hearts are better than eyes. Thank you. If you have any question, you can contact me through my mail. Thank you.
Thank you, Dr. Shadat. That was an excellent presentation. Hope the participants have learned and benefited by sharing your view.
Thank you.
Okay, thank you, Dr. Shadat. And the next speaker, I now welcome to Angela Zeda.
Zeda.
I'm sorry.
Tutto bene. I'm trying to share my monitor. Okay. Okay. Can I share my presentation?
Yeah. Okay.
Okay. One moment, please. Oh. Okay, can you hear me?
Yeah, yeah.
Perfect. So thank you. Hello, everyone. Thank you for the invitation and for joining me. I'm Angela Zeda, a consultant from the University Heart Center in Dresden, in Germany. And today I'm talking about the left atrial isolation plus appendage occlusion, a novel ablation strategy for the patient with atrial fibrillation and end-stage left atrial fibrotic disease. I have nothing to declare. And I will start, one moment. I will start with a clinical case. Here I present a 79-year-old man with a highly symptomatic persistent atrial fibrillation that already underwent a PVI and substrate modification a few years earlier. Nevertheless, he experienced atrial fibrillation recurrences despite another treatment. So he presented in our department with a willingness to another ablation attempt. As in this case, we perform in every, oh, one moment, please. Okay, there's something wrong. Okay. Sorry. Okay, perfect. As in this case, we perform in every ablation for atrial fibrillation a 3D voltage map with the 3D mapping systems. And here are depicted the 3D reconstruction of the left atrial of these patients. And there are extensive low voltage areas colored in gray, representing a fibrotic disrupted myocardium. So this patient had an advanced fibrotic left atrial cardiomyopathy. We know from the previous studies that atrial fibrosis plays an important role in the genesis of atrial fibrillation through different mechanisms, not yet fully understood. But we know that it promotes micro-reentry, local automaticity that trigger and maintain atrial fibrillation. And we also know that there is a correlation between the reduced electrogram amplitudes recorded during the invasive voltage maps and left atrial fibrosis that we can see in histological studies. So what we also know is that the extent of low voltage zone is an independent risk factor for atrial fibrillation, also after a PVI alone. So in this patient, what can we do to obtain a better outcome? As we can see from the study of the Leipzig group, adding to the MER PVI substrate modification could result in a better outcome in terms of AF recurrences in the midterm. But what is the substrate modification? Here I have listed the main procedure that we perform in our center. That is that we can, the goal of these strategies are always the same. That is isolate, confine the low voltage zone from the healthy myocardium of the left atrium. And this is achievable through a local regional ablation or through linear ablation lines between anatomical obstacles to isolate these low voltage zones. So, and unfortunately, we know that a very important detail of this substrate modification is how extensive are these low voltage areas. Yamaguchi in 2018 well described this problem. Patients that had more than 30% of low voltage zone in the left atrium had a very poor outcome in comparison to patients that had smaller areas. So what can we do in these patients if also low voltage zone modification could not help besides the PVI ablation? For example, in this patient, if we have to think about a substrate modification, we have to deploy different ablation lines with extensive ablation, and this could be challenged without compromising the left atrial systolic transport function, as well as diastolic function, and of course the thromboembolic risk of this patient. An alternative already existed in the 90s. Emerged a few small studies of an attempt of surgical cut of the left atrium from the right atrium with a good outcome in terms of recurrences. And this was an attempt only for atrial fibrillation, not only for atrial fibrillation, but also for supraventricular tachycardia, mostly accessory pathway. But the outcomes result in a lower rate of recurrences. So we decided to attempt this strategy percutaneously. We try on a left atrial isolation, and we tested whether this strategy followed by the left atrial appendage occlusion could result in better outcome in terms of control of the rhythm and control of the thromboembolic risk. In the next part of the presentation, I would like to focus on three main topics: how to achieve a left atrial isolation, how to manage the stroke risk, the thromboembolic risk in this patient, and the hemodynamic changes that could be after the left atrial isolation. The first point, the ablation strategy. As we can see here below, we have the main interatrial connections between the right and the left atrium. The Bachmann's bundle is the main pathway for the activation of the left atrium, but we also have connection in the coronary sinus and around the fossa valis in the septum. So we try with our ablation strategy, with our ablation technique, to disconnect the left atrium from the right atrium through mainly two lines. An anterior line, including the Bachmann bundles, from the right superior pulmonary vein to the mitral annulus, and if needed, we can also deploy the line from an epicardial access. and then also a paraseptal line from the right inferior pulmonary vein to the mitral annulus. In this case, is also needed an ablation from the right side in and around the coronary sinus. In some patients, it also needed a right pulmonary vein isolation or re-isolation if was already done. What can we expect from a left atrial isolation is a dissociation between the right and the left atrial signals. In this figure, we have an ablation, and we can see that the left atrial signals indicated by the blue arrows gradually split from the right atrial signals indicated from the yellow arrows. After isolation in the left atrium, we can see a complete asystole, a slow rate intrinsic rhythm, as well as atrial fibrillation, atrial flutter, while in the right atrium, a sinus rhythm is maintained. From the second point, the stroke risk management is always a very important point, and implies a very high concern for this patient, because we have an atrial standstill besides a fibrotic atrial myopathy. So in all these patients is a left atrial appendage occlusion mandatory. If the occlusion is not performed during the ablation procedure, a triple therapy or at least dual therapy according to the bleeding risk is could be safe and efficient as bridge to the left atrial appendage occlusion. In our center, we tested the very first 92 patients that received this new ablation technique. We conducted a prospective non-randomized study between February 2016 and February 2020. We enrolled patients with highly symptomatic paroxysmal or persistent atrial fibrillation or left atrial tachycardia, and that with previously ineffective antiarrhythmic drug, that demonstrated in the voltage map more than 3 regions affected from fibrosis, with a mandatory involvement of the anterior and paraseptal regions. Our endpoints were freedom from atrial arrhythmia without and with antiarrhythmic drugs in the follow-up checks, and of course also complication rate, procedural data, and then the clinical endpoints such as NIA and NIRA classes. Here depicted the baseline patient's characteristic. As we expected, the mean age were older at normal atrial fibrillation patients, 71 years old, mostly female gender, and mostly with persistent atrial fibrillation. As we can see, we can also have a population. We had also a population with a high thromboembolic risk. Chadva score medium was 4, and highly symptomatic. ERA score medium 3. Then here I reported the main bipolar voltage map characteristics. To analyze the voltage map, we divided the left atrium in 5 main regions: the anterior, posterior, lateral, inferior, septal wall, and every region was further divided in 9 segments. And as we can see, on average, the percentage of low voltage zone was more than 40% in the left atrium, with a major involvement of the anterior, septal, and posterior wall. The rhythm outcome demonstrated that our technique was efficient. At 12 months follow-up, we observed that 78% of the patients were free from other recurrences, left atrial fibrillation recurrences without antiarrhythmic drugs. We have also a good follow-up with an implanted devices in more than 80% of the patients, and only in 12 patients we have to perform a redo of the CS, mostly because of reconnection. From the clinical point of view, we observed also an improvement of the symptoms immediately after the left atrial isolation, as well as the follow-up check. And from here, the picture also the complication rate that also were relatively low. A stroke was occurred in the pilot phase of this study. The patient was not on triple therapy and was between the left atrial isolation and the left atrial appendage occlusion. So after this event, after the patient number 3, we decided to establish in every patient a triple therapy until the left atrial appendage occlusion. And we check also the hemodynamic changes after the left atrial isolation. Previous study demonstrated that after extensive left atrial ablation and in the presence of atrial cardiomyopathy, the diastolic function as well as systolic function of the left atrium could be affected, the so-called stiff left atrial syndrome. So we checked over this problem was an issue also in these patients. We analyzed the first 20 patients with an invasive measures during the procedure, and after that also at the left atrial appendage occlusion procedure, the right atrial pulmonary artery and left atrial pressure, but we didn't demonstrated significant changes after the ablation. So in conclusion, we demonstrated that the isolation of the left atrium percutaneously is feasible, as be done by surgeons, so can be done as also by us, and it offers an effective treatment option alternative as a substrate ablation and also a patient ablate strategy in patients with an end-stage fibrotic atrial disease. Of course, the thromboembolic risk remain one of the major issue, and left atrial appendage occlusion is mandatory with a double, triple anti-thrombotic treatment if necessary as bridging therapy. Thank you for your attention. If you have any comments or question, I'll be here. I'll be happy to hear them.
Thank you, Dr. Zeda. That was an excellent presentation. Hope the participants have learned and benefited by sharing research work. Dear audience, does anyone have a question for Dr. Zeda? Please write it down on the chat box. Okay, thank you, Dr. Zeda again.
Thank you, thank you.
And now I would like to invite Dr. Ernst Kavala to give his presentation from the University Medical Center of Ljubljana, Slovenia.
Hello, can I share the screen?
Yeah.
Can you see my presentation?
Yeah, I can.
Okay. My name is Urška Hvala. I come from Slovenia, and I work in University Medical Center of Ljubljana. So today I represent a short study we titled Knowledge of Atherosclerosis and Risk Factors with patients, between patients with peripheral and coronary artery disease. I have nothing to declare. So we start. Cardiovascular disease are a major global health problem and the leading cause of death in the world. Most cardiac events in adults occur to those who do not even know they have cardiovascular disease. So finding highly at-risk individuals for developing cardiovascular disease at an early stage is very important. Knowledge of cardiovascular disease has been found to be very poor, especially among the population over the age of 75, among those of lower socioeconomic status, poorer education, and among ethnic minorities. Peripheral artery disease occur because of the same factors as the narrowing of the coronary arteries, with the differences that it affect the peripheral arteries most often on the lower extremities. Disease is still diagnosed too late in developed countries, although it affects a fifth of the population over the age of 55. PID is one of the most common consequences of atherosclerosis. Coronary heart disease occur when the coronary artery narrow. Coronary artery occlusion can cause cardiac arrest. The patients lose consciousness and shows no signs of life. So we got acute coronary syndrome. So the health education of patients with PID and TID at high risk of developing cardiovascular disease should be a priority of cardiovascular disease is growing worldwide. So the proposed study was to identify differences in knowledge about risk factors for cardiovascular disease between patients with PID and CID, ways of obtaining information in patients with PID. So I put some research hypotheses. So the first one was that the patients with PID are less familiar with atherosclerosis compared to patients with CID. The second one was patients with PID are less familiar with risk factors for atherosclerosis compared to patients with CID. The third one was especially for my work, important for my work, because I do the education with these patients with peripheral arterial disease. So I put that third hypothesis, that 80% of patients with PID received information about the disease from healthcare professionals. Use the descriptive method with cross-sectional study. Measuring instrument was a survey questionnaire, which was complete based on the questionnaire for assessment of knowledge about coronary heart disease, KTQ, and assessment of knowledge of patients with heart failure. So there are two articles from that questionnaires. So the final version of that instrument had 41 questions divided into 4 sections about diet, treatment methods, physical exercises, and risk factors for atherosclerosis. And in the last part, patient with peripheral arterial disease had a 5th section with a question about the source of information about that disease. The question was found to be internal consistent, so we do the that with Cronbach alpha coefficient, and was calculated to be 0.85. So we we know that the questionnaire was internal consistent. The population consists of 47 patients with peripheral arterial disease who come to the hospital for elective treatment, and 46 patients with coronary heart disease who come to the outpatient clinic for rehabilitation after the coronary events. Both patients are in our wards, so I do with the education with both of them. So the result was the knowledge of patients with PID was significantly better than the knowledge of patients with TID by an average 4.65. And why happened this? Don't happen. So I found identify relevant studies. So in the first study, done by Greco in 2016, in that study, they looked at the need to obtain information about the disease of patients with acute myocardial infarct in the post-hospital period between 2 and 8 weeks and 6, 12, and 24 months after discharge from hospital. The result shows a marked reduction in the need for information 2 weeks after discharging from the hospital. So we have the same problems also in our hospital. So that's the marked problem. In the another study connected to Duma in 2012, I found that the desire to obtain information decreased over time relative to the reduction of disease symptoms and the experience gained with overcoming the disease. And a third study showed the time between first and the second rehabilitation phase can vary in lag due to orders. So the role of the nurse before discharging a patient to home care is crucial for patient health education. Many studies suggest that before discharging patients from the hospital, the focus should be on health education. Practice health education practice that affect on lifestyle, but most hospitals focus only on taking medication after discharge. How that sits in our hospital the same. We don't have a time to talk with the patient, to have a time to realize what do at home, what he have to change. So we just put some brochure or explain them how to take the medicine. That is real. Now in the COVID, it's show more that problems show more is really a problem. We found that between 45% and 77% of PID patients receive information about their disease from healthcare staff, albeit to a lesser extent than expected, but it's enough for me. Because in the table you can see that the 62% of patients they receive the information from health professional, 40% from computer, and 41% from books and brochures. So we do some good jobs there. And the same results were obtained by Greco et al. In 2006, who found that the first source of information were specialist doctors and personal physicians. They also showed reduced need to seek information to take care of daily activities, behavioral habits, or to take care of disease complications and risk of disease recurrence. In another study, do one on 2016, this was what I found. The use of modern technology can also diversity learning, a study to determine to knowledge of patient with PID about their disease and treatment, found that the use of different learning methods and modern technology in the health education of patients with PID strongly influence patient motivation to learn. So this opened a new field and questions about how much modern technology helps us and what effect it has on improving patient with empowering patients with PID and CID. So in the conclusion, in the study, we demonstrated better knowledge of patients with peripheral arterial disease and poorer knowledge of patients with coronary arterial disease about atherosclerosis and risk factors for atherosclerosis. The work of the nurse for the health education of patients with PID and CID has proven through research as needed and key to improving patients. So we must formalize the process of health education of patients with PID and CID. The position of a nurse is required for the health education of patients with PID and CID. New learning methods are needed, such as learning backwards. We tried to put that last year in our education process, but now we are still in brochure because of COVID and, and that problem. Preparation of website which contain about peripheral and coronary heart disease. So this tool can be used in clinical settings to measure the effectiveness of health education for patients with peripheral and coronary artery disease. Thank you for your attention, and I'm waiting for your comments or questions.
Thank you, Dr. Wala. That was an excellent presentation. Hope the participants have learned and benefited by sharing research work. Does anyone have a question? Please write it down in the chat box. Okay, thank you again, Dr. Wala.
Thank you. Goodbye.
Goodbye. And now I welcome to Dr. Nanani Karima to give her presentation from University Hospital Center IBN Roche of Casablanca, Morocco. Dr. Karima, can you hear me?
Hi, everyone.
Hi.
I'm just going to share.
Okay.
So I hope that you can see my slides.
Yeah, I can see.
Yes, great. So we're gonna start now. So my dear audience, I'm so glad to reach this International Congress of Cardiology through this webinar, even if I'm a little bit sad because I cannot meet you all because of the sanitary restrictions. And I would like to thank a lot Gabriela and her team for this incredible work and organization. So today I'm going to do a quick presentation about this unclear syndrome, which is the Takotsubo syndrome in the postpartum, used in a case we had this year in our obstetrical unit. So first of all, we're going to start with an introduction. We will give a small definition of the Takotsubo syndrome. So the Takotsubo syndrome it was introduced by Sato and Dodds in 1991 and 1990 to describe the left ventricular silhouette during the systole. Its physiology remains unclear and the management is relatively unknown. And epidemiologically, this pathology occurs preferentially in women in the immediate aftermath of an intense mental or physical stress. So to discuss more this cardiac condition, we report the case of a 46-year-old patient who had 6 infants living vaginally. She had no cardiovascular risk factors and no particular pathological history other than a myomectomy in 2020. And she was pregnant at the 35 weeks of amenorrhea. And she was admitted to our maternity unit in a non-reassuring fetal state associated with severe anemia. When we talk about her physical examination, our patient were conscious. She had a cardiac frequency about 120 beats per minute. She had normal blood pressure and she had polypnea at 25 cycles per minute. At the gynecological obstetric examination, the uterus was relaxed, she had no bleeding, and the cervix was dilated at 1 centimeter. But the fetal cardiac activity was present, but he had severe fetal bradycardia at 42 beats per minute. So we rushed our patient to the operating room for a fetal extraction by C-section under a spinal anesthesia. So in the operating room, after the spinal anesthesia, the C-section gave birth of a newborn male who had an Apgar score 0 out of 10 and with no cardiac activity, even after the resuscitation procedures. On the exploration, we found a posterior phandic rupture of 4 centimeters associated with the pneumoperitoneum. As we can see in this picture, it was a posterior phandic rupture, and this posterior phandic rupture were responsible of hemodynamic instability, and we had to introduce our patient the noradrenaline, and we did a transfusion of 2 red blood cells. Then the patient was transferred to the obstetrical intensive care unit. But at the second day at the intensive care unit, our patient presented a sudden onset chest pain radiating to the neck and left upper limb with arrhythmias. These arrhythmias was particularly marked by bigeminal extrasystole, as you can see in this picture, and an attack of ventricular tachycardia. Then we made an electrocardiogram objectifying nesty segment elevation in the anteroseptoapical and inferior segments. We did even a blood analysis objectifying an elevation of the troponins about 40,585, and we did the transthoracic heart echo too, where we objected an hypokinesia about the left ventricular in the anteroseptal and inferoseptal walls. After all, the patient underwent a coronary angiography for the suspicion of the NSTEMI, which returned normal. As we can say, the common trunk is of normal length without stenosis. The anterior interventricular artery is medium in size and free from significant lesions in all the 3 segments. And the circumflex artery is of all normal size dominant without stenosis. And the right coronary artery is dominated small in size and free from any significant damage. 2 weeks later, the electrocardiogram returned normal, and the echocardiogram showed a complete recovery of the left ventricular systolic and diastolic functions. So, the Takotsubo syndrome is an acquired cardiomyopathy with transient and reversible left ventricle dysfunction that can mimic acute coronary syndrome, and that was the case of our patient. But we should know that the Takotsubo syndrome in the postpartum is a different clinical entity from the peripartum cardiomyopathy, or what we call the Meadows cardiomyopathy. When we talk about the diagnosis of the Takotsubo syndrome, is based on the Mayo Clinic diagnostic criteria. It includes the presence of transition akinesia, hypokinesia, or dyskinesia of the left ventricular with or without apical involvement. This regional defects in ventricular wall movement extends beyond a single epicardial vascular perfusion territory. Additionally, there is no obstructive coronary artery disease or angiographic evidence of acute rupture of a plaque. The patient might also have ECG abnormalities, such as an ST segment elevation with or without a T-wave inversion or moderately elevated cardiac troponin levels. Our patient had transient electrocardiogram abnormalities and no angiographic coronary evidence of acute plaque rupture or vessel occlusion, meeting the Mayer criteria for the Takotsubo cardiomyopathy syndrome. When we talk about the etiology and the pathophysiology, it remains uncertain, but it seems that the sympathetic system appears to play a central role because when we have an emotional or a physical stress, it will be responsible of a sympathetic system activation, which will give a catecholamine abnormal release, then a cyclic calcium overload mediated by the NPM, which will be responsible of a microvascular dysfunction and the cardiotoxicity given our Takotsubo syndrome. So when we talk about the emotional stress and the depression, the presence of the depression in this type of pathology, as we know the Takotsubo syndrome, has been reported in several studies. As we can say, at the study that have been done by VD, 21% of patients present with a depressive or anxiety disorder, this factor being more present than other cardiovascular risk factors, such as smoking or diabetes. And there is a study that has been done by Mood. They found a prevalence of depression and anxiety disorder of 40% in 110 patients with levels of catecholamine, especially norepinephrine in depressed patients. But regarding our patient, she presents several factors explaining the occurrence of the Takotsubo syndrome. First of all, she had presented in hemorrhagic shock following the uterine rupture, causing an hemodynamic instability and the massive involvement of the adrenergic system. The second factor is the vulnerability of the patient in the absence of an emotional expression, especially the difficulty of adapting the neonatal death that she just had learned about her little child. When we talk about the treatment, therapeutically, treatment during the acute phase of characterized feature of the Takotsubo syndrome is spontaneous resolution in hours or weeks. Therefore, treatment in the acute stage should be supportive and focus on appropriate treatment of complications, but there are no controlled studies or guidelines on how to treat the Takotsubo syndrome. So as a conclusion, the prevalence of stress cardiomyopathy is rare, and the pathophysiology of this disease remains to be defined. The case that we have presented highlights hypovolemia as a complication of any childbirth, as well as the emotional state of a patient in the peripartum may predispose to this type of pathology. This implies that the risk of any event may depend not only on the person's cardiovascular vulnerability following exposure to stress, but also on their mechanism of coping. Thank you.
Thank you, Dr. Karima. That was an excellent presentation. Hope the participants have learned and benefited by sharing your view. Does anyone have a question?
If you have any question, you can ask.
Okay. Anyone have question? Please write it down on the chat box.
Sorry, I didn't hear you.
Said if anyone have question, please write it down on the chat box.
Yes,
Okay.
you can ask on the chat box.
Thank you again, Dr. Karima.
Thank you.
Next speaker, I now welcome Dr. Ismail Azir to give his presentation from University College Hospital, Nigeria. Hello, Dr. Aziz. Can you hear me, Dr. Aziz?
Yes, Dr. Motera, I'll share the video of Dr. Ismail.
Okay. The crisis. Can you hear me?
Yes, Dr. Motera. Can you hear the video?
Please click on share screen in the middle of bottom of your computer screen.
Okay. Is the video visible now?
Your video is the bottom of computer screen. You can click on. You should click on.
Okay.
Turn on. Find it. Okay.
I am Adiruba Aziz.
Now can you
I
hear
would
me?
like to thank the organizers of this program for inviting me to present at this conference.
Can you hear now, Motera?
Yeah.
Okay.
I will be presenting the abstract, treatment response in adult hypertensives attending a secondary healthcare center in southwest Nigeria. The outline is as shown, which include introduction, research objectives, methodology, results, implication of the study to research and clinical practice, and references. There has been an increase in prevalence of hypertension globally, and a trend towards poor control. The prevalence of hypertension was reported to be 44% in Western Europe, 28% in North America. In the US, blood pressure control was achieved in 48% of hypertensives, while in Nigeria, about 24% had their blood pressure control. Despite the development of new drugs and guidelines in management of hypertension, it remains a difficult disease to control. The failure of adherence to prescribed drugs is a major cause of poor blood pressure control. The treatment by modern treatment of hypertension is that most patients regard many drugs to achieve targeted blood pressure levels. The recommendation of the current international guideline, optimization of drug treatment, including the need for prompt initiation of drug treatment, selection of the most appropriate antihypertensive agents, and the use of monotherapy or combination therapy based on the level of blood pressure. Also included is the presence of other cardiovascular risk factors. The predictors of poor blood pressure control, diabetes mellitus, chronic kidney diseases, diabetes nephropathy, cerebrovascular disease, lifestyle medications, efficacious and adequate antihypertensive medication doses, Appropriate drug combinations must be prescribed to have adequate blood pressure control. High prevalence of uncontrolled hypertension has had accompanying morbidities, mortalities, increased burden on the healthcare system, economic loss. This study aims to determine the effect of health education on blood pressure reduction to improve patients' outcome. Methodology. The study was conducted at the State Hospital, a secondary healthcare center in Nigeria. The study was an intervention study of 386 patients with uncontrolled hypertension, followed up for 2 months. Respondents were recruited from April 2015 to May 2015 and followed up till July 2015. A simple random sampling technique with computer-generated random number was used for selection of patients. The study population was composed of adults 18 to 70 years with uncontrolled hypertension. The intervention. During the administration of questionnaires to the respondents, at first contact, patients receive essential information about hypertension, lifestyle modifications, adherence to pharmacotherapy. The study was approved by the Ethical Review Committee of Oyo State Ministry of Health, Ibadan, Nigeria. Informed consents were obtained from eligible patients before administration of questionnaires and examinations. Data was analyzed using SPSS version 20. First criteria was used to analyze the association between categorical variables. The blood pressure reduction was analyzed by peer student t-test. A p-value of less than 0.05 was considered to indicate statistical significance. Now let's have a look at the results of the study. 386 patients who met the criteria for recruitment were interviewed. The mean age of the respondents was 57 years. Figure 1 shows level of adherence of the respondents. About 91% of the patients had good adherence, while about 9% had poor adherence. Figure 2 shows the rate of antihypertensive drug used by the patients. About 40% of the respondents were moderatic, 39% on lodipine, 31% on amlodipine, 23% on lisinopril, atenolol, adrenaline, propranolol have very few patients on them. Figure 3 shows the number of antihypertensive drugs used by the respondents. About 60% of the patients were on one type of drugs. About 45% of them were on 2 types of drugs. 29% were on 3 types of drugs. Those who are taking more than 3 types of drugs were about 10% of the population of the patients. Figure 4 shows distribution of body mass index of the respondents. Only about 3% of the patients are underweight. Normal weight has about 35%. Overweight has 30%, and those who are obese were about 20%. So the population is majorly that of overweight and obese patients. Table 1 shows association of body mass index and the systolic blood pressure. A higher proportion of patients who are overweight and obese had high blood pressure compared with those who are underweight and those who are normal. Table 2 shows the relation between body mass index and diastolic blood pressure, just like the case of systolic blood pressure. A higher proportion of those who are overweight and those who are obese had higher blood pressure compared with the underweight and those who are normal weight. But in this case, the association was statistically significant. Table 3 shows the effect of health education on patients with uncontrolled diastolic blood pressure. There was a significant difference between the mean first diastolic blood pressure and the mean third diastolic blood pressure. Table 4 shows the effect of health education on patients with uncontrolled systolic blood pressure. There was a significant difference between the mean first systolic blood pressure and the mean third systolic blood pressure, just like the case of diastolic blood pressure. So this is showing that after 2 months of follow-up with intervention of health education on the respondents, there was a significant reduction in the blood pressure of the patients. Figure 5 shows that at the beginning of the study, that the patients had uncontrolled systolic blood pressure. But at the end of 2 months, 39% of the patients had their systolic blood pressure control, while 61% had their systolic blood pressure uncontrolled. Figure 6 shows diastolic blood pressure changes at 1 month interval. After 2 months of follow-up, 66% of the patients had their diastolic blood pressure controlled, while 34% of them had their diastolic blood pressure uncontrolled. So those who have the diastolic blood pressure control are higher than those who have the systolic blood pressure control. Table 5 is showing the relationship of blood pressure levels and body mass index. The relation of body mass index with first diastolic blood pressure was positive, weak in strength, and statistically significant. Whereas that of systolic blood pressure was also weak in strength, but not statistically significant. Table 6 shows linear regression for the first diastolic blood pressure on significant variables. As shown in Table 6, for every 1 unit increase in body mass index, there was a statistically significant increase in diastolic blood pressure by about 0.22 units. The predictor of diastolic blood pressure from this table was body mass index. In conclusion, after health education and counseling of the patients at first constant, there was a significant difference between the mean first diastolic blood pressure at first visit and the mean third diastolic blood pressure after 2 months on drugs. Also, there was a significant difference between the mean first systolic blood pressure and the mean third systolic blood pressure. Body mass index was a predictor of diastolic blood pressure. Based on the findings of the study, there is a need to launch a comprehensive approach for educating patients on hypertension, lifestyle modifications, as non-pharmacological treatment are the need for the patient to adhere to their drugs. Limitations of the study and future research. The study was an intervention study, but there was no comparison group and no randomization into groups. It is called before and after study with health education as intervention. Large-scale randomized controlled trial will give better results. The study was hospital-based, making secondary generalization difficult. Although they also serves a very big population. The study was an experimental study, and so causal relationships could be established to some extent.
Okay, thank you, Dr. Aziz. And that was an excellent presentation. Hope the participants have learned and benefited by sharing research book. Does anyone have a question for Dr. Aziz? Nobody have a comment? Okay. As the next speaker, I now welcome to Dr. Jose Morigara to give his presentation from Biostatistics and Epidemiology, Mexico.
Yes, Dr. Motera, I'll share the video of Dr. Jose Morega now.
I'm sorry, Dr. Aziz, you can hear me?
Yes, Motera.
Okay, you can start.
Is the audio, can you hear the audio?
Yeah.
Okay, thank you.
Dr. Morigara. Hello, Doctor. Can you hear me?
Yes, yes, Motera. You can't see the video?
No, unfortunately.
Okay.
Okay, I can't see.
Okay, thank you.
Risks level we would accept of being wrong when rejecting the null hypothesis. He suggested 5%, but without a basis for his decision. Now, more than 70 years later, we are amid an increasing concern about the usefulness and the problems created by the incorrect use of the methodology and interpretation of hypothesis testing. But why do we need statistics? And is it not enough to present the data as it is collected, and what is so about scientific method, statistics, and epidemiology? We will analyze the basic concepts and then center today's presentation on analyzing the recommendations regarding the suggestion to abandon the use of p-values. First of all, without statistics, the amount of data in scientific investigation would be impossible to manage and understand. To make the data manageable, you first classify them to avoid getting lost. Then you apply the basic rules of probability. After classifying the quality of evidence, we proceed to make predictions and thereby make decisions regarding the diagnosis, prognosis, and treatment of patients. So we know that the use of statistics is to cope with variability and the large amount of information that comes out of every clinical investigation. We know that we are not able to study a universe, say, the people with high blood pressure in the world or in my city, and we have to take a sample, which we expect will be representative of the universe it comes from. But no matter how accurately and precisely we try to take that sample, Albert Einstein reminds us that the bias will always be present. In this regard, we hope that the sample will be efficient and the risk will be small if we accept the sample values as representative of the universe they come from. As shown in the Mayo Clinic proceedings, in 10 years' time, up to 62% of the published studies will have their conclusions reverted or inconclusive. There are many causes for some research not standing the test of time, and very often it's the poor quality, as has been mentioned several times by Joy Ioannidis. As Robert Lee Hodges mentions, a big problem is giving too much importance to statistical significance and presenting the data as absolute truths of immediate application, when many are low-quality sponsored studies and the results can have statistical significance but not clinical importance. The phishing of P is the misuse of data analysis to find patterns that can be presented as statistically significant, thus dramatically increasing the risk of false positives. The phishing of P has become a modern sport, stimulated by the lack of methodological knowledge of journal editors and other decision makers about the quality of research studies and the selection of those to be published. This is an example of a result produced by data dredging, showing a correlation between the number of letters in the contest Scripps National Spelling Bees winning word, here in red, and the number of people in the United States killed by venomous spiders, here in black. The correlation is almost perfect, but clearly enough, nobody can claim a cause-effect relation of these parameters. So, association does not mean causality. Chantecler, the rooster in Edmund Rostan's novel, realized that the association was perfect. He sang and the sun rose. So he convinced the hens that his singing was what made the sun rise. But everything collapsed the day he fell asleep, and the hens saw that already the sun had risen. The rules began with Sir Austin Bradford Hill in 1964. They have evolved to the Evans criteria, but the foundations remain the same. Statistical significance refers to the risk of being wrong when rejecting the null hypothesis. When many hypotheses are tested, it's virtually certain that some will be reported to be statistically significant, and almost every data set with any degree of randomness is likely to contain some spurious correlations. Researchers using data mining techniques can easily mislead the readers by the use of these results. Let's review a little more the reason to use inferential statistics. If we were all the same, it would be boring. But knowing one individual would be enough to know all of them. But variability is the norm. So we have to observe the dispersion and calculate central tendency and variance values. That gives us some idea of the group's characteristics. To study variable, we have to define the universe from which we want to know its parameters, which are obviously unknown, and we take a sample. With a probabilistic sample, we calculate some statistics, and with them we try to estimate the parameters' values. Statistical significance refers only to the probability of the sample data correctly reflecting the universe data. As shown in these diagrams, the distribution in the bottom graphic shows a large dispersion, the green line. By increasing the sample size, upper graphic, the dispersion will be reduced and have smaller confidence limits, and many differences, although remaining the same, become statistically significant. Compare the confidence limits of both graphics and the positions of the high tail of the lower values distribution and the low tail of the higher values. In the upper graphic, they are separated, and in the bottom one, they overlap. Although Fisher left open to experimenters the choice of the risk level for the rejection of the null hypothesis, in the following decades, 5% has been the reference to decide on statistical significance. But along that road, it has wrongly been used to decide on the importance, quality, and applicability of the investigation, and often used in a fraudulent way. Remember, p-values do not measure the size of an effect or the importance of an outcome, and by itself does not provide a good measure of the evidence. Most conclusions with p-values slightly below 5% are probably false. If so, the postulated associations and treatment effects do not exist. When studies are repeated in similar or stricter situations, most of the time the results are not reproduced. Even among those statements that are true, a small effect size does not have significance for decision making. There are some authors that warn us about the need to fully understand what statistical significance is. There is a key article published in 1995 where Donald McCloskey reminds us, as I have already tried to show today, that P is a probabilistic calculation of the occurrence of an event. If the results of the sample are an efficient estimator of what happens in the universe, and we can't speak of certainty, In addition to this, in our profession we have to differentiate the statistical significance, p-value, confidence limits, type 1 or alpha risk, from the size of the effect and the clinical importance and applicability of the findings. We should not be interested primarily in the question, how likely are these results if the null hypothesis is true? On the contrary, we should be interested in the question, how big an effect is there? As we saw, statistically significant values can be obtained by taking very large samples, even if the effect is small and without clinical significance. With this in mind, what is the author's reaction in view of the results of an investigation? In this table, we can see that a clinically important difference that reaches a statistical significance, as shown in box A, pleases the researcher, for they facilitate publication. On important differences or effects that do not attain significance should be okay, box D. The annoying important differences that were significant, box C, indicate that too large a sample was obtained, but they are used to push medications and indications beyond the real value. Further, in box B, if a difference was not significant, but the investigators consider it as important, they conclude that the sample was insufficient, even if the sample size was calculated in advance of the investigation, and call for further research with larger samples until one reaches statistical significance. This is a crazy use of the concept. In conclusion, unimportant differences that turn out to be significant are annoying. Important differences that fail statistical confirmation are truly depressing. This schizophrenic nature of the interpretation of significance greatly reduces its value. The concept of statistical significance has to be revised to the basics of what is the definition of solid evidence, as do groups like Cochrane, Appropriate Use, and Clinematics Corner. Defining this, we could proceed to analyze in depth the redefinition of statistical significance. John Ioannidis, whose aims are defined by himself as to improve research methods and practices and to enhance approaches to integrating information and generating reliable evidence, comments on the proposal to lower p-values from 5 in 100 to 5 in 1,000 or even lower, as other sciences like astronomy already do. The following are some proposals to reduce the degree of misinterpretation of p-values and its misuse. The first is to lower the p-value threshold, because it has been observed that with a risk of 5%, many studies are never replicated. It would be of some utility to show the actual value, because to say lower than 0.05 includes many potential values. Focus on effect size, the main objective of the investigation. Show the distribution's confidence limits. A few have gone as far as saying that p-values are useless. But what we have to do is disseminate its proper interpretation. We have to promote the study of science, and in particular biostatistics and clinical epidemiology. The main objective is to assess the size of the effect and analyze the results in depth, including the original values and not only the author's statements. At the same time, we have to show the biases and how some people lie with the statistics. Finally, Bayesian methods are very useful but require a deeper knowledge of statistics and probabilities. Anyhow, its use is increasing, and at least we have to understand its fundamentals. Do we need to be mathematical experts to understand the concepts of probability? Most calculations are done by computers, but we have to know if the chosen statistical method was appropriate and what is the true meaning of the results. We will use the contributions of Sir Isaac Newton, Gottfried Leibniz, and Leonhard Euler, who paved the road to understand calculus. The late German physicist Hans-Peter Dürr, on talking about the paradigm's shift, tells us that the relationships in nature are complex and that the whole is more than the sum of its parts, that we are in a reality ruled by complexity and we can no longer allow any reductionism. Does this scare you? For many doctors, it can be seen as an immense effort to be prepared on issues that are not familiar to us. The goal seems impossible to achieve. Einstein saw more than a century ago that changing a paradigm will be a difficult task. But if the sorcerer bought himself a stethoscope, we too can progress. If you decide to get prepared in science, please accept for some time the loneliness of knowledge and abandon the comfort of being part of the flock.
Thank you, Dr. Borgerga. That's an excellent video presentation. Hope the participants have learned and benefited by sharing research work. Now I welcome to Dr. Alba Regina Cartexpo to give this presentation from Santo Tomé Federal University of Alagoas, Brazil.
Yes, Dr. Motera, I'll now share the video presentation of Alba Regina now.
Thank you.
Good afternoon.
Is it audible, Motera?
Yeah.
Okay, thank you.
Everyone, it's a pleasure to be with you today. First, I would like to thank you, the events organization team. Secondly, I would like to thank you for the invitation to share my research with you. Introduction. Recent reports reveal that more than 200 million surgeries are performed worldwide each year, according to World Health Organization 2019. Despite several global patient safety initiatives over the past decade, adverse events rates for surgical conditions remain unacceptably high. Human error is inevitable, but is more likely to occur under stressful conditions, mental fatigue, or when deviating from conventional procedures. Second Safe Surgery 2020, surgery remains a dangerous undertaking through much of the world. Among the surgeries, cardiac surgery is considered of the most complex. These factors are especially relevant in cardiac surgery, where cases are complex, time-consuming, and integrate more innovative techniques, and can benefit from managing part of the complexity through the use of checklists. It is an intrinsically high risk procedures and a multi-steps process with frequent interruptions to the workflow, making communication a challenge. And as a consequence, there is a great multidisciplinary interest in improving cardiac surgery. So, identifying causes and developing plans to minimize or eliminate adverse events can help establish a system that ensures patient safety. The World Health Organization in 2009 launched a safety checklist that included 3 well-defined steps: before anesthesia induction, sign-in, before the surgical incision, time out, and before leaving the room, sign out. It's that the team checks safety items and identifies possible risk of errors, whose objective is to systematically assist critical safety steps. The safety list is not adapted to address surgical subspecialty problems and risk factors, so the World Health Organization recommends making adjustments from the primitive list. The purpose of the research is identify a checklist for safe cardiac surgery. In the literature based of the following research question: which checklists are available in literature for cardiac surgery? Methodology. The methodology is an integrative review between September and October 2020, consisting of the 6 steps in order to understand the context address. The searching strategy of a primary study were elaborated and they were combined according to each element of the PIC strategy, where P, patient safety, I, checklist, CO, cardiac surgery, according to John and Breeze Institutes. These stages were definition of the research questions, searching selection of primary studies, extraction of data from primary study, critical evaluation of primary study, synthesis of review results, and review a presentation. Before the survey results, I would like to make some provocations through questions. Do you have a reliable surveillance process? Do you know the evidence and do we know how to apply it? And where do we want to go the safety culture? What do you know about it? The research resulted in 8 articles that presented a checklist for cardiac surgery. Quantitatively, there was not expression response in the number of articles. However, a vast health of appropriate items aimed at the surgical safety of cardiac patients can be seen. For the origin of the institutes yes, most were from the United States of America, 50% in relation to the professionals who were part of the instruments. Anesthetists, surgeon, perfusion, nurse, and scrub nurse were included. Lists and in the surgical phase, the most prevalent was timeout. All articles were important in the results, but the main checklist is my review are the ones in bold. The first one is lessons from aviation. Describe the crucial steps involved in cannula insertion for minimal invasive cardiac surgery procedures with 22 sequence checked. There is a checklist that outline cannula insertion steps for minimal invasive cardiac surgery procedures. The second one is checklist and safety in pediatric. Describe a checklist involved for a pediatric cardiac program with check directed to professionals. Maintain the sign, timeout, and sign out phases, with the additions of 2 pre-procedurals phases, the before the procedural surgery and on the day of surgery. The 31 is improved compliance and comprehension of a surgical safety checklist with customized versus standard training, a random trial. The surgical safety checklist consists of 44 items divided into 5 phases, modified locally. Confirmations of need for selective brain perfusion, placement of eyes, of a red and type of primer used, the cardiopulmonary bypass were identified. The 41's briefing and debriefing the cardiac operation room, analysis of impact on theater team, attitudes, and patient safety. It's a checklist with dichotomous answers divided into a general stage process with 4 items, briefing with 11 items, and debriefing with 6 items. At the point, I will talk about the main find of the articles. In this article, we look at important perfusion checking factors, such as amount of heparin and insertion of cannulas. In this article, shows very important check for the cardiac environment, such as valvular size confirmations and antibiotic ready. Echocardiography is available. It's very important for cardiac surgery. In this part, timeout, we can observe important check for the cardiac surgeries, like verifications, positions to minimize risk of the COVID defibrillator, and questions about transplant and special gas needed, confirmation for cannulas by the surgeon, and the question is very important and different in the others articles, does anyone anything they think is unsafe, so it's very important. At the sign-out, we observe standard checks issues as the traditional World Health Organization list. The addition of what did we do well? Consider the team opinion. In this article, particularly, I appreciate that because I bring 5 phases of verifications with emphasis, pre-procedure confirmations, and A, B, C, D. A, on talking over from wards, and B, before anesthesia beginning. C and D talk about before skin incision. Surgeon leads this section, so separated are surgeon leads the sections with perfusionist, nurse, and anesthetic and surgeon. And E, before external closure, it's a little part. This article shows checks they brings in the briefing, a format as efficient as the signal timeout or signal system. The conclusion: it's possible to conclude that the existence of a checklist for safe cardiac surgery with elements and safety informations for the cardiac surgery team contributing to reflections on practice in the context of cardiac surgery. So recommended to use the checklist of this study for patient safety in cardiac surgery as a model for the most diverse local practice. So thank you for guys the opportunity, and see you soon.
Okay, thank you, Dr. Caratexo. And now I would like to invite Dr. Teresa Minero from New University, Mexico. Dr. Minero, can you hear me?
Do you want me, Dr. Birnbaum, to give the talk? I couldn't hear you.
Okay, welcome, Dr. Minero.
Okay. So good afternoon or good morning if you are on this side of the ocean. I need to do screen sharing and host disabled participant screen sharing.
Okay, it's normal, okay.
Okay, share. Okay. So let's start. Do we really need aspirin loading for stemming? And for years, we thought that everyone after an age of 45 or 50 should be on aspirin. Ask your doctor, or at least patient at risk for coronary artery disease should be on aspirin. And most recently, papers have come out showing that actually the damage, the potential risk of bleeding is greater than the potential benefit for primary prevention. And now there is ongoing back and forth guidelines and documents who should be on aspirin for prevention exactly. How do we find patients that are will benefit more from the aspirin than the damage of bleeding, but we are sure that aspirin is an integral part of secondary prevention and for the treatment of acute myocardial infarction. And this is part of the quality assurance criteria that everyone that comes with chest pain to the emergency room will get aspirin within 10 minutes of arrival. But do we really need it? Do you see my screen? Hello? Do you see my screen?
Yeah, doctor.
Okay. So those are the guidelines, American College of Cardiology and the American Heart Association guidelines from 2004, giving class 1, aspirin should be chewed by patients who have not taken aspirin before presentation with STEMI. The initial dose should be 162 to 325 milligram. Although some trials have used enteric-coated aspirin for initial dosing, more rapid buccal absorption occurs with non-enteric-coated aspirin formulation, giving level of evidence A for 162 milligram and level of evidence C for 325 milligram. And the small text says, unlike fibrinolytics agents, there is little evidence for the time-dependent effect of aspirin on early mortality. However, data do support the contention that a chewable aspirin is absorbed more quickly than one swallowed in the early hours after infarction, particularly after opioid therapy. The 2012 European guidelines say that aspirin should preferably be given orally, including chewing, not recommended chewing, to ensure complete inhibition of thromboxane-dependent platelet aggregation, but may be given intravenously in patients who are unable to swallow. And convincing evidence for the effectiveness of aspirin in addition to fibrinolysis was demonstrated by the ISIS-2 trial, in which the benefit of aspirin and streptokinase were seen to be additive. The first dose of 100 to 300 milligrams should be chewed or given intravenously, although at a lower dose range, and a lower dose, 75 to 100 milligrams, given orally daily thereafter. The 2013 ACC-AHA guideline for the management of ST elevation myocardial infarction kind of molded the recommendation, and actually they mentioned that emergency medical dispatcher, the ambulance people, are trained to instruct patients with possible STEMI symptoms to chew non-enteric-coated aspirin, 162 to 325 milligram, unless contraindicated while personnel are en route. This is the only place in the 2013 guideline where chewable aspirin is mentioned. And this is from the table. Aspirin 162 to 325 milligrams should be given before primary PCI. Level of evidence being now, they decrease the level of evidence. And after PCI, aspirin should be continued indefinitely with level of evidence A. And the table, aspirin, 162 for people who are going for primary PCI, 162 to 325 loading dose before procedure, 81 to 325 milligram daily maintenance dose. With those who receive thrombolytic therapy, again, the same dose, 162 to 325 milligram loading dose. Nothing is mentioned on chewable. and 81 to 325 milligram dose indefinitely thereafter. And adjunctive and antiplatelet therapy with fibrinolysis and aspirin and clopidogrel loading for patients below 75 years of age, 75 milligram dose of patient above 75 milligram should be administered to patients with STEMI who receive thrombolytic therapy. Aspirin should be continued indefinitely. Please note again that the chewable part disappeared from those guidelines. The 2017 European Guideline for the Management of Patients with ST elevation says aspirin oral or IV, if unable to swallow, is recommended as soon as possible for all patients without contraindication. Aspirin can be given orally, including chewing or IV, to ensure complete inhibition of thromboxane A2-dependent platelet aggregation. For patients receiving fibrinolytic therapy, the first dose of aspirin should be chewed or given IV, and a low dose given orally thereafter. Again. So all those guidelines point to the ICIS-2 trial. And in the ICIS-2 trial, which was published in 1988, 17,000 patients within 24 hours after the onset of suspected myocardial infarction, not STEMI. At that time, the concept of STEMI versus non-STEMI was not established. Patients were randomized to streptokinase, 1 month of enteric-coated aspirin 162.5 milligram per day, both treatment or no treatment. The primary endpoint was 5-week vascular mortality. Those who allocated to oral aspirin, the dose was given daily for 1 month, starting immediately with the first dose crushed, sucked or chewed for rapid antiplatelet effect. So the original study, the only study that actually looked on outcome of patients with STEMI, gave enteric-coated aspirin that now is no longer recommended. All patients that received aspirin received chewable aspirin. So actually, we don't have separate data to know if this oral chewable loading dose did something. But it became part of the routine and standard of care. And indeed, the study showed that streptokinase was great, aspirin alone was great, and the combination had additive effect. But again, what was the contribution of the oral chewable first dose has not been established. Now, there is this paper that is not mentioned a lot, but it was published in Circulation in 1985, and they looked on what actually the low dose of aspirin is doing. And they claim that low dose of aspirin actually does not cross the liver when we swallow it. And it exerts its antiplatelet effect in the portal circulation, while being absorbed by the gut until it reaches the liver and deacetylated, it acetylates the COX-1 in the platelet and exerts the effect because the platelet continue with the blood flow. While 81 milligram, 75 milligram here probably does not have systemic effect. It is not antipyretic. It doesn't work against pain. Only at higher dose, it treats the systemic circulation. And probably when we give it IV, bypassing the liver or even chewable through the buccal mucosa, we bypass the liver and get systemic effect. And then, since the aspirin is COX inhibitor, non-specific for COX-1 and COX-2, if it is reached systemic level, it can cause COX-2 blockage, and this might have deleterious effects that will go. So here, I don't have more clinical data, but I am now toggling between animal studies and clinical data to show some potential adverse effects of the aspirin loading. So we have shown, this is from 2008, that when we give atorvastatin pretreatment to mice, we reduce infarct size. And here we see in the wild-type mice, atorvastatin for 3 days significantly reduced infarct size. It was not seen in enos knockout mice or in inos knockout mice, suggesting that both enos, inos, and NF-kappa B are essential. Now, well, what is a clinical study showing that statin reduce infarct size? We give all patients with acute coronary syndrome, we gave them high dose of statins, mainly atorvastatin 80 milligram based on the small scale miracle study. But do we have evidence that it reduced infarct size? So in this paper, patients that underwent primary PCI for STEMI within 12 hours after symptom onset were randomized to atorvastatin, 80 milligram, before PCI and 5 days after it, or a control group, 10 milligram daily after PCI. All patients received aspirin 300 milligram and clopidogrel before PCI. So they did cardiac MRI and nothing. Atorvastatin did not reduce infarct size. Myocardial salvage was 37.1 with atorvastatin high dose loading and 46.9 with atorvastatin 10 without the loading. In other studies, the Rosemary study, 185 patients were assigned either to an early high dose of rosuvastatin group or to a conventional low dose rosuvastatin group. Placebo loading and 10 milligram maintenance for 7 days. All patients were treated with aspirin and clopidogrel before primary PCI. Infarct size, no difference. So in contrast to the animal study, and I showed one example of our lab, but there are many studies showing in various animals that statin reduce infarct size, but not in patients. And the difference might be related to aspirin, because in the animal studies, so far, none of the animals received aspirin, while in the clinical studies, all patients receive aspirin loading. So in 2007, we conducted a study looking for the effect of aspirin. So we gave 3 days of atorvastatin pretreatment with and without aspirin, 5, 10, or 20 milligram per kilogram, given intraperitoneally just before reperfusion, at 25 minutes of coronary artery occlusion. We reperfuse for 4 hours and look on infarct size, and we can see now that aspirin alone had no effect on infarct size. Atorvastatin reduced infarct size, and aspirin added to atorvastatin dose-dependently blunt the effect. Interestingly, aspirin, when given at occlusion here, blunted the effect of atorvastatin, but when it was given at reperfusion, not 5 minutes, but at reperfusion, did fail to block. So can it be that the aspirin that we give to all our patients with STEMI blocks the potential effect of statins, and therefore the clinical studies are negative? Another example is ticagrelor. And this is a study from our group in 2014 that 3 days pre-treatment with ticagrelor reduced infarct size. Here we see that it reduced the infarct size. Clopidogrel, despite achieving the same degree of platelet inhibition, had no effect of infarct size. This is CGS. This is an adenosine receptor blocker. It didn't do anything, but ticagrelor with CGS, the protective effect was blocked because the effect of ticagrelor is mediated by adenosine. Now, when we gave aspirin, again, before reperfusion, 5, 10, and 25, dose dependently, we attenuated the effect of ticagrelor. The effect was blocked with SC5815, which is a COX-2 inhibitor, but not by SC560, which is a selective COX-1 inhibitor. So the protective effect of ticagrelor is COX-2 dependent. And when we give aspirin together with the ticagrelor, we eliminate at least the initial loading, the effect of the initial loading dose of ticagrelor. Now, the Plato trial showed that ticagrelor had major effects in patients with acute coronary syndrome. And there was a question why it didn't work in the North America patient. And then there was this question whether this is a low dose of aspirin versus a high dose of aspirin used by the American patient. And the high dose of aspirin blocked the advantage of ticagrelor. And we thought that our model showed some explanation why high dose of aspirin, at least the loading, may affect the outcome. In this trial, they try to see if pre-hospital ticagrelor loading will reduce infarct size or induce the Atlantic trial. So 1,862 patients with ongoing STEMI of less than 6 hours duration were randomized to receive pre-hospital in the ambulance en route to the hospital versus in-hospital treatment with ticagrelor. But all patients received aspirin. And actually, it was a negative trial. Absence of ST segment elevation resolution, pre-hospital, in-hospital. None of the endpoint reached statistically significant, while no effect on mortality, nothing. They claim that the time difference between the pre-hospital and the hospital was only 31 minutes, the median time, which may explain it. But it can be that this is only the effect of aspirin. Now, post-conditioning. This was described in 2002, 2003. The short episode of occlusion reperfusion at the beginning of reperfusion reduced infarct size in animal. It drew a lot of attention, and clinical trials try to imitate it. but all trials of ischemic post-conditioning, at least a large trial that were well conducted, were negative. In the Dynamis-3 ischemic post-conditioning trial, routine post-conditioning, in addition to primary PCI, failed to reduce the primary composite outcome of all-cause death and hospitalization for heart failure, where the post-conditioning may offer cardioprotection in an enriched STEMI population remain unknown. Now, this is another negative study published in European Heart Journal in 2012. Infarct size, 27 with post-conditioning, 22 with control, not statistically significant. Myocardial salvage index yet was positive. Now, we published last year in rats that aspirin given before reperfusion blocked the infarct size limiting effect of post-conditioning. So the rat underwent, here is infarct size as a percentage of the area at risk. Post-conditioning reduced infarct size. Aspirin alone has no effect, but aspirin blocks the effect of post-conditioning. The fourth and the last example is morphine. This is an old study that suggested that morphine in animal reduced infarct size. They also claim that ibuprofen reduced infarct size, but aspirin not. Now we don't like ibuprofen with myocardial infarction because it increases the risk of rupture. But aspirin blocked the protective effect of morphine. This is another paper showing that morphine can reduce infarct size in animals. Yet, in using MRI, morphine does not have effect on infarct size. Myocardial salvage is the same. Myocardial salvage index is the same. Can it be that the aspirin loading blocks the potential effects, protective effect of morphine that has been described in animal study? So there are several clinical questions. The animal models, there is external ligation of the coronary artery, not a thrombus. Do we really need rapid onset antiplatelet drugs? Can this be achieved with other antiplatelet agents? Remember that in the ISIS too, people even didn't get heparin. At that time, you didn't think that you need heparin for after streptokinase. There was no clopidogrel. There was no 2B3A inhibitors. Does aspirin have other unique property besides its antiplatelet effect? Can it be that by using other antiplatelet agents that do not block COX-2, we might be able to benefit from agent procedures that protect against ischemia reperfusion injury, minimize reperfusion injury, and improve prognosis beyond reperfusion? So this is kind of a summary of the finding. If we start with ticagrelor, ticagrelor block ENT1 that leads to reabsorption of adenosine, reuptake from the interstitium, increasing the adenosine level in the interstitium. Statins activate ecto-5 nucleotides that secrete adenosine into the interstitium. The adenosine activates its receptors that with downstream activation of COX-2 and INOS. INOS activate COX-2 by S-nitrosylation. Opioids, again, I show you some suggestion that there is an effect with aspirin or COX-2. Unclear. Might be that this is another pathway. Post-conditioning, well, we blocked it with aspirin, but we don't know if post-conditioning work directly on the COX-2 or activate somehow and increase the adenosine secretion. The role of adenosine was established in the late form of ischemic preconditioning, but actually nobody checked if COX-2 is also involved in the immediate form, the classical form of ischemic preconditioning. So here is a classical picture of a patient with acute myocardial infarction, acute coronary syndrome with oxygen. Those are, we knew for years that everyone with chest pain and acute myocardial infarction should be on oxygen, and these were the guidelines until the 2017 guideline changed it. Oxygen is indicated in patients with hypoxemia. Routine oxygen is not recommended in patients with saturation above 90. So we have changed a lot of the recommendations that we had in the past for treating STEMI. The oxygen, the routine use of lidocaine, and even IV beta blockers. It might be that based on the discrepancy between the animal studies and the clinical studies, it's the time to test the hypothesis that nowadays we can use alternative to aspirin and see if omitting aspirin or replacing it by other drug will result in better outcome, smaller infarct size in patients with ST elevation myocardial infarction. Thank you.
Thank you, Dr. Yochai.
Any questions?
Thank you, Dr. Birnbaum. Can you hear me?
Wake up.
Dr. Birnbaum, thank you. That was an excellent presentation. Hope the participants have learned and benefited by sharing research work. Does anybody have a question? Please write it down on the chat box. Anybody have any comment? Thank you, Dr. Birnbaum. Okay, and the next speaker, I now welcome Dr. Lisa Minero from Lund University, Mexico. Dr. Minero, can you hear me?
Hi, good afternoon. Can you hear me?
Yeah.
I don't know why I can share my screen.
Okay, please click on the bottom of computer screen and share screen.
Okay. Wait a minute.
Okay, no problem.
I can't. I don't know why.
In the bottom of, in the middle of bottom, there are screen share.
Mm-hmm.
Can you find?
No.
Move your mouse at the bottom of your computer screen.
No, I can't. I don't know why.
This icon is disappear when you move your mouse. You can see it. Find it or no?
No.
Oh.
Can you see my screen?
No, unfortunately.
No, I don't know what happened.
Sorry, can give a help?
Dr. Larissa, can you hear me?
Yeah. Yes, I hear
can
you.
you send your PPT to the official email ID so that I'll download it and we
Okay.
will. So Dr. Motera will move on to the next presentation, and after that presentation, Dr. Larissa will be presenting her presentation, and the next presentation will be Dr. Mariana Davis Recher from Brazil.
Okay,
Yes.
thank you. Yeah.
So I now welcome to Dr. Mira Daniela Lubiacano to her presentation for Argentina Society of Cardiology, Argentina.
Hi.
Hi.
1 second, please. You can see my presentation?
Yeah, I can see.
Okay. Okay. One second, please.
Okay.
Espérate que no puedo compartir. Que no lo puedo ver bien. A ver, espérate. Okay. Good afternoon, everybody. I am Daniela Lobianco, physician specialized in internal medicine and cardiology. I work at the Clínicas Hospitals, part of the University of Buenos Aires, the biggest teaching hospital in Argentina. And I also am the elected full member of the Argentine Society of Cardiology, working specifically at the teaching department and secretary of the Clinical and Therapeutic Council. First of all, I'd like to thank the organizer for the invitation and for the opportunity to present our research, and also thank you all for your time. Argentina is located in South America, and according to the last census, we are about 45 million people. The clinical hospitals belong to the University of Buenos Aires. There are 4 Nobel Prize winners who studied and taught at this university, showing an example of the quality of education. Carlos Saavedra Lamas, a lawyer, who received the Nobel Peace Prize in 1936, who discovered the role of the hypophysis anterior lobe in the regulation of carbohydrate metabolism and on the pathogenesis of diabetes. Because of this, he got the Nobel Prize in Medicine and Physiology in 1947. He also brought the first electrocardiograph in 1912 to be used in the School of Medicine. Leloir, Nobel Prize in Chemistry in 1950 for describing sugar nucleotides for the first time and their role in the formation of carbohydrates. Milstein, Nobel Prize in Medicine in 1984 for his research in monoclonal antibodies. I also like to mention Dr. René Favaloro and his contribution to cardiovascular surgery with myocardial revascularization. Epidemiologically speaking, in the last risk factor surveys, we learned that 66% of the population is overweight or obese, 45% has hypertension, 29% has dyslipidemia, 22% are smoker, 12% ischias has diabetic. Compared to previous years, only the number of smokers has been reduced, but hypertension and dyslipidemia remain stable. In Argentina, cardiovascular condition and tumors are the most relevant non-transmissible disease, being the cause of 15% of deaths registered in 2019, and 28.45% correspond to cardiovascular condition, similar to the world cardiovascular deaths rate, 31%. According to statistics, Argentina in 2020 had 404 physicians and 35 nurses for every 10,000 inhabitants. The total amount of practicing physicians, is almost 2,1700, and they are unevenly distributed across the country. Today, there are 51 schools of medicine in the country, generating 5,000 new physicians every year. Cardiology specialties are trained mostly through a system of residencies and hospital practice. Setting a bit of context, the National System of Health Residencies was created in 1969, and in 1979, it was established that residencies were considered a full-time commitment. In 1919, it was agreed that a physician was considered a specialist if he or she had a certificate of passing their complete residency practice, no less than 3 years, issued by an accredited public or private institution. A residency is considered the best strategy to train specialty physicians, although it's not the only one. The residence system started in Argentina in 1944, thanks to Dr. Tiburcio Padilla, who created the first medical residency at the Clínicas Hospital in the University of Buenos Aires. There are around 200 cardiology residencies in the country. In 2006, the National System of Residency Certification was created, with the objective of standardizing the evaluation criteria, so all residence programs offer equal training opportunities, applying standard according to the specialties, but respecting also the local characteristics. The Ministry of Health invited scientific organizations and universities to take part as assessment bodies. Oh, sorry. Vení que se me trabó la compu. 1 second, please.
Okay.
Vení, vení. Que se me trabó la compu. La presentación. No, para ver. Como le digo que tengo que minimizar un poquito. Dejo de compartir y vuelvo a compartir. Solamente give me a second. Give me a second, please.
Okay, no problem.
Deja compartir. Ah, por esto. Compartir cuando la fecha no la función. You can see my presentation?
Yeah, I can.
Yeah, again, okay. No se me pasa, che. No pasa. No, que no, el anterior necesito aceptar que quiero compartir la pantalla, pero no me deja. Para, lo voy a hacer desde acá. Ok. Voy a seguir de acá. Sí. The Argentine Society of Cardiology joined an enhancement body in 2009, and since then it worked closely with the Ministry of Health and Social Development, evaluating residencies to improve and standardizing the training of new cardiologists. To be certified and recognized residencies by the Ministry of Health, the assessment should include the following. Pedagogical approach, include residency program with transversal contents regarding professional practice and collective health, such as patient safety across all specialties. Activity program development, include rotation, number and variety of medical conditions, number of on-call duties, access to interconsultation, theory practice integration activities, research development, and assessment system for resident performance. Material and human resources include attending physician to supervise the program and the equipment for the specialty. First of all, the residency director should send a note to the Ministry of Health formally requesting the certification. The Argentine Society of Cardiology sends for requesting information about available resource, resident procedures, and the program. Them and the evaluating team made up of 2 recognized cardiologists is sent to the institution to visit the establishment and assess the area as a teaching center for cardiologists. After renewing the documentation, the establishment and meeting the residents, the evaluating team report back about the strong and weak point of the programs. If a center is renewing the certification, the area of improvement had been pointed out in the previous assessment will be reviewed again. The final report will rank the sentence and suggest how long it will be valid. Once the Ministry of Health receives the evaluating team report, is defined the category for centers. There are 3 categories: A, valid for 4 or 5 years, B, valid for 3 years, and C, valid for 2 years. Finally, the ministry gives the appropriate suggestion for changes and improvements. The aim of this research has been to present the result of the evaluation process and the certification of the cardiology residency from 2010 to 2017. The result compares strong and weak points together with recommendations for improvement. Material and methodology. The study includes documents and files available at the teaching area at the Argentine Society of Cardiology. the Ministry of Health website and the official gazette. The reviewed fieldwork, resident programs, the SAC evaluating team reports, and the Ministry of Health resolution published in the official gazette from 2010 to 2017. The report provided by the evaluating team showed the strong and weak point of the program, and the corresponding recommendation for improvement were published in the official gazette. It was possible to identify the frequency of appearance of the different variables in relation to the total of cases. Coincidences and discrepancies between SAC report and the Ministry of Health suggestions were established and measured. The cardiologist part for the evaluating team highlighted the following strengths: 45.7% proper monitoring of resident performance, 43.2% opportunities to practice on high complexity procedures, 40.5% suitable profile of attending, 40.5% existing training, while the theory systemic approach, and 15.1% positive resident feedback about the program. The evaluating team also mentioned the following weaknesses: the 2.4% short period of time dedicated to outpatient, 29.7% low production of scientific research, 27% poor systematization in resident performance assessment, 21.6% few attending supervising residents, and 18.9% lead rest after on-call duties. The 4 residencies applying for certification renewal comply with the Ministry of Health recommendation, getting the A category of 4 years. Some of the main changes were the introduction of transversal content, generating research projects, and reduction in work hours. There was 86% of agreement between the Ministry of Health assessment and the evaluating team report. It's important to highlight that the A category is not granted unless the residency hours post on CalDatis, resting hours, and constant supervision. Analyzing the ministry resolution and the frequency and suggestions for improvement, we noticed that 17.3% suggest adding transversal content to the program, 58% suggest distributing on CalDatis fairly and implementing after work rest time, 40.5% assessment resident performance systematically, 37.8% signing agreement with the other institution for external work shift, 32.4% suggest that resident learn practice and procedures and ask for the attending signature, 29.7% adjusting work shift to current labor law, 29.7% encouraging scientific research and resident participation. Discussion. The point of agreement between the Ministry of Health assessment and the evaluating team report are the importance of supervision, the need of systematizing the resident performance assessment, the need of increasing scientific research, encouraging resident participation. The main difference we note is that adding transversal content in a common recommendation that arises in the Ministry of Health resolution. However, it was not present in the evaluating team report in the first certification, but it was included later in the certification renewal. Another difference we found is that getting positive feedback from residents is very important for the Ministry of Health, but only 35% of the evaluating team report mentions it. Another source of information about the situation of cardiology residencies in Argentina are the surveys organized by the National Council of Cardiology Residents. The last survey was made in 2017, and it was and answered by 390 residents and 19 provinces. The results were the following: 54.2% of the interviewees were doing their residence in a private institution. 53% present being satisfied with the opportunity offered in the programs. Only 58% of the cardiology residents did at least of a year of internal medicine. 50% reported not having continuous supervision. More than 50% claimed to be attending medical school while doing the residence. Almost 60% said they work more than 70 hours per week, and 60% reported to be working in non-medical shops. Pollster didn't find big differences between public and private institutions, and these results match the strengths and weaknesses highlighted by the Ministry of Health and the evaluating team. In my personal experience, after having finished 2 residencies in public institutions, 4 years in internal medicine and 4 years in cardiology at the clinical hospital I mentioned at the beginning, the administrative and nursing work fill up most of my time, especially during the first years. There was no after work rest program at that time, and I go to work up 100 hours per week. There have been other studies using specific tools to assess the educational environment in cardiology residencies in a hospital context. In one of these studies, there were 148 residents in 31 hospitals in Buenos Aires, 71 residents in public hospitals, and 75 in private hospitals. According to the answers, there were no difference between public and private hospitals in terms of tolerance levels, no gender or race discrimination, supervision, high academic standards, little feedback, and lack of study time. There were significant differences in the learning environment in private institutions regarding having good supervision, better facilities, including resting areas for on-call physicians. However, subjectivity in resident performance by the evaluating team has an impact on the indicators. All in all, we arrive to the following point. The conditions highlighted by the Ministry of Health were not considered in most of the evaluating team report. The Ministry of Health tend to focus on the residents and the resident well-being and patient safety. However, the evaluating team took care more about records, availability, and supervision resident activities. Despite such differences, there are extensive coincidences in the category rating and certification year suggested by the SAEC and the Ministry of Health. Therefore, we consider it to be a complementary approach, and they both share in the intention of improvement the resident training programs. To overcome the subjective issue, the SAC has created a text list to systematize the observation of the teaching center. Muchas gracias. Thank you.
Dr. Murata. That was an excellent presentation. Hope the participants have learned by sharing research work. Does anyone have a question? Nobody have a comment? Okay, thank you, Dr. Murata. And next one, I now welcome Dr. Mariana Diabes Recte Andreda to give her presentation from Universidad de São Jose, Brazil. Welcome, Dr. Marianne. I can't.
Good afternoon. Can you?
Yeah.
Okay, sounds good. Just let me know. Can you see my screen?
Yeah.
Okay. So let's go. So I'm coming here today to present a case.
Sorry, I can't
Okay.
see your slide.
Oh, you cannot. Let me see.
Please click on share screen in the middle of bottom of computer screen.
What about now?
Yeah.
Okay, sounds good. So thank you for all to come here today and to share my presentation with you all. So I'm coming here today to talk about a case of multifactorial atrial tachycardia as a typical presentation of cardiac myeloid sarcoma. So we had a patient, a 52-year-old male, that was admitted to the emergency department of our hospital due to palpitations. He was on the third day following a new chemotherapy scheme with venetoclax and Vidasa. His past medical history, which is very important right here, it's that he had primary essential thrombocytosis, which was diagnosed in 2010, which progressed to myelofibrosis and acute myeloid leukemia. The patient was treated with various chemotherapy schemes and received an allogeneic bone marrow transplant in 2020, complicated by acute graft versus host disease. Talking about his acute graft versus host disease, he had predominantly skin presentation and liver dysfunction. So in the emergency department, his physical examination showed a bilateral flank abdominal mass and tachycardia. His EKG shows multifocal atrial tachycardia. His laboratory investigation demonstrated a severe neutropenia and thrombocytopenia. And he performed a transthoracic echocardiogram that showed a right atrial mass. Initially, he was treated with amiodarone and admitted to cardiac intensive care unit. In the cardiac care unit, when me and Dr. Giuliani received the patient, we asked for a cardiac magnetic MRI, which revealed an infiltration mass in both atrial walls, more in the right atrial, which had isosignal intensity in T1 and high intensity in T2, and weak enhancement by contrast, suggesting a tumor mass. And then after a lot of discussion, we thought about granulocytic sarcoma. So granulocytic sarcoma, also called myeloid sarcoma or chloroma, is an extramedullary tumor of immature granulocytic cells. It is a rare entity and most accompanied by acute myeloid leukemia, which was the case. A first mention of the pathology was found in 1811 by Burns, and later called chloroma on account of its typical green appearance caused by the presence of enzyme myeloperoxidase, MPO, in the granules of the immature granulocytic precursor. It may develop concurrently with mentioned primary disease or be the initial manifestation of the relapse in an already treated case, especially after allogenic bone marrow transplantation, which was our case. So in the literature, according to the article published by Meyer in 2019 on the Radiology and Oncology journal, the commonly affected body regions were visceral soft tissue, followed by cutis, and it can be swelling or changing coloration of the cutis, bones, and central nerve system. The cardiac presentation in this article was 2.3% of cases, 2 cases. And in addition, both cardiac cases was identified incidentally by imaging. So what usually we see on literature is that cardiac manifestation usually is incidentally. So we got a very rare case, which the cardiac manifestation was the multiatrial tachycardia. So clinically, myeloid sarcoma was apparent in half of the cases with swelling and skin discoloration, as I said before, which underlined the importance of a good physical examination in oncologic patients. Furthermore, in 29.2 neurological and organ dysfunction were found, and 21.5% pain was the main symptom. Notably, 11.3% of MS cases was detected incidentally by imaging study. Eventually, due to increasing performance of imaging study in oncologic patients, we hypothesized that the amount of the incidentally detected MS will increase. Therefore, the radiologists, oncologists, and cardiologists need to be aware of the intensity of MS. There were another review by Lam K, which he followed up 12,000 patients in 20 years. He found in their autopsy that the cardiac involvement by leukemia was 40%. And the majority of this remain undiagnosed in living individuals. Furthermore, the most common symptomatic was pericarditis. So again, our case was very rare in literature. So to conclude, our case, which was a cardiac arrhythmia, multifocal atrial tachycardia, was the first clinical manifestation of this patient. And GS was presumptive due to cardiac intracavitary mass found on the echo on the ED. Also, after we asked for MRI, which has the same presentation of GS tumor. Moreover, after cardioversion, the sinus rhythm that the patient was, the PR interval of the patient before the cardioversion was 380 due to the cardiac conduction infiltration that we saw in the MRI, explaining the first-degree heart block that this patient had. So, and after all of that, if you remember, in the physical examination, we saw right here that the patient, he had bilateral flank abdominal mass. This mass was we sent this to biopsy, and we got the conclusion of granulocytic sarcoma. Anyway, so due to its rare incidence and the lacking of data in our literature, we are here exposing this case. So the main purpose of this report is really to highlight the different forms of cardiac presentation of GS and to contribute to medical literature as GS remain a clinical challenge. Thank you.
Thank you, Dr. Mariano. That was an excellent presentation. Hope the participants have learned and benefited by sharing research work. Does anybody have a question? Nobody have comments? Okay, thank you, Dr. Mariana. And now I welcome again Dr. Ismail Aziz from University College Hospital, Nigeria. Dr. Aziz, can you hear me? Unfortunately, his internet made an error, and now again we are back to hear his speech. Can you hear me?
Yes, I can hear you, but I'm trying to upload my presentation.
Okay.
I'm sorry, it's just coming up.
Okay, okay.
It's coming up. Good afternoon. I hope you are hearing me.
Yeah, I can.
Okay. Good afternoon, everyone. I hope we are enjoying the cardiology conference starting today in Paris. I would like to appreciate the organizers of this conference for inviting me to present our work titled Treatment Response in Adult Hypertension Attending a Secondary Healthcare Center in Southwestern Nigeria. My name is Abdirogba Abdulaziz, as I've mentioned. So the outline of the presentation is as shown: introduction, research objectives, methodology, resource, implication of the study to research and clinical practice, and references. By way of introduction, there has been an increase in prevalence of hypertension globally and the trend towards poor control. The prevalence of hypertension was pointed to be 44% in Western Europe and 28% in North America. In the United States of America, blood pressure control was achieved in 48% of hypertensives, whereas in Nigeria, it was around 24% control. Despite the development of new drugs and guidelines in management of hypertension, it remains a difficult disease to control. The failure of adherence to prescribed drugs is a major cause of poor blood pressure control. The truth about modern treatment of hypertension is that most patients require many drugs to achieve targeted blood pressure levels. The recommendation of current international guidelines for authorization of drug treatment includes the need for prompt initiation of drug treatment, selection of the most appropriate hypertensive agents, and the use of monotherapy or combination therapy, depending on the blood pressure levels. Also included is the presence of other cardiovascular risk factors. The predictors of blood pressure control were recorded to be diabetes mellitus, chronic kidney disease, diabetes nephropathy, and cerebrovascular disease. Lifestyle modifications, efficacious and adequate antihypertensive medication doses, appropriate drug combinations must be prescribed to have adequate blood pressure control. High prevalence of uncontrolled hypertension has had accompanying morbidities, mortalities, increased burden on the healthcare system, and economic loss. This study aims to determine the effect of health education on blood pressure reduction to improve patients' outcome. The methodology. The study was conducted at the State Hospital or a secondary healthcare center in southwestern Nigeria. The study was an intervention study, health education, and counseling in the intervention of 386 patients with uncontrolled hypertension who were followed up for about 2 months. Respondents were recruited from April 2015 to May 2015 and followed up until July 2015. A simple random technique with computer-generated random number was used for selection of the patients. The study population was composed of adults 18 years to 70 years with uncontrolled hypertension. The intervention was health education. During the administration of questionnaires to respondents at first contact, patients received essential information about the nature of hypertension, morbidities, mortalities associated with hypertension, lifestyle modifications as part of treatment, and adherence to treatment, drugs for treatment of hypertension. The study was approved by the Ethical Review Committee of Oyo State Ministry of Health in Nigeria. Informed consents were obtained from eligible patients before administration of questionnaires and examinations. The data was analyzed using SPSS software version 20. Chi-square tests and correlation analysis were used to analyze the variables. The blood pressure reduction were analyzed by peer student test. A p-value of 0.05 or less was considered to indicate statistical significance. Now let's go to the results of the study. 386 patients who met the criteria for recruitment were interviewed. The mean age of the respondents was 57 years. Figure 1 shows distribution of adherence levels of the respondents. About 9% of the patients had poor adherence. So majority of the patients had good adherence, 91%. Figure 2 shows distribution of the antihypertensive drug used by the patients. About 40% of the patients were on mudretic. About 39% on amlodipine. About 31% on nifedipine. Lasinopi had about 23% patients on them. Drugs like losartan, atenolol, idralazine, and propranolol had very few patients on them. Figure 3 shows distribution of number of antihypertensive drugs used by the patients. About 60% of the patients use one type of drug. 45% of the patients use 2 types of drugs. And 29% of the patients use 3 types of drugs. More than 3 types of drugs were used by 10% of the respondents. Figure 4 shows distribution of body mass index of the respondents. About 3% of the respondents were underweight. About 35% of them had normal weight. Majority of the patients are either overweight or obese. Table 1 shows association of body mass index with group systolic blood pressure. That is a chi-square test. It shows that the majority of a high proportion of patients who were overweight and obese had high blood pressure compared with those who are underweight and those who had normal weight. So the same thing with table 2, which shows the distribution of association of body mass index with diastolic blood pressure. A higher proportion of those patients who are overweight and obese had higher blood pressure compared with those who are underweight and who had normal weight. Now, this is the student PRT test that shows the effect of health education of patients follow up for 2 months. So after 2 months of follow-up, there was a significant difference between the mean first diastolic blood pressure and the mean third diastolic blood pressure. So the same thing goes with the systolic blood pressure. After following up the patient for 2 months and then giving them health education and counseling them, there was a significant difference between the mean first systolic blood pressure and the mean third systolic blood pressure. Now, this is figure 5 that shows systolic blood pressure changes at 1 month interval. At the beginning, the patient were uncontrolled, that they have uncontrolled hypertension. After 2 months, about 39% had their systolic blood pressure control, and a large percentage, 61%, had their systolic blood pressure uncontrolled. So only 39% had their blood pressure control, 61% did not have their blood pressure control. So the percentage of uncontrolled blood pressure was very high, even after 2 months of follow-up. But in the case of diastolic blood pressure, about 66% of them had their diastolic blood pressure control, and about 34% had their diastolic blood pressure uncontrolled. So those who had diastolic blood pressure control were more than those who had systolic blood pressure control. Well, this might be due to the fact that the population was essentially an adult population. Table 5 shows the relationship of blood pressure levels and body mass index. That is a correlation. The association of body mass index with first diastolic blood pressure was positive, weak in strength, but statistically significant. This is showing the linear regression that shows that for every 1 unit increase in body mass index, there was a statistically significant increase in diastolic blood pressure by about 0.22 units. So the diastolic blood pressure, the body mass index is a predictor of diastolic blood pressure. And these have been recorded or reported in some other studies. In conclusion, after health education and counseling of the patient at first contact, there was a significant difference between the mean first diastolic blood pressure at first visit and mean third diastolic blood pressure after 2 months of drugs. The same thing goes with the systolic blood pressure. There was a significant difference between the mean first systolic blood pressure and the mean third systolic blood pressure. The body mass index was found to be a predictor of diastolic blood pressure. So based on the findings of this study, there's a need to launch a comprehensive approach of educating patients on hypertension, lifestyle modifications as non-pharmacological treatment, and the need for the patient to adhere to their drugs. So counseling and health promotion are very important management of patients. Limitations of the study and future research. This study was an intervention study. It's called before and after study. Some call it pre-experimental study. But there was no comparison group and no randomization into groups. So large-scale randomized control trial would be expected to give better results. The study was also hospital-based, making secondary generalization difficult. Although the hospital serves a very big population. However, the study was an experimental study with health education as the intervention. So causal relationship could be established to some extent. Thank you for listening.
Thank you, Dr. Aziz. That was an excellent presentation. Anybody have questions? Okay. Thank you, Dr. Aziz. And the next one, I welcome again Dr. Larissa Minero to give her presentation from Lulu University, Mexico.
Hi, can you hear me?
Yeah, I can.
Okay. I'll try again. I'm sorry.
No problem. It's okay.
Can you see my screen now?
Yeah.
Okay. Now? Can you see it?
Yeah, I can.
Perfect. Wait a minute, please. Okay. Hello, everybody. Good afternoon. Thank you very much for the presentation and the invitation to this event. I'm very happy and grateful for the opportunity to present this work, and I really hope you really like it. Well, the title of this work is a novel non-invasive integral imaging assessment in atrial fibrillation by cardiac tomography. These are the authors who participate in this study. This was a multidisciplinary group that includes
hemodynamics, cardiologists, and imaging specialists. Well, this study took place in Mexico country. Well, what do we know about atrial fibrillation? We know that it is the most common arrhythmia in adults. It affects 1 to 2% of general population. We know that it increased 5 times the incidence of cardiovascular disease. And also it is responsible for 50 to 20% of all cerebral thromboembolic events. About the left atrial appendage, it is known that it is located above the left atrium, which forms a big part of the left posterior face of the heart. And it is known that it is the main thrombogenic focus in patients with atrial fibrillation. In atrial fibrillation, what happened? Well, the atrial rate is so fast that it doesn't allow adequate atrial contraction, decreasing the blood that passes to the ventricular cavity, and it creates blood stasis at the level of the left atrial appendage, as we can see in this image. This blood stasis start to create thrombus formation at the level of the left atrial appendage. It is the main risk factor for creating embolic events later. The left atrial appendage is so important in the pathophysiology for the embolic events that there are also some therapies for the prevention of embolic events that decide the occlusion of this little part of the left atrial. That is the occlusion of this structure. Well, about this, there are some articles like we can see here. How important is this? Well, we can see in this AHA statistical update that the main causes of death worldwide are cardiovascular disease. And in this group, the strokes represent a big part of them. So here's the importance to study the causes of these thromboembolic events because it is an important disease worldwide. Well, the appendage has different parts, as we can see in this image. It has an ostium, a neck, and a lower region. There are 4 types of morphology according to the to some authors, and this is mainly based on his shape. We can see in this picture the 4 groups of left atrial appendage that exist. We can see that the most common is the chicken wing type in 48%, following by cactus in 30%, windsock 19%, and in the last place, the cauliflower type, just in the 3% of the general population. Well, what is the importance to study the morphology of the left atrial appendage? There are some studies we can see here. In fact, there are few studies because there's not too much information about it online that have related the morphology of the left atrial appendage and the presence of stroke events. So as we can see in this study from the Argentine Neurologic Society, we can identify that non-chicken wing types of appendage. There are also related with strokes versus chicken wing types that is not related. There's another study that we can observe that not chicken wing type are the most associated with stroke. Some authors like this study, Bossi et al., they have demonstrated in anatomical models in vitro that left atrial morphology is related to blood flow hemodynamics and suggests that the lower the flow velocity, the higher the possibility of thrombotic episodes. So these specialists found that the cauliflower morphology has the lowest flow velocity and the windsock type is related to a higher flow velocity. About the cardiac tomography, it's important to mention some of the things that can evaluate current advances in cardiac multi-detector computed tomography, allow high spatial and temporal resolution with three-dimensional images that enable non-invasive quantitative and multiparametric assessment of the left atrial appendage. So there are already comparative studies between transesophageal echocardiogram and computed tomography in the identification of intracavitary thrombo, where the cardiac tomography, showing better diagnosis occurrence. So it is a very new thing that is also in some studies, but the tomography hasn't been comparison with two meds in patients with atrial fibrillation. In this image, we can observe some parameters that allow us to evaluate the cardiac tomography, such as the index volume of the left atrial in this image. Also, we can quantify the flow velocity of the left atrial, which has before thought that it could only be measured by echocardiography. Now, it also has been described as Japanese method that allow us to perform it. The multi-detector tomography allow us to quantify multiple variables of atrial function. We can see the presence, like in this image, the presence of thrombus in the left atrial appendage, and also a new parameters like in this this image, like the epicardial fat. We can conclude with this that the cardiac tomography is currently a very useful imaging and a study in the assessment of the multiple variables in patients with atrial fibrillation. So it's very important and very useful. Well, the objective of this study was to analyze the clinical utility and feasibility of the multi-detector cardiac tomography in multiparametric imaging assessment in atrial fibrillation patients. About the method, this was a prospective case control study in 84 subjects, which 54 atrial fibrillation subjects and 30 was healthy subjects. Left atrial appendage morphology was classified as I mentioned before in cactus, chicken wing, windsock, and cauliflower type. Intracardiac thrombus, stroke history, and Chapbacks scale were compared to cardiac multi-detector tomography atrial imaging assessment. Well, in this table, we can see the clinical characteristics that we evaluate in this study. We can see some of the things that we evaluate in these patients, such as the age, gender, body mass index, the present or not of some diseases like diabetes, dyslipidemia, smoking, alcoholism, history of a previous thromboembolic event, and also the treatment in these patients and the Chapbacks score. In this other table, we can see the clinical characteristics that we evaluate in this study. We can see about some things that we evaluate by tomography, like just like calcium score, left atrial volume maximum, left atrial volume minimum, the ejection fraction of the left atrial appendage, also the presence or not the thrombo in the morphology, also the left atrial fraction ejection. As we can see, the tomography allows to quantify a lot of things that I'm going to explain later. In this box, we can see the representation of some results of the study We can see in box A the comparison of the flow velocity of the left atrial appendage between the patients with atrial fibrillation and the control group. You can clearly observe the big difference in red color. There are the atrial fibrillation patients. As you can see, there were lower than the control group. And on the other hand, in box B, we can observe the flow velocity of the left atrial appendage in patients with atrial fibrillation and the presence of thrombus in the left atrial appendage. We can see a marked difference in between patients with the presence of thrombus, where the flow velocity is much lower than the patients that doesn't have thrombus. In relation to patients without presence of thrombus, where the levels are, well, more dispersed. Well, here in those tables, we can observe in table A, in box A, the differences between the index volume of the atrial fibrillation of the atrial and the left atrial appendage in the presence of thrombus. We can see that the relationship of the index volume of the left atrial in relation to the presence of thrombus, it was higher than patients that doesn't have thrombus. In this graphic, we can see in box A, the presence of thrombus in the left atrial appendage, where, well, we can see here that the most common type of atrial appendage morphology in patients was the cauliflower versus patient that doesn't have thrombus was the cactus type. In box B, we can observe the relationship between the morphology of the left atrial appendage and the presence of the thrombus in the left atrial appendage. And we can see that it was related to a high risk in the CHA2DS2-VASc score. It was, or we can conclude that the cauliflower type is related to the presence of a thrombus in the left atrial appendage and a high risk of CHA2DS2-VASc score. In this image, we can observe some pictures that we obtained through the cardiac tomography. We can see some pictures from our patients. In image A, we can observe the index volume of the left atrial. We can see the great size of this atrial, like we see here. A typical thing of these patients that have atrial fibrillation. In box B, we can observe the quantified flow velocity in this patient. Like I said before, it was a new method that we discovered in a Japanese study, and we want to try to quantify this by this method. We can see the differences when there's the presence of a thrombus versus where there isn't. And we can observe a thrombus in this image C. We can see the presence of thrombus. It covers more than 50% of the cavity in a 3D dimension. And finally, on the right part of this slide, we can observe in numbers the 4 types of morphology of the left atrial appendage in a reconstructed in 3D. Number 1, we can find the cauliflower type. Number 2, the windsock. Number 3, the cactus type. And number 4, the chicken wing type. How we can observe multi-detector cardiac tomography allow us to quantify diverse variables that help us as a doctor to decide the treatment with each patient. In conclusion, this parametric assessment offers more information to the doctor for optimize the treatment and allows to re-stratify the score in patients with atrial fibrillation. we can modify the quality of life and prognosis of these patients. So, well, in this last slide, I leave you the article that you can find online. And I appreciate your attention. Thank you very much.
Thank you, Dr. Larissa. That was an
Thank
excellent
you.
presentation. Does anybody have questions? Please write it down on the chat box. Okay. Nobody have a comment? Thank you, Dr. Larissa. And now,
thank you.
I welcome Dr. Mariana Yaves Aresh de Andrés to give her presentation from Casa de Cida São Jose, Brazil. Welcome again.
Is anyone can listen?
Yeah.
Okay. Let me just share. Is it okay?
Yeah.
Okay. So once again, I want to thank you for giving me this opportunity for sharing all those information worldwide. And for this presentation in specific, I'm here on behalf of a cardiologist colleague, Giuliani Raffel. Those three patients are from her, but due to clinical issues, she could not be here with us today. So I'm going to share her presentation of his bundle pacing and left bundle branch pacing, a physiologic stimulation. So we all know that the pacemaker syndrome is a complex of symptoms consisting of heart failure, near fainting, sensation of pulsation in the neck or abdomen, cough, which develop or are aggravated after cardiac pacing. Objectively, a fall in systolic blood pressure is observed in the majority of cases, and also canal wave in the neck vein, signs of heart failure, retrograde arterial activation, and possibly canal wave in the central venous pressure. The condition is most probably caused by a lack of atrioventricular synchrony with resultant distension of the atria, which will result in a reflex-mediated decrease and defective increase in the total peripheral resistance, and thus a fall in systolic blood pressure. Treatment will consist of establishing normal atrioventricular synchrony, and this is where we are. So her abstract was about 3 patients that she put his bundle pacing instead of the ventricular pacing. So we know that the cardiac pacing in the treatment for patients with severe bradycardia or AV blocks. It is also known that 20% of the patient requiring more than 40% ventricular pacing may develop pacemaker syndrome, mainly in those with structural disease. In order to reduce the synchrony that we said that was the most important thing to develop the pacemaker syndrome, the implantation of the ventricular electrode in the his bundle and left bundle branch emerged as an alternative for physiologic stimulation and improvement of the desynchronism with narrowing the QRS. It also known that physiologic stimulation can be an alternative to resynchronization with improvement in cardiac function by improving synchronism. In this work, we are presenting 2 cases of successful his-bundle electrode implantation, maintains of a narrow QRS similar to physiological, and 1 electrode in the left bundle branch with significant QRS reduction and significant improvement in ejection fraction, with normalization of the left ventricular function 7 days after the implantation. The main of this work is to present 3 successful cases of physiological stimulation and show that this method is safe, fast, and beneficial to the patient when performed by an experienced team. So I'm going to show the follow-up of her patients. So one of the 3 patients had a left ventricle ejection fraction less than 40% at the implant. And then this patient has an improvement of more than 50% of LVEF in the follow-up of 7 days. Another good thing is all 3 patients had an improvement in New York Heart Association functional status. And also all the QRS were narrow at the presentation, and the paced QRS remained narrow and stable during the follow-up for 1 month. So here we have a basal EKG from one of those 3 patients. And here we have the pace QRS, the base EKG. So in this one, the QRS has 95 milliseconds, which again, we all know that the QRS remained narrow after the use of the electrode pacing. So for the conclusion, as a direct consequence of increasing adoption of his bundle pacing, there is a need for more widespread awareness of EKG analysis and specific programming requirements relative to this therapy. We know that the system configuration leading its unusual program settings, and this can be confused to a lot of cardiologists. So there is no doubt that we all are going to adapt this technology to meet the new challenge that we have in programming the his bundle pacing and left bundle branch pacing. So in the meantime, while the technology is developing better for this situation, we need to familiarize ourselves with HBP programming to ensure safe and effective therapy for our patients. Thank you.
Okay, thank you, Dr. Mariana. That was an excellent presentation. All the participants have learned and benefited by sharing research work. Does anybody have a question? Please write it down on the chat box. Nobody have comment? Okay, thank you, Dr. Mariana. Now the session is over. I deeply congratulate each and every speaker of the event for delivering your excellent research work. We hope all would have had a great time in this event. My heartfelt thanks to all the speakers and attendees who made this event a success. Presence for taking time from your busy schedule to be the speaker at our webinar Heart 2022. We hope that you will want to be involved in our conference next year, and we once again thank you for your valuable contribution to make this event successful. Also, I would like to take this opportunity to announce the upcoming series of cardiology conference, the second international conference on cardiology in November 10 to 11, 22 at Paris, France. Once again, we extend our sincere gratitude to all, and we would wish you all the best for your future endeavors. Thank you. Enjoy your day.
Thank you.